I kindly request all the delegates to please be seated. Good morning, ladies and gentlemen. I'm Dr. Lavita Pereira.
And I am Paromita Behera.
And on behalf of AIG Hospitals, it's our distinct pleasure to welcome you all to the AIG Cancer Summit 2026 at AIG Hospitals, Hyderabad. A welcome note for a cancer summit might express the excitement and honor of hosting the event and the importance of collaboration and innovation in the fight against cancer. It also highlights the latest trends and challenges in oncology and the goal of improving patient care and reducing the global cancer burden. The AIG Cancer Summit 2026 focuses on the latest advances in the treatment of lung, breast cancer, sarcoma, and cancer genetics, covering the novel therapeutic strategies and emerging technologies that are shaping the future of cancer care. Beyond the scientific sessions, the Cancer Summit promises a platform for networking and collaboration. Thank you for being part of this summit. A kind note for all the keynote speakers. It is to kindly request you all to strictly adhere to the time in view of the packed schedule of this summit. The mic would fall silent and the screen would go blank post the scheduled time. Without further ado, let's start the first session of the day. I call upon our eminent speaker, Dr. Akhil Santosh, to take us through our first topic, Molecular Testing 101.
Do it here. Good morning, everyone. At the outset, I would like to thank Vamshi sir and team AIG for inviting me to speak today. So the topic given to me is Molecular Testing 101. So I thought I'll deal into basically non-EGFR entities, since we already have a talk by Dr. Prabhat on EGFR. So let's get directly into it. So first I'll be dealing with the basics in molecular diagnostics with respect to ALK mutation. So as we all know, the most common rearrangement in ALK is your EML4 gene, which accounts for around 6.7% of cases. And ALK incidence, if you actually see the non-smokers, it's up to around 15 to 20%. And the most characteristic feature is that the ALK mutations are most commonly found in SNR and signet ring cell types. And you must also be aware that apart from EML4, there are other rare fusions like your KIF5B, TGF, and your KLC fusions. And the gold standard is IHC. So, which clone is the most commonly used for the ALK detection? It is your D5F3. It has the highest sensitivity and specificity. What are the main issues related to ALK IHC? The reasons for your false negative issues are as you can see that in case of excessive signet ring cells or intracytoplasmic mucin staining, they can be false negatives, and false positives can occur because of your false uptake in your alveolar macrophages and other nerve cells and ganglion cells. And in case of your KIF5B fusions, there may be a dot-like positivity which may be interpreted as negative. And again, the problem with IHC is that it cannot provide your details of your other fusion partners. And FISH, as you all know, FISH is an alternative to IHC. There can be issues with regards to your time to fixation, your type of fixation, and the type of fixative used. And another important thing to be kept in mind is that your strong decalcifying agents that you use may lead to failure of probe hybridization. So, in essence, FISH is a good alternative to IHC. But as you all know, the gold standard for detection of ALK is still your NGS. So what are the advantages with NGS? With NGS, what you can actually see that you can even get to know your ALK variants. So what are the significance of ALK variants? So as you all know, there are mainly 5 types of ALK variants with different implications on prognosis. For example, your variant 1 has a good prognosis compared to your variant 3 and your variant 5. And additionally, your NGS can help in detection of kinase domain resistance mutations, which can help in deciding your further management. So this is a paper which was presented by Dr. Ullas Batra sir and colleagues from RGCI. So they compared basically different modalities for ALK detection, your IHC versus FISH versus NGS. And they found that there was good concordance to the tune of around 85 to 90% between these 3 modalities. So they came to the conclusion that even though NGS offers a better throughput and visualization, your IHC still remains your quintessential method for detection of ALK IHCs. So this is, as I alluded to before, there are 5 different variants with different prognosis. Your most common is your variant 1, which is E13A20, which is a good prognosis compared to your variant 3, and variant 3 has a moderate sensitivity to ALK inhibitors, and variant 5 has a very poor sensitivity. And they do not respond at all to ALK inhibitors. So this is a excerpt I taken from the latest CROWN trial, which was presented in the JCO, the 5-year update. So in that, they've compared basically lorlatinib versus your first generation crizotinib. So they found that patients with poor prognosis factors like your variant 3 and variant 5 and presence of co-mutations like TP53, they have lesser PFS and an OS with lorlatinib compared to, even though it's more than crizotinib, the absolute numbers are lesser with lorlatinib. So again, this is your resistance kinase domain mutations. You can see that lorlatinib is active against almost all resistance mutations. So coming to ROS1, ROS1, as you all know, is an orphan receptor. It does not have a ligand. The gene is on chromosome 6q. The most common partner is your CD74, which accounts for around 65% of cases. And your non-NSCLC cases where the ROS1 fusion is there, the most common partner is your GOPC. So that is not relevant to us. And what are the characteristic features of your CD74 altered ROS fusions? So they have a predilection for CNS metastasis and have a high incidence of venous thromboembolism. Again, IHC, if it is D5F3 in ALK variants, it is D4, D6 in ROS. But again, the issues are that the cytoplasmic cutoffs are not standardized and reactivity may be influenced by tissue fixation. And there can be variable ROS1 expression in your other type 2 pneumocytes and alveolar macrophages. So again, all the IHC positive cases have to be confirmed by a FISH. Again, FISH, better than IHC, but it's still currently not your gold standard. And they can be false positives because of non-functional gene fusions and false negatives because of, as I mentioned before, there are the GOPC fusions. So they can have small intrachromosomal rearrangements which may not be picked by your FISH. So again, RT-PCR, the main problem is that there are only a limited number of primer sets. So this is the $1,000,000 question. So what NGS you want to do for your confirming your ROS fusions, whether it is a DNA or the RNA. So the main issue with the DNA is that this is a very important point because ROS1 is a large gene with a dispersed structure of fusion breakpoints and complex intronic rearrangements, which may not be picked up well with a DNA NGS. And again, not every rearrangement picked up by DNA NGS may lead to an actionable alteration which can be targeted. So coming to metexon 14 skipping, so it is around 3 to 4% in incidence. Common in, it is also seen in squamous and in sarcomatoid carcinomas, and it is mutually exclusive with other alterations except for your KRAS G12 alterations. So there are different types of alterations in MET, your overexpression, your amplification, and your metexon 14 skipping. For overexpression, IHC is good enough, but it does not have any therapeutic significance. And for your MET amplification, the current standard of care is, for diagnostics, it is your DNA NGS. So only if you, first you do a DNA NGS and you detect a MET amplification, and only if it is borderline positive or negative, then you confirm it with a FISH. And so coming to metexon 14, so there can be 3 results. One, you have a positive, and one is, and in case of negative or unknown fusions, you should always confirm a metexon 14 alteration with an RNA NGS. So why is that? So why is RNA NGS preferred for a metexon 14 skipping? So this is again a very important point because there can be a lot of cryptic splice altering mutations in your deep intronic regions flanking the exon 14. So which may be difficult, which is difficult to pick up with the help of a DNA NGS. So the good thing with RNA NGS is that you directly get evidence of the mRNA transcript lacking the exon 14. So that is more specific. So So that there can be two situations if you are considering a MET amplified NSCLC. So one case is where there is a de novo MET amplified NSCLC, and in the other case where MET amplification can occur as a resistance mechanism to your EGFR TKIs. So the cutoffs in fish, they are different for both. So if you have a de novo case, the main cutoff for the gene copy number is more than 5, and if you have your post EGFR TKI mutation, the cutoffs are usually more than 10, as evidenced in the Tatton, Orchard, and the Savannah trials. So this is again one a very important paper that I recently come across. So do you actually take action if you find a MET exon 14 skipping alteration, or you can go ahead with your standard chemoimmunotherapy? So this paper has shown that so in the extremes of PD-L1 levels, like your PD-L1 level more than 70 to 80%, you get a better PFS if you start off with the chemoimmunotherapy compared to your MET exon 14 skipping. And the reverse is also true. So if you have a PD-L1 score of less than 50%, you get a better PFS with your capmatinib and tepotinib upfront. So again, as I discussed before, MET IHC as of now does not have a big role, but recently there was a paper in JCO. So they have developed a new ADC which targets the c-MET. So here the confirmation is with the help of an IHC. So if there is IHC positivity in more than 50% of the cells, so you can try telisotuzumab vedotin. This is basically in your EGFR wild type NSCLC progressing after your initial therapy. It has around 40% responses and 8 to 9 months of PFS. So as of now, this is the only evidence we have for targeting of MET IHC. So coming to RET, again, incidence is around 1 to 2%. Similar to ALK, it's seen in minimal no smoking history, and around 20% CNS diagnosis at diagnosis, and up to 50% in the course of time. Most common alteration is your KIF5B, followed by your CCD6, and there may be other rare fusions also. And TP53 mutations are common in around 20%. So again, there are different methods of identification. Your IHC has a very low sensitivity and specificity. Currently, the gold standard is NGS, preferably an RNA NGS because RET is a fusion, and DNA can have its own issues, as I had mentioned before. And coming to HER2, as you all know, has got different types of alterations. The most common is your HER2 mutations, and among the HER2 mutations, the most common is your exon 20 insertions. And the other alterations can be your overexpression and amplification. And among the exon 20 insertion, the most common is your 4 amino acid insertions. That is your tyrosine, valine, methionine, and arginine, your YVMA insertion between codon 775 and 776. So this is the most common type of exon 20 insertion that you see in your NGS reports. So around 20 to 30% can have SNVs or point mutations in your exon 8 and exon 19. And so what are the other issues with the HER2 NSCLC? So it can have brain mets up to around 50%. So if you actually see your HER2 mutations, they are most common in your women, young non-smokers, and the reverse is true with HER2 amplifications. And HER2 amplifications are mainly seen in males and smokers. And again, there is currently no therapeutic significance for HER2 amplification and overexpression. So all the current, the drugs that we commonly use, your TKIs, your TDXD and your TDM1s, they are all active in your HER2 mutations, and responses to these agents with HER2 amplification is very poor. So as you all know, for your HER2 exon 20 insertions, your DNA NGS is currently your standard method for diagnosis. They have very poor responses to your chemoimmunotherapy. And currently, we have 2 molecules, 2 TKIs for targeting your exon 20 insertions. One is cevabertinib, which was evaluated in the SOHO 01 trial, and your zongertinib in the BEAMION 01 trial. Pretty much similar responses, around 60 to 70% response rates, around 9 to 10 months of PFS. So this was a recent paper which came out in JTO recent. So here what they have shown is that, as I told you before, TDXD has got a role for HER2 mutations in your Destiny Lung 01 and Destiny Lung 02 trials. So here they have evaluated TDXD in case of HER2 overexpressors. So basically your IHC 1+ and 2+ and FISH negative. So they have seen that TDXD still has got a role in these cases with a tune of responses of around 40% and your PFS of around 5 to 6 months. So even with your IHC positive, if HER2 positive cases, if you're out of other options, you may try TDXD. And HER2 IHC positive, so it's a very wide number between around 10 to 30%, unlike your HER2 mutants, which accounts for around 2 to 3%. And coming to BRAF, as you all know, V600E is the most common alteration, more prevalent in females. And with your non-V600E, it's more common in males. And it has a proclivity for CNS mets. This is something that which you are all aware of. There are 3 types of mutations. Your class 1 is your classical V600E, and class 2 is your non-V600E, and class 3 is your dead variants. Basically, it is RAS dependent, and your BRAF exists in monomers. So this is a beautiful paper which I have seen in JCU Precision Oncology recently. So as we all know, only the class 1 alterations can be targeted. So in case of your DET kinases, in your class 3 alterations, so they have seen that they may still be dependent on EGFR signaling, and you can still try your conventional EGFR inhibitors in your class 3 alterations. So there exists still an importance for your NGS testing with respect to BRAF alterations. So you can target non-class 1 alterations also. So IHC is a good screening test, but only for your V600E alterations. We use the VE1 clone. The sensitivity is around 80%. And NGS, it is still the gold standard because, as I told you, it can detect all classes of alterations, requires very little tumor tissue, and it can also detect your co-occurring alterations. So this is another beautiful paper which recently came out in Lancet Oncology. So again, what to do if you get a BRAF V600 report? So you need to like wait. Can you go ahead with your chemoimmuno, or you can directly go ahead with your dabrafenib, trametinib, or your encorafenib, binimetinib. So this paper has shown that your chemo IO has got better responses if you're targeting males over the age of 70, non-smokers, brain mets, and high PD-L1. So in those cases, you can go ahead with chemoimmuno, and you can reserve your BRAF inhibitors for your other variants. I'll just finish in 1 minute. So coming to NTRK, as you all know, NTRK is very rare, up to 0.2% in incidence. IHC is a good screening test, but again, it does not discriminate between your wild type and your NTRK actual variants. So you actually need the help of your RNA NGS. And this is my last alteration. This is NRG1. This is a new kid on the block. Recently reported to be clinically actionable. The incidence is less than 0.5%, seen most commonly in mucinous varieties of lung and in CA pancreas. The most common, the variant is your CD74 altered NRG1. And basically what is NRG? It contains an EGF domain which binds to HER3 and HER4 and activates your PIK3 AKT pathway. So basically, IHC is a good screening test, but you can detect only your ERBB3 IHC, which is currently not well in use. So the gold standard is still an RNA NGS. NRG1, as I told you, is targetable. We currently have 2 drugs in the pipeline. One is seribantumab, and the other is zenocutuzumab. Similar responses to tune of around 40% with a PFS of around 8 to 10 months. Yeah. Thank you. If there are any questions, I'll be happy to take them.
Thank you, Dr. Akhil. We have time for maybe one question. Okay, so we'll move on to the next session. Paromita, you can take over.
Thank you, sir, for this comprehension. I now call upon our next speaker, Dr. Balu Nair, to speak on the topic role of AI in detection of early lung lesions.
Yeah, very good morning to all of you here, and thanks Sujana for having me over here to talk to you about this. So just to let you know about me, I've been in CMC for the last 22 years, and I work as a radiation oncologist, and I also part of a lab which works on, current focus is on AI in health. We do research as well as we deploy AI solutions on ground for efficiency as well as better patient care. And I also have some clinical trials which we can discuss if anybody is interested. So in the next 15 minutes, I would be talking to you about the role of AI in oncology in general and with a focus on lung cancer, and also, if time permits, a bit about our work at CMC. So the promise of AI in healthcare, for me at this point, I would see it can improve a lot of gaps that we have when we have large patients in larger settings, in improving the quality especially, as well as to focus on personalized medicine. And if we look at the role of AI in oncology, I would classify it as 2 aspects. One is automation, that is do things more efficiently than humans. That is most of the workflow that we have. I'm sure in the next few years you would see AI coming in and improving you as a better clinician, giving better quality output and more efficient output. The other is things that humans cannot do. That is where the AI can come in. Better prediction of what happens to your patients with the data that is in front of you, and also to help you to adapt therapy based on what happens. Kind of an assistant to you, which would help you to deliver at a much higher level. Okay, so now in the lung cancer pathway, if you see from preclinical stage to the treatment and follow-up, there are multiple ways with which AI is introduced. That can be in screening, that can be in imaging, pathology, in creating prediction models, assisting in treatment, or in terms of surveillance after therapy. But let me just go into detail of certain aspects of this. One, I've been asked to talk about early lesions and how AI works it in that setting, and that is what is specifically here. That is nodule detection, volume tracking, all these things. So if you look at early detection in lung cancer, in our setting, I would classify it as two. One is a normal population where you do screening and try to identify early cancers, which is important, and we have low-dose CT for that. And then there is the diagnosed malignancy, which is very relevant for all of us, where we have indeterminate nodules and we are left to think what to do for this patient, because most often biopsies are not easy. And also to detect metastasis early within the lung. So these are two scenarios when I look at early nodule detection in lung. So in the normal population at this point, we know that AI tools are as good as humans and more efficient in actually determining what is negative. That is, if you have a set of 100 chest X-rays, the AI is more efficient in telling you what is a normal X-ray. And once you have such a robust tool, then the human focus can actually go into the abnormal ones. So that's the efficiency gain that we are going to get in normal. But in India, these models are probably trained abroad also. If you see, NHS has actually adopted X-ray reporting using AI. But in India, a specific challenge is the presence of high prevalence of tuberculosis, which we all know, and similar to other countries. So in that case, we need another level of AI, that is nodule characterization, and that is now there. This is another solution called ClearRead, which actually characterizes and gives you more about these nodules, so that you can make an inference and a choice regarding each patient. So that's the next level. And it has also proven that in the setting of high prevalent TB, in those countries also, this kind of solutions have actually been successful. And if you see, this was last year, the news clip, the government of Goa has announced that they are partnering with Cure AI for early TB diagnosis. So it's not only cancer, early TB diagnosis using their models. Again, when we come back to cancer patients, the problem is the indeterminate nodules, and there are several things, several situations where we are unable to make a decision because there are nodules. We say, okay, let's do a scan after 2 months or 3 months. These are various scenarios that can happen, and the AI can actually predict between a slow-growing and a fast-growing nodule. This is a Cure AI model, which you can see that the model can do a tracking of nodules in serial X-rays and tell you whether it's malignant or not. The human has to sit and actually measure these things and give a qualitative report, but then this is more of quantitative reporting and more objective. So this is the future that we are going to see in terms of early nodule detection. And in terms of metastasis detection, we have this model which says that it is much more efficient than human eye to actually detect early lung metastasis in oncology settings. So this is this is in terms of early nodules, but let me look at the other pathways in lung cancer. In terms of diagnosis and staging, you may know about the radiomics, where we use quantitative imaging to actually predict or classify lung tumors. If you have a CT scan of a patient and you know that it is adenocarcinoma or squamous cell carcinoma from the CT scan much earlier, then much earlier in the pathway you are able to introduce therapy. Similarly, with when you look at it in pathology reporting, even before staining and NGS, you may be able to classify and tell you that it is adeno or squamous, or even the mutations can be predicted. The same with cytological images, and this is another one is exciting, that is the heat map of pleural effusion in various scenarios, various etiology. You are able to detect whether it is malignant or non-malignant situations. So these are all on the bench side at this point, but you would see solutions coming forward. More importantly, there is workflow optimization, autonomous reporting, as you may be aware, and that is there in place. NHS has adopted it. Some of you would have tried QRAI models which have been deployed in India, which is very good. I mean, it actually predicts what is a normal as normal. Only thing is sensitivity is very high and you will end up detecting a lot of nodules. This is a workflow which shows that which all touch points in radiology reporting or workflow that AI is going to make a change, and obviously everywhere there is presence of AI. And this is a workflow integration chart. You can see 3 levels at which people have integrated AI in the radiology workflow. One of the things is a backup reporting, that you have a radiologist and you have an AI reporting, so radiologist is more, his report is getting more validated by the background AI. Another is a supportive role, and a fully integrated role is shown below. In terms of treatment, this is more, again, relevant for all of you. A human brain can actually handle around 20 parameters to make a prediction or a choice. So when it goes beyond that, and we just heard the previous speaker that you have so many mutations to deal with, how do you make a choice as to what is good for the patient? How will his survival be when I adopt a therapy? And that's what AI models can help you to predict. Sorry. Predict the Kaplan-Meier of a patient, and also to interpret your NGS and choose the right patient for right drug for the patient. Another exciting field is where we are developing synthetic images. You don't have to do PET-CT for all patients. Glucose uptake is a very linear function, and PET is based on that, and you can actually generate PET images from CT scans, and that is something which is exciting and is coming up. When we talk about models, you can see this column actually tells about the accuracy of a model, but I wish to warn you, a model becoming very, very accurate like this, the interpretability is going to be low, because it may not fit to the right patient that you are trying to predict. So the accuracy of the model will reduce the generalizability, and somewhere around 70% is where all our models are touching at the time of implementation. So that's a warning. And this is something which came out 3 days back from the Government of India, which is very good. That Government of India has brought out that in terms of cancer screening and adoption of AI in cancer, we come under the CDSCO classification of class C, moderate to high risk, which is a good regulatory setting, and people will have to license it before bringing it to the clinic. So what can we do so that AI works for Indian patients? Not everyone is set to build AI models. Some of you may, but everyone will need good data at your center to actually, if you are adopting a model in your center for patient care, you need to validate it with your local database. So you need to start collecting good data. Good data means not only the scan, but the good metadata that goes around it, as well as outcome data. So for example, in the lung nodule, you need good biopsy. And if you have 10 set of patients with good CT, good metadata, and the biopsy saying it is cancer, it is TB, it is indeterminate, and that's a good data set. And if all of us pool in this good data set, that is something very good for a model to be built on. So that's what we need to do, and that's where we have to collaborate and contribute. Next 1 or 2 minutes, I will just quickly run through what we do. QRAI lab was a quantitative imaging radiomics analysis AI lab was started in 2020. And we have multiple projects. We started with head and neck cancer. We work with lung cancer. Now we are also moving on to non-malignant situations, and as well as workflow efficiency within the institution and outside. These are 2 major projects that we have done with lung cancer: is pneumonitis prediction as well as automatic segmentation. Or AI-assisted target delineations is actually helping us ease out the workflow. We have a model which we have deployed in our setting within Eclipse workflow by ourselves, which actually reduces the time for whole body segmentation from 4 days to half an hour. So you see how much human time is actually saved, which can be taken front, and they can spend more time with the patients. So Argos is a multi-institutional, all over the world setting where we have a model for lung cancer segmentation. We have used this know-how to actually do it for head and neck cancer. Now head and neck cancer auto segmentation is also available with us as a model. This is something which we did with pneumonitis prediction. So in radiation oncology, we have daily CT imaging while we do lung cancer radiotherapy. And when we do that, we are actually, with this model which we built, we are able to predict pneumonitis as early as 3 weeks into the radiotherapy. So how does that help us? That early prediction is actually helping us to select that patient whom we have to probably modify the plan, make sure that more of lung is paired, or even start steroids early so that you can avert a clinical pneumonitis. So all these relevant predictions can actually have clinical relevance to each patients that we treat. So this is one model we were excited about. Then we did benchmarking of AI models. There are multiple AI models for nodule detection, and we did a benchmarking study to see which is right. And finally, we ended up finding out that composite models is the future, where it's not only about single model, and multiple models can work together and give you a much more accurate segmentation. This is something which we did last year to deploy an AI model that I said that we have a auto segmentation model which is open source, which we fine-tuned for the data set from CMC, and we are now able to push our images from our Eclipse workstation to a virtual computer, which the AI model will contour, and then it will come back and come back into the Eclipse in half an hour. Which means that in head and neck cancer, we take around 4 hours to actually finish normal structure contouring. This is something which is available in 30 minutes. And in a large center like ours, where we have 250 patients on the couch, this is actually saving a lot of human hours. And that is actually bringing, we did a survey of what are you going to use these extra hours for. And most of them may be personal time learning, because these are all junior doctors who are spending their time. And most often what I wish is that they get to spend more time with patients. Radiation oncologists being behind the computers than radiation oncologists being at front, in front of the patient, discussing and listening to them. And that's the future that AI promises for us. So this is another pet project which I'm excited about to bring forward to you in 2026. This is AI and language technology. You've seen AI chat GPT and a lot of LLMs. There are translation models. There is a model called Bhashini, which is MeitY and Government of India has brought out for language translation for Indian languages. We have fine-tuned that for healthcare data, and we have Bhashini Health, and we have used that to create solutions. And one of the first solutions that we have is the Bandhu Care, which actually helps patients to engage with the clinical team on an app on multiple languages. So the clinical team just need to upload the documents only in English, and the patient can actually converse in 9 Indian languages as of now, scalable to 36. The second layer of it is that we can actually use the AI agent to fill up prompt forms for you, the quality of life forms. The AI agent will have a conversation with the patient and just fill it up. You just have to upload that in English and link to the calendar. We are still fine-tuning the development, and by probably mid-2026, this app should be available for most people. This is at TRL level 5 at this point. And all of our AI modeling has been under the principle of fair use, that is findable, accessible, interoperable, and reusable, which is a standard for the world for AI development. And there are several barriers to adoption. I think the time is not enough for me to elaborate on that, but if you wish to engage with me on this, I'd be happy. I'll be here till noon, and would be happy to discuss with you on this. We also focus on education. Every 2 years, we have a national conference on AI in health and data. We also have started PhD program with the University of Maastricht at CMC, and also we have a professional development program for clinicians and healthcare workers in liaison with IIT-M and Maastricht University. These are our footprints and our collaborators. Thank you for listening to me.
Thank you so much, Dr. Balu. Amazing work in AI, and it's great to know that we're actually applying it, and we're still not just in the phase of exploring it. One quick question.
Yeah, thank you, Dr. Balu, for the interesting talk. Just one simple question. Like, I'm a pulmonologist. I work in AIG Hospitals. We are at the receiving end. We see patients, and a lot of incidental nodules are detected. We see day in, day out. CTPA was done. One central nodule, solid nodule, in a patient who is non-smoker. I mean, what I want to know from you is that which is the best AI model which can tell us that this nodule has got a very high probability for cancer, where I need to do biopsy, I don't have to wait. Or it could tell, it could be non-malignant, I can wait. Like there are other models we have used, like if you see BTS guidelines, there are Brock's model, Herder model, which tells if it is more than 70% risk or between 20 to 70%, then you have to biopsy it. But with the present evidence, which AI is the best one? So
I don't have a list of AI models, but I work with Cure AI, and it does give you a good assistive report on these nodules. Let me tell you that all these models will work on the principle of human in the loop. So it is only an assisted technology where, as you said, it will give you a number, and it is ultimately on you to actually make that particular decision, and the model is not going to decide it for you. But as we go forward, and as the human gives feedback to these models, and that's why I said if you have good data sets with a biopsy report outside along with it, which is a gold standard, these models will learn further. And as future goes by, at this point, I don't think any of this can work independently. The best use of AI solutions at this point, I would limit it to getting a negative report.
Thank you. That's great.
Thank you.
Thank you, Dr. Balu. We'll move on to the next
Thank you.
session, and we can engage with Dr. Balu outside. I'm sure lots of us have questions on this topic.
Thank you, sir, for the wonderful insight. We now proceed ahead towards our next topic, surgery of the lung in the era of neoadjuvant therapies. And for the presentation, I would like to call our speaker, Dr. Saravanan Rajamanikam, onto the dais.
Thanks, Dr. Sridhar. Thanks, Vamshi. Very good to be among friends. So we are also, like Dr. Balu mentioned, we deployed a QRA in our hospital, and to answer your question, sir, we are actually working with them to actually wait exactly. We have a lot of data on these nodules. We operate a lot of lung cancer and small nodule lung cancer, and we are waiting with them. So basically, you need to give the feedback like you mentioned. And the problem is they are engineers and we are doctors. And this is a mathematical problem. So they ask me, doctor, how much weightage you want me to give for this feature, which is speculation. So I have to tell them 80%, 81%, 82%. This is the kind of information they want from us. So it's not easy, and it's a work in progress. I believe that in 2 or 3 years, an Indian base, because like the foreign data which is there may not apply to us. We have too many nodules in us, so we'll have to create our own. So I'll be talking about surgery in the era of chemo-IO targeted treatments, readings from Tangma Hospital, Namakkal and Kanpur. So why chemo-IO? We are very much convinced. Our medical oncologists actually try to push it on to us, but we actually over the period of years, we found that the patients that we actually see, T3, N1, N2 disease, stage 3B disease for lung cancer, actually benefit with neoadjuvant chemoimmunotherapy. So although there is no trial has actually proven overall survival benefit because the numbers have been quite low. There's a recent meta-analysis which has suggested there's a trend towards overall survival improvement, but event-free survival, which is an important factor in a cancer like lung cancer, there's a huge difference. And as days go by, we can see that the blue is chemo-immuno versus the green, which is just chemo alone. There's a huge difference in survival, event-free survival. And not only that, if you look at pathological complete response, we were part of almost all of the practice-changing clinical trials, Checkmate, 816, the NeoStar, the AGN. We were part of all those trials, and believe me that the complete response rates in our patients, they have unblinded us now, is almost more than 60% in our population. Because we had more of, it was early days, probably 6 years back, we had more of squamous in our group. Complete response in squamous was almost 67%. So if you think that, and many of them continue to have a durable response to this kind of treatment. So, which had us convinced that we are very pro neoadjuvant chemo-IO, especially for certain histologies and certain situations, because of the PAT-CR rates that we were seeing. And there was a recent meta-analysis which also, took individual patient data from all of these clinical trials and showed a huge benefit hazard ratio of 0.36 for patients with the chemo-immuno if you give it in the neoadjuvant setting. And not only that, as surgeons, we have to realize that there's a lot of recurrence which happens when we operate patients up front. And today, if you see chemoradiation followed by immunotherapy for patients with unresectable disease as determined by surgeons is having a 5-year survival of almost 45%, which we have never seen before. So if as surgeons we have to, reach up to that level and, cross over that recurrence rate of more than 50%, which is seen in even stage 2 cancers, I think we'll have to do better, and chemo-immuno will help us in that regard. So as of now, most of the European, the American, the Japanese guidelines have approved, based on these pivotal studies on the application of neoadjuvant strategies in cancers. You can look across the board. Nowadays, it's PD-L1 all comers in almost all settings. And depending on the type of drug and the type of chemotherapy that they use, there was a difference. But nowadays, I get fed up because every day a new. In fact, we have 6 clinical trials running, and I just don't know which chemotherapy and which immunotherapy is happening. And I'm geared up for whatever is coming. So I tell my medical oncologist, you don't tell me which drug you're giving, just tell me chemo-immuno. I'll be ready for what I need to do. So what does this mean for the surgeon? It's extremely difficult surgery when you're starting off. Believe me, there's a lot of scarring, adhesions, fibrosis, bleeding. More conversions, that was our initial experience, but we've gotten better. We've started having patients who are on chemoimmunotherapy developing, pneumonitis, and we had to manage them. You're taking a curative patient technically and then putting on to the neoadjuvant strategy, and then you're stuck whether you have to not operate these patients, how to manage these people. And then the complications like empyema, because these patients have an intense immunological response, and along with the chemotherapy, they have a huge T cell load, and even a small infection can flare up in them. You have empyemas, bronchopleural fistulas, and mortalities with this. Luckily, we didn't have the worst of those. We've had a few empyemas, but none as significant as that has been reported in literature. Just to give you an example, for those surgeons in the crowd, this is a patient who received post chemo immunotherapy, and I'm trying to find the inferior pulmonary vein, which is step 1 of surgery when you want to do a right lobe lobectomy. The simplest surgery for lung cancer is a right lobe lobectomy, and usually the inferior pulmonary vein, I take hardly 5 minutes to identify and transect. And here it took me 1 hour to reach the inferior pulmonary vein. It's extremely difficult. So as a medical oncologist, when you ask a surgeon, boss, operate kar do, you should actually feel for them, because it's not. Now you see, after 1 hour of dissecting in that region, now I identify what I see is a glimpse of the inferior pulmonary vein, and there is a intense response around the vein, and you can see over here, to find the vein I have to actually peel it or peel off that. This patient had nodal disease on the inferior pulmonary vein, and actually this tissue was sent for frozen section. It turned out to be negative, and on histopathology it had dense inflammatory lymphocytes and no tumor cells in this location. So good for the patient, but extremely difficult for the surgeon to operate. In our initial days, you can see how this is. Again, another chemoimmuno patient, torrential bleeding, we have to go for conversion. And luckily, I would say that, we've converted only 1 patient in our series of around 32 patients that we have performed. So this is what it means. It's not easier surgery just because your response is very good. It's very difficult surgery. What do we as surgeons need to do to get better? As our experience grows, we get better. Same situation happens 4 cases down the line, and now we are in a better position to understand. Now you can see, I kept the lung on the bleeding, and I went for a coffee, waited for 10 minutes. It already seals because of the inflammation. The coagulation is also very good. And then I put a bulldog, which is a clamp, vascular clamp for those non-surgeons here. And then I cut along the pulmonary artery, and then I suture it back. So you need to adapt and get better at doing surgery. And for me, when we were already doing only early cancers, surgery was easy and I was getting bored. And this was like a new lease of life for me as a surgeon, because life started getting excited now. So you can see over here, we are now using a clamp, and then this patient required a sleeve resection. I'll talk about that later. So there's been a lot of talk on difficulty in surgery. The first report of post-immunosurgery was reported by the Sloan Kettering group. Although they had a 95% R0 resection, 70% of the patients had an open surgery, and only 4 patients out of the group of 22 patients had VATS, out of which they converted 1 in 4 of them, and 65% of the surgery, they deemed that the surgery was difficult. And in fact, for those surgeons who don't know, there is a difficulty scoring that you have to report when you're doing post-chemo immuno. And if you are doing any of those clinical trials and the current clinical trials which are coming, you have to report the difficulty of surgical staging by one of these scores. So there was a recent meta-analysis which was published just this month, and you can see over here that the difficulty in surgery, although it is present, good surgeons can achieve in high volume centers 98% resection, only 15% conversions to open surgery for those starting off with minimal access, and only a mean delay of 28 days, which is almost similar to the chemo delays that you see in neogen setting. And now, as you can see now, most of the surgeons who were not even thinking of doing a post-chemo immuno case by minimal access, that is by either VATS or by robotics, are now venturing into it. Earlier, everyone used to do open, even I did the same, but now we've all moved on to minimal invasive. And operative times are also, you can see along all the trials, as experience grows, it becomes almost similar to what we see in the normal situation. So how do we adapt? And I believe that this is very important. because after seeing the benefits and the survival advantage of doing minimal access surgery in lung cancer, it's very difficult to do an open surgery for a patient who is curative. And I believe that robotics is going to change the way. More and more surgeons are going to take this up to do more difficult cases because it's easy for the surgeon, there's better instrumentation. You can manage your complications with robotics compared to VATS. I can manage the complication VATS, but if you see a core surgeon, they may not have the same competency that, that is required. And for them, robotics is required. And there's less conversions. You can see the type of surgery that we can do here. This patient was planned for a pneumonectomy because the tumor was completely encasing the pulmonary artery. So this is the kind of dissection that you can achieve with robotics. The structure which I am cutting now is the bronchus. We are doing a sleeve resection in this patient. And the node which is usually between the bronchus and the pulmonary artery has completely vanished and has formed a plastered layer around the artery. And now you can see we are going between the layers of the adventitia. So I am going between layer 1 and layer 2 of the pulmonary artery, which is already a thin artery. Because for those, you need to know that the pulmonary artery is not like other arteries in the body. It's almost like a vein. It's very thin. And it's scary. If I make a puncture hole here, it's torrential bleeding and immediate, loss of almost 2 or 3 units blood in 5 to 10 seconds of time. So you can see this layer which has formed. This is a response layer. So what I do before going in for a pneumonectomy for this patient, I dissect this layer out. I send this layer for frozen section. And like I mentioned, if it shows no tumors and only lymphocytes, that is most of the case, I do not do a pneumonectomy. I actually save a portion or more of the lung to get it back. So this kind of surgery is possible with robotics, very difficult to do with minimal access. I mentioned to you how we are able to manage complications better, and one of the core principles of good surgery is actually to try and avoid a pneumonectomy, because pneumonectomy is a disease, and for surgeons here I would mention here now, these three are the only indications where I do a pneumonectomy now. If there's fissural involvement, if there is tertiary bronchial or arterial involvement, that is involvement beyond the 3rd degree vessel, is the only indication for pneumonectomy. If this is not the case, please do not do a pneumonectomy for your patients. They will land up in trouble. Their lifespan will decrease by almost 30% compared to if you do a lung sparing operation, or if you don't do surgery and send them for chemoradiation. So we had to modify the operations. We had to make these modifications. Like instead of doing a lobectomy where it's just stapling or cutting and suturing, we actually do a sleeve resection where we cut and anastomose. These are complex resections. I'll just show you how. It is again another post-chemo case. For the surgeons in the crowd, they will see this is not how a normal lung cancer surgery looks. Lung cancer surgery is very neat and clean. Here you can see the color. This is a Chinese immunotherapy drug. The moment you saw my videos earlier, it was like red, and now this is a blackish thing that you are seeing. So this, in fact, I can tell the immunotherapy drug that was given even without hearing the medical oncologist. And each drug is having a separate kind of immune. Now, here what we are doing is we are cutting out the tumor and we are saving the lung. You can see 2 curtains of the bronchi over here. We are using a dye called indocyanine in green to check for vascularity. Green means that the blood supply is very good. And fortunately for post-chemo there is a lot of neovascularization. So what happens when there's neovascularization? You don't have the problems of post-radiation surgery, where there is less vascularity and there's a lot of chance of bronchopleural fistulation. Here it's post-chemo intense neovascularization and less stenosis, less formation of fistulae. Actually the sleeve resection, these patients do very, very well. We are anastomosing the bronchi to bronchi and saving almost 70% of the lung, where in this patient it would have been a bilobectomy. Not only that, you should try to save, even if you are going to save only 3 segments, save that much. Don't do a pneumonectomy. Here, this particular patient, you can see the tumor is here. I could only save this portion. I had to take this, but this also I could join to this. I'm joining 3 segments to the main bronchus, and it is possible to join. You can manage almost 60% discrepancy of the bronchial lumen when you do sleeve resections. So the message here is, even in post-immunotherapy status, try to save lungs as much as possible. And not only that, with more and more aggressive, we have now started doing stage 3B cancers, because the medical oncologist is sending to us and the radiation oncologist is not ready to give radiation for those patients. So post-chemo stage 3B, he sends to us telling that, Sarana, just artery nikal ke jod do, just remove the artery and anastomose. So here we are actually anastomosing the pulmonary artery to a segmental portion of the pulmonary artery. And this is possible with robotics, very difficult to do with VATS. I have never done it VATS. I have done this open many times, but it's easy to translate that same open skill to a robotic skill because the robot helps you in suturing and it's made for it. So here it's almost like doing an auto transplantation, taking the lung. So here we've removed the bronchus, anastomosed the bronchus, removed the artery, anastomosed the artery, and one patient we've done the vein and vein as well. So it is safe after chemo immuno because you can see over here. I'll end with the last two more slides, madam. You can see in the left hand side, those pinkish things that are there are actually intense lymphocytic markers which are seen, compared to on the right side when immuno is not given and you do a surgery, there's a lot of tumor which is there, which is green in color. So almost 75% of the patients after doing a sleeve resection, when the decision was to do a pneumonectomy, they were found to have a major pathological response. Not only that, we have good surgical planning techniques. We now go into the theater better equipped. We are working with an AI company to help us do this, just like the radiation oncologist mentioned, help us plan and do these surgeries in a better manner. We function preserve, so post-chemo surgery is not easy. So to prevent post-operative pneumonitis, we actually prospectively identify the vagal branches, the bronchial arteries to the remnant lung and save them when doing surgery. And last, this is the kind of surgery that we are getting right now. Salvage resection post-chemo immuno. This patient received surgery, received adjuvant radiation, had a recurrence, received immunotherapy, was on 3 years of immunotherapy, and now the tumor started growing again. And we had to go in and we had to remove the superior vena cava, we had to remove the entire right lung, and here we are actually looping, we have looped everything via sternotomy. This is still done in open. We are cutting open the trachea. We are reconstructing the trachea with the left main bronchus. So that the tubular structure, so this is a trachea and it is directly stitched to the left main bronchus. The right main bronchus is removed. Now before doing a SV resection, we actually put a graft from the upper to drain the extremity veins. We are now using a graft from the atrium and temporarily creating a shunt between the left innominate system and the atrium prior to going for a SVC resection. And then then now we are actually doing the SVC resection and reconstruction, and this is how it looks. And finally we disconnect the shunt and then reconnect it with the SVC graft. And this patient has now completed almost 9 months, and this is the only hope of these patients. So very difficult surgery, and what medical oncologists are now making us do is in service of the patient. Most probably this patient will go on to have a good result, because this patient also had more than 90% response and only 10% viable cells in the tumor that was remaining. And just while I was making this presentation, I think our lifetime of surgeons is going to get lesser by another 5 years, because now they're going to ask us to do post-chemo IO RT surgery. Extremely difficult. Thankfully, there's no difference. In this study of a very small group of patients, there's no difference between chemo IO surgery versus chemo radiation IO surgery. So thankfully, I hope it doesn't happen, because it will be miserable for us then. So this is the last slide. It's feasible to do these operations if you plan well, and it needs a change in the surgical mindset. Robotics definitely makes life easy, and in the future I expect more difficulties to come, and probably it will keep me interested in this field forever. Thank you.
Thank you, Dr. Saravanan. As always, excellent, brilliant lecture, very, very practical. We'll take one quick question while we're just arranging the chairs for the panel discussion.
As always, sir, calling you here is a mind-numbing experience. I'm sure the entire audience, irrespective of whether you're a surgeon, non-surgeon, pathologist, pulmonologist, is absolutely in awe of what you do. I think it's very heartening that you have been the gold standard and the torchbearer for people who have been interested in VATS, uniportal VATS, but my only funda is, when you're doing robotic surgery, have you found any different? There's no feedback from the lung, no, sir. That is a problem. So I think sometimes in early lung cancers, localizing the lesion itself sometimes becomes a problem. But you're saying that obviously, when you're doing it, it is the way forward, especially for people like me.
As you know, I'm not that skilled in VATS. I'm just a learner. So maybe I should transition, and I think we should all transition to robotics more, so that we can.
It takes 20 cases to feel with your eyes.
Yes.
20
First
cases.
20 will have to refer to you, sir. There's no doubt about it. Or do an open surgery.
No, do
There's
20
doubt
simple
about it.
cases.
Yeah.
So your eyes become your fingers.
Yes.
It takes 20 cases, and I've converted so many people to robotics now. I used to convert everybody from open to VATS. Now I'm converting everybody from VATS or whatever to robotic.
Yes.
It takes 20 to make your eyes your finger.
Yes.
And you can feel it. You can actually feel with your eyes. I always tell.
Yes. Great, sir.
I'm
As
sure you will
usual.
do too, sir.
No, sir. Let's hope.
Thank you, sir. Thank you.
Thank you, sir, for the thought-provoking insight. Next on the schedule is our panel discussion on the topic Note Positive Early Lung Cancers. I now call upon our moderator, Dr. Amish Vora, along with our panelists, Dr. Venkatesh K., Dr. Shupreet, Dr. Deepak Das, Dr. Madhu Narayan, Dr. Sarthak Mohanty, Dr. Aravind Motaravilu on the dais.
So we have Dr. Venkatesh, Dr. Suprit, yes, Dr. Sachin, he's not here, okay. Then we have Dr. Sarthak, yes, Dr. Deepak, Dr. Madhu, yes, and Dr. Arvind, okay. So we have 2 medical oncologists, 2 radiation oncologists, and 2 surgical oncologists. Right, okay, perfect. So my, first of all, thank you, Dr. Vamshi, for giving this opportunity. It is always a pleasure to come to AIG and see such wonderful work which they are doing. AIG reminds me, I was in Delhi in one of the meeting, and one of my friend, uncle, told me he has some GI problem, and I sent him to my gastroenterologist. And the next day he said, नहीं, मैं तो हैदराबाद AIG जा रहा हूँ, यहाँ पे कुछ समझ में नहीं आ रहा है. So I think the reputation which the hospital has built is commendable, and it's very good. We will start with that. Can I have my presentation, please? Our topic is node positive early lung cancer. Okay. So my first question is to Dr. Arvind and Dr. Madhu. How does it feel, the concept of complete pathological response? आपने अपनी, when you were doing MS general surgery or early days of surgical oncology, there was no concept of neoadjuvant and complete pathological response. How does it feel as a surgeon with that concept?
Yeah, sir. Generally in oncology, complete pathological response to neoadjuvant therapy is shown to have translated to improve the survival. So yes, of course it benefits the patient, but at the same time it troubles the surgeon also.
We saw Dr. Sarwan's video, yes, I saw for the first time, and I was surprised. He said that Chinese molecule he could make out from during intra-op. That's amazing. We'll come to that. But do you also have a feeling that it makes the surgery difficult?
Yes, sir. I have few cases in my loop. Yes, it makes the surgeon's job difficult, and of course it benefits the patient. And always neoadjuvant concept is always to have a good response, and you assess the prognosis of the patient, and you can change the treatment post-surgery based on the residual disease. That's the concept we believe, and that's how the trend is going on. So yes, I believe the pathological complete response improves the survival.
Dr. Arvind?
Yeah, so my experience, I would say when I was in UK, so we had done about 63, we sent for ESMO also by then. When you have complete pathological response, definitely the surgery becomes difficult, but it's very good for the patient.
Yes.
When you have major pathological response, surgery was a bit more easy. And when the response was bad, actually surgery was pretty easy.
Okay.
So I think that pretty much sums up, but it's good for the patient. So
it's a good thing. I think, it's very happy. I'm very happy that surgeons are embracing even though it is difficult to operate upon, but everything for the patient's outcome, which is actually very good. So again, Dr. Madhu, to you, our topic is early lung cancer with node positive. Will you involve N2B in early lung cancer, or how would you define early lung cancer with node positive?
Honestly, the first question, sir, N2B, multiple mediastinal lymph node stations, I won't involve in early lung cancer.
You
definitely.
Won't involve in early lung cancer. Dr. Arvind?
Yeah, probably if they want some mediastinoscopy or something, if EBUS has failed, but otherwise I think we're not involved in early.
Dr. Saravanan, would you involve N2B in early?
I actually don't want to use the word early at all. Potentially resectable is what I want to talk over here. So all of these, the N2A technically will go for early lung cancer up to N2A, but N2Bs technically were not resectable, and so they were
Right. So why I put that, and on all three of you surgical oncologists, is because the keynote and the durvalumab study, they involved N2B.
Yes. So for
and they
me,
operated upon those patients.
So for us, N2Bs go for neoadjuvant with the intent of surgery.
With the intent of surgery. Dr. Madhu, Dr. Arvind and Dr. Saravanan, do you people think that IO plus chemo in a neoadjuvant setting change the biology of the disease? I am not talking of conversions into open to close, all that you showed. Do you think it changes the biology, or it just downsizes? Dr. Madhu, Dr. Arvind and then Dr. Saravanan.
Yes, sir. Of course, the studies have shown to have a good response or major complete response based on the checkmate trial, 25%. So definitely it assess the biology and it will determine the further treatment also. So I believe, yes, it will assess the biology of the disease, and of course it will be shown to have an improvement in event-free survival according to the studies, chemo and immuno.
Okay, perfect.
So I'm not sure how much it will change the biology. If you ask me per se, I feel it just tells us whether the patient's biology is good for
whether the
how
patient.
well he will.
So you think it
respond
does
to the
not
surgery.
change? Dr. Saravanan, you have labeled a patient inoperable to begin with. Have you seen those patients getting operated?
So we do quite a few of those.
Quite a few.
The last one I showed you is similar to that
Right,
situation. So my concept is, what immunotherapy does is, once it gives, selects the patient, that is obvious, better patient selection, that is one thing. Second thing what I've seen is, it trains the body to fight a recurrence if it happens in the future also. And with all of the colleagues whom I work with around the world, the concept is that if the tumor is there, it's easy, just like AI, it needs training. So if the tumor is inside, AI is, the immunotherapy, the cells train better, and the immune response is sustained in the long run.
Right.
So in our clinical trials, what we found is the response is sustained.
Right. Dr. Venkatesh, Dr. Supreet, you are surprised that surgeons are now talking about long-term sustainable effects of immunotherapy.
No, sir, it's good, sir. Actually, we are also.
Right. Okay, perfect. Dr. Arvind, very quickly, how do we confirm node positivity in NSCLC? That's the topic for today. I would say, assuming the PET CT shows 2.3 centimeter subcarinal lymph node or the hilar lymph node, and SUV of 9, and the primary SUV is 8.3, unequivocal, would you still like to go for pathology confirmation, or for you this PET CT is good enough?
I think yes, we definitely go by based on the guidelines. We have to get an EBUS to just confirm definitely. And
so
also
pathology is mandatory.
Yes.
Dr. Madhu?
Yes, sir. Yeah, PET shown to have a good sensitivity, but specificity is poor, sir. So we should confirm with the tissue sample, EBUS guided. Yes.
EBUS guided.
And
Yes.
one more thing, especially in our setup, we definitely need to rule out any other possibilities like tuberculosis or any others. Of course, they might not give that much PET avidity, but still in our Indian setup, I think it's still mandate.
Dr. Deepak, if the patient comes to you and all the three surgeons here, they said we can't operate on this patient, you better give CTRT, and then oncologists, medical oncologists would say we'll add up durvalumab. Would you like to confirm each and every node station before RT, pathology wise?
No, I don't think we need to know about the pathological status of the lymph node. We need to know that if it is pet-habit or not. If that is pet-habit, then we go for elective irradiation of that lymph nodal area. We don't do pathology in regular practice of that.
Dr. Sarthak?
Yes, I agreed.
Okay, so surgeons want pathology as node positivity before surgery. Medical oncologists would want node positivity, but radiation oncologists do not want the pathology confirmation. Does the definition change from modality to modality? See, I have written here, I have gone through some 11 different meta-analysis and update in 2025. The sensitivity and specificity of PET-CT remains between 85 to 89%. That means 15% of the patients you are going to miss or you are going to overdiagnose.
Sir, it is not only the like sensitivity and specificity, it is the positive predictive value. So if it is node is positive, then in positive predictive value of PET-CT is more in lymph node compared to the primary disease. So it is positive predictive value of lymph node is around more 95%. So if it PET is habit, that means it is thought as positive. So we generally don't go for pathology before giving CTRT.
Dr. Saravanan, in your hospital, if you say, I doubt, you would be saying those sentences frequently that I can't operate upon, but suppose assume you say that I can't operate upon, you send for CTRT, would you like the nodes to be
definitely.
confirmed?
We've had situations where medicinal evaluation is mandatory before you send a patient for either surgical or non-surgical treatment. If there is a node which is non-FDG avid as well as an FDG avid node which is even smaller than 1 centimeter, it is mandatory because your decision making will change. Now, for example, if a patient had N3 disease before and you gave CTRT for N3 disease and you didn't biopsy that node and now the patient is having a focal recurrence, would you go and operate those patients? So I think it's necessary to evaluate the mediastinal lymph nodes. In India, our false positive rate for PET-CT, because we EBUS everybody, our false positive is more than 42%.
I completely
so
agree.
I think we need to know whether any node is positive or negative before we proceed.
Okay, no, I completely agree on that point. Dr. Madhu, somewhere it's a paradox today. N2B multi-station, 5-year survival, which say surgery adjuvant CT, not IO I'm talking of, is to the tune of 30-35%.
Yes, sir.
And we have seen that Pacific trial, 5 years data, that N3 disease, if you involved in CTRT, and you give durvalumab, and if the patient is lucky enough, the 5-year survival rate is 40%. And still we say early lung disease, node positive, we will not include N3. Isn't it a little paradox? Because I feel once upon a time we used to say early breast cancer, locally advanced breast cancer and metastatic breast cancer. Now everything is EBC or MBC. I think similarly in lung also, I think everything is going to be ENSCLC and MNSCLC.
Yes, sir. So multi-station N2,
and you answer this question also, that which
yes,
N2 you would finally see can be operated upon.
Yes, sir. N2A, single station N2, I feel it's operable, sir. Multi-station N2, I don't prefer to operate, sir, because they have a good definitive chemo-RT with immunotherapy that gives a good.
So there are two points here: upfront surgery versus surgery after neoadjuvant IO plus CT. I would like you to answer both as a surgeon,
yes,
because see, in an MDT, before we give any treatment to patient, we have to decide the intent first.
Yes.
What would be your intent?
So N2A, sir, if I would divide that N2A and N2B, so N2A I would go for neoadjuvant chemoimmuno and followed by surgery, sir, and followed by the adjuvant treatment. So N2B, my plan will be definitive chemo radiation followed by the immuno. So that's my takes.
Okay, Dr. Arvind. See, I have put the survey which is published in NCCN. This is yesterday's download. They did a survey to NCCN member institutions in 2024. And if you see, not a single institute considered upfront surgery for multi-station or bulky N2 disease, but they preferred neoadjuvant IO plus CT or systemic therapy, and then they decided to operate upon. Dr. Arvind, what would be your practice? What is your practice today?
It's pretty much same what Dr. Madhu has said. Only thing is we have done some multi-station N2s post chemo IO, well, not here while I was in UK, but yeah, they did so far okay, but I think they had got more quicker recurrences compared to the other one, and they didn't tend to have complete pathological response. Maybe
would you
just
include tomorrow, if your hospital starts a trial, would you include N2B in your perioperative IO plus chemo trial?
probably not.
Probably no. Dr. Madhu? Trial purpose, yes. Okay. Okay.
Standard, I feel. Not a standard currently, yeah.
Dr. Saravanan, N2B, would you include? Because 24% of patients in AG and durvalumab study were N2B.
So we are actually asking ISLC to make N2C also, because infiltration of major airways and probability of pneumonectomy after the chemo IO. These two situations, I think they should never come for surgery. So we are trying to make, now N2B is I think resectable discrete nodes multi-station is a case for neoadjuvant and surgery.
Fine, perfect. So I think N2B is something which I understand is surgeons are slowly getting comfortable about the same, but it is still a difficult choice, and rightly so, because the survey was divided. Okay, we come to Dr. Venkatesh. Dr. Venkatesh, MRI brain in all comers. See, assuming surgeons, MDT has happened. Now patient is to you for perioperative IO plus CT or NACT IO. MRI in all node positive NSCLC, which is given. NGS in all patients. Is there anybody here who does not do NGS in node positive NSCLC? Is there any institute? It is not done. You have to do it. You do it in all?
Yes, sir. No, MRI, no, sir.
MRI, no. In node positive, NSCLC, MRI is no.
Only metastatic we are doing, sir.
Only in metastatic you are doing. Okay. What do you say?
I would do, sir. I would do MRI, because before offering any definitive therapy, it becomes imperative to rule out any asymptomatic
MRI brain, yes.
MRI brain is, I would definitely do.
Definitely do it. Okay, perfect. Dr. Deepak, you agree? MRI brain?
Yes, sir.
Both the surgeons agree that we should do MRI brain, or you have some other thought process? Venkatesh says that Tata Hospital does not allow us to do MRI brain. It allows us.
Smaller tumors, UK sometimes they go for just CT contrast, but yeah,
CT, but something imaging of the brain. Okay, perfect. That is what I believe. Venkatesh, NGS, EGFR and ALK in all patients?
No,
Okay.
NGS. Earlier days we used to do in Tata also was only PCR and all, but now NGS lung panel.
Now NGS lung panel. Okay. So Venkatesh, see there are two scenarios here. EGFR ALK has to be negative, if I understand correctly, for IO. We will not waste time on discussing that. PDL1, do you do in all patients?
Yes, sir.
You do it? Yes. You don't do it in all patients. Ullas Batra. Okay. The main question, Dr. Supreet, would you consider Dr. Saravanan in his, not Dr. Saravanan, the speaker before him said that OS data is not available in IO plus CT, and Ullas would take the next flight back if that is the right answer. If all of you, Dr. Ullas Batra is the authority in lung cancer, and Dr. Prabhas also. So we are lucky that they are here. Dr. Supreet, NACT IO or perioperative? Which one would you believe?
For now, I believe in periop IO.
Believe in periop
for
IO?
2-3 reasons. One,
Okay.
because the periop IO trials also say that if the patient has achieved pathological complete response, the benefit with adjuvant part of immunotherapy may not be so much, which is the concept behind neoadjuvant IO only. But how many PAT-CRs do we see in our day-to-day practice, or even in the trials, it is only 20%. So my counseling will be periop, but later on, if the patient to his luck achieves PAT-CR, then neoadjuvant.
Then only neoadjuvant. Okay. Venkatesh?
Same, sir. I agree with you. So,
Same. Okay. So if the patient does not achieve PAT-CR, then you would go for, you would continue with IO.
yes.
Okay, perfect. Right. So we have in 2022, this is the OS survival of Checkmate, but in 2022, first time EFS data was there, and the same time perioperative pembrolizumab came, and same 2023 perioperative durvalumab trial was published. Okay, so if we see the event-free survival in only Nivotherapy, only Nivolumab arm, and if we see the event-free survival in the perioperative Pembrolizumab arm, the hazard ratio is exactly the same, 0.63 and 0.58. Dr. Venkatesh, based on this data, why should I offer more Pembrolizumab to my patient? Or do you need more data before you say, okay, 3 doses of Nivolumab, the matter ends there. Okay. In a country like India and in a place where you are working, less is better, I feel. Right? Okay. So why do you want to give more? Help me understand what is the extra advantage of adding more IO when this is there. Some people may say that there is an overall survival advantage. Okay, so let's look at this OS data. So this is the Durvalumab data. This is the overall survival data with 5.5 years of follow-up and ASCO 2025, and we have a publication in NEJM also about the overall survival. And this overall survival, again the hazard ratio is 0.72 in unselected patients, ITT population.
I think we are running short of time.
I have calculated and I have 7 more minutes, ma'am. Exactly, मैं हर 2-2 मिनट में time देख रहा हूँ. Vamshi is here? No, not here. Okay. Fine. Venkatesh.
Yes. Yeah. So one thing, sir, because these all are one is neoadjuvant and this periop is cross comparison. We don't have an arm which is to be randomized in the beginning to show which is beneficial. So that is one point I would like to include here, sir, mainly.
Suprit, overall survival data with 3 doses of Nivolumab.
But we still don't have overall survival data for the periop trials. So
we have the overall survival data of periop trial, and at the 3.6 years, exactly the same hazard ratio. So we now have OS data of 3 trials.
But we also have the proportion weighted analysis.
5 years, 3.6 years and 3.3 years. These are the follow-up of OS data of the 3 trials. And exactly same hazard ratio. There is not a single dot difference in the hazard ratio in OS in a perioperative versus neoadjuvant only. And the perioperative, the only difference which I feel is that the neoadjuvant Nivo trial did not involve stage 3B, while the other 2 involved stage 3B also. That is the only difference I see. But if the patient has stage 3A, I don't see any reason today if it is there. And we talked about that. My point is that if your patient has operable node positive disease and EGFR and ALK negative, immunotherapy in any form works. So again, Venkatesh and Suprit, if you achieve major pathological response, would you continue IO? If you have started Pembrolizumab, there is no data of Pembrolizumab, only neoadjuvant.
No, if I have started Pembrolizumab, then I would continue and complete adjuvant phase as well.
So isn't it better to start with Nivolumab?
Yeah.
Because if this is a complete pathological response.
But again, it all boils down to the percentage of PATCS that we see. So if we
30% assuming. So 1/3 of the patients at least will, avoid this thing. Yeah. Venkatesh, Chinese manufactured IO, you are comfortable?
Yes, sir. Now with the data we have NeoTouch and even Rational 315. I'm okay with that. But NeoTouch include only stage 3, which we can see. But okay. I'm okay, sir.
You are okay. Okay. Last 2-3 minutes about both the radiation oncologist, Dr. Sarthak and Dr. Deepak. What is the role of radiation in node positive non-small cell lung cancer? Completely resected N2 disease. Completely resected. There is not only R0 resections, no margin positive, no extra nodal extension. Lung RT, post lung RT, do you still give RT in such patients? Dr. Deepak. See, the guidelines mentions that you can give here if you see in such patients. Doctor.
In multi-station N2 disease, definitely there is a role of radiotherapy, adjuvant radiotherapy. Or if there is extracapsular extension, then definitely there is a role of adjuvant radiotherapy. Otherwise not. If it is completely resected, then there is no role.
Then there is no role. Dr. Sarthak.
Yes, it is a multidisciplinary team thing, and it's said multi-station lymph node positivity. In that particular case, I may give RT, otherwise not.
Otherwise not. Ullas, in Rajiv Gandhi, completely resected N2. Do you give RT? Do you consider RT? The NCCN still says you can consider RT. You may not give, but you should consider. You don't consider. And you don't give. AIMS Delhi? You don't give. Okay, fine. So I think I hear they have said consider RT, but we have now enough evidence that in a completely resected N2, you should not giving RT also is justified, which is absolutely okay. Those who have not received neoadjuvant can receive adjuvant IO. Very quickly, Venkatesh and Suprit, this would be my last topic of panel discussion. EGFR and ALK mutation positive, would you offer IO in any form?
No, sir.
No, you would not offer. Okay. If the patient is EGFR positive, we have NeoAdura trial. The data readout is about the feasibility.
Yes.
Okay. Would you consider, say, N2 disease, multi-station but non-bulky? You know, not straight away, surgeon is not very happy operating upon. Would you give osimertinib with chemo in such setting?
Yes, sir.
You would give.
Yeah.
Okay.
I mean, I cannot say they are fully established phase 3 study, but there are many studies which I saw in literature which has given combinations also. And
you would give. Okay. Would you give?
Yes, sir, I would give.
You would give. Okay. Ullas, what is your RGCI recommendation? N2 bulky, multi-station, non-bulky. Surgeon is not very comfortable operating upfront, but EGFR exon 19 positive. Would you give neoadjuvant OC plus chemo? You would give. Okay, fine. I would not give because there is still no clear-cut data. It is just the feasibility data readout is there. I would wait for at least some event-free survival data before we can give on that. Venkatesh, when EGFR positive post-op, with chemo or without chemo?
As long as patients with chemo, sir.
With chemo. Suprit?
With chemo, sir.
With chemo.
We have.
If ALK positive, with chemo, without chemo?
Though study doesn't give, maybe I would give too.
You would give also. Would you give?
Same here. Same here.
But this trial said you may not give chemo.
But the problem is with the other resistant mutations like TP53 or any other mutations that might confer resistance.
Okay.
So there we are.
Fine, perfect. So this is the very, very nice trial. So I would very clearly say that in ALK positive patients, I think you can avoid giving chemo, and post-op you can give alectinib. And in osimertinib, unfortunately, the trial was designed in a way that you are supposed to give chemo, followed by osimertinib. And with that, I thank all the panelists. I think I am still on time. If any panelist has any comments, anything, please share so. We can, surgeons, Arvind. Yeah, there's my first bell.
No, I think the timer stopped in between.
Okay, I'm finished. Yeah. Dr. Arvind.
So that data we had shown that of course chemo IO has not changed much of the patient's eligibility for surgery. Only about 2 patients out of 63 have actually become inoperable because they become very, very sick and they had not. But the PFTs, the echo, CPET, nothing has changed in any of them. So they were still eligible for surgery. And like I mentioned, the more the pathological response, the harder the surgery was. But still about 82% of them were done by VATS, and only 18% had to go for conversions or open. The open was, some of them were actually big tumors, so there was no point in trying to do that. So they had been upfront open as well.
Perfect. Point well taken. The second bell. Thank you so much, all the panelists, for wonderful participation. Thank you.
Okay. Thank you, Dr. Amish. As usual, a very dynamic moderation. So now let's quickly move on to the next session. So
long time, sir.
May I invite our chairpersons for the session, Dr. Vijay Kumar and Dr. Sunita. So Dr. Vijay Kumar is a pulmonologist at Apollo Hospitals, and Dr. Sunita is the head of nuclear medicine, AIG Hospitals. Yeah.
Thank you, our dear moderator and the panelists, for taking us through this knowledgeable session. Kindly note, there is no specific tea break, but the same is being served outside the auditorium from 11 a.m. onwards. To continue the next aligned topic, may I invite Dr. Prabhat Singh Malik to elaborate us on the topic Metastatic Carcinoma Lung, EGFR Positive, Problems of Plenty.
Thank you. At the outset, I would like to thank Dr. Vamshi and the entire organizing team for giving me this opportunity. And the task assigned to me is to discuss about the landscape of EGFR mutated advanced non-small cell lung cancer management. And what we have currently is really the problem of plenty. All of you would agree with me, I mean, at least people who have treated lung cancer in last more than a decade, that we have really seen a therapeutic, change into paradigm from nihilism to cafeteria choice, and that to an extent that we are literally spoiled for the choices, and that's the problem with this subset of lung cancer that's EGFR mutated. This slide basically summarizes all the landmark trials of EGFR TKI in EGFR mutated non-small cell lung cancer, starting from IPAS to more recent combination strategies. And what you can see more recently with the combination strategies, you are reaching to an not previously seen kind of progression-free survival, which is going beyond 2 years, and even overall survival reaching approximately 4 years in FLAURA2, where we have more mature data. With the Mariposa, which is another combination strategy which is commonly used in a first-line setting, although the median in that subset has not reached, but probably we are heading to that extent as well. And after that, you have more of a chemotherapy-free regimen, apart from Mariposa, where you can combine TKI with VEGF inhibitor, be it erlotinib or osimertinib. And then we have some data about using afatinib and osimertinib for uncommon EGFR mutations. So when you have all these options available, how to make a decision which treatment to be given to each patient. So it's not that simple that you have an EGFR mutation, give osimertinib or give erlotinib or give gefitinib. So it's not that straightforward. And I think this is the most important slide in my entire presentation, that this decision has to be a shared decision making, where we have to consider several factors, be it disease-related factor, the patient-related factors like comorbidity, the performance status, disease-related factors like presence of co-mutation, disease burden, presence or absence of brain metastasis, and the side effect profile and the logistics of the patient, whether patient is able to visit hospital frequently or not. And then last but not the least, the financial status, whether patient can afford the treatment or not. So, we do have wonderful treatment option, but probably one size does not fit all, and I think individualization is the best way to go. Again, this is re-emphasizing the same point that with the monotherapeutic approaches, when we were reaching a PFS of around 18 to 19 months, with the third generation TKI and with the combination strategy, be it FLAURA2 or a Mariposa approach, we are reaching to a PFS of close to 2 years and an overall survival of 4 years. And we know that exon 19 deletion and L858R behave a little different. You have better outcomes, be it a monotherapy or a combination strategy. You have better outcomes with DEL19 as compared to L858R. And this is the landmark trial, the FLAURA2, which initially reported the improvement in progression-free survival, and now we have mature data of overall survival. The interesting part that even patient with having brain metastasis, this combination lead to even significant, much more significant improvement in progression-free survival as compared to patient without brain metastasis. And traditionally, we consider that chemotherapy doesn't cross blood-brain barrier, but it's certainly this combination do something, and you have better intracranial efficacy. And now you see that the overall survival, patient with advanced lung cancer, patient in this subset, if you are using the combination strategy, these patients are living beyond 4 years. And the subgroup analysis does show that most of the subsets, they derived benefit. But what was the problem? The problem is the tolerance of the treatment. So when you are adding two treatment strategies together, it would add to efficacy, but it would add to the toxicities as well. The problem was here. Almost 40% serious adverse events, 64% grade 3 and higher toxicities, interruption of osimertinib in almost 40% patients, and discontinuation of even osimertinib, not chemotherapy. I'm not talking about interruption of chemotherapy. That's interruption and discontinuation of osimertinib, which is a quite important treatment for this in 11% of patients. So that's something which is bothering and which makes this a little bit more complicated decision. But the impressive part that despite all discontinuation and interruption, you have a survival advantage. So overall, it's kind of a winner combination. And simultaneously, you have the other combination, which is approved now for first-line use, this amivantamab lazertinib, another chemo-free regimen, but require hospitalization because of IV infusion. More or less similar results in terms of progression-free survival as compared to osimertinib alone. And now you have OS data as well. The median has not reached at 3 years, but the 3-year overall survival rate of 60% indicates that probably the median is going to be more or less same what you have got with FLAURA2. Again, the tolerance, if you look at more or less same what you get with FLAURA2, I would rather say that even worse in terms of discontinuations and interruptions. And not to forget the little older trial of using first generation TKI with chemotherapy, more or less similar replica that you get in progression-free survival and overall survival benefit, but the cost of higher toxicities. So now the argument is, which is the better strategy, to use combination for everyone or to reserve the sequential approach for maybe a subset of patients. But if you look at the efficacy and you see the advantage in terms of, let's just talk about progression-free survival at the moment. If you are using a FLAURA2 approach, you reach progression-free survival at around 25 to 29 months. So in the FLAURA2, when they did an independent review, the PFS was around 29 months, but the investigator-assessed PFS was around 25 months. So you reach at about 29 months. And more or less same what you if you use the amivantamab lazertinib combination. And then if you use the sequential approach, you use osimertinib, you reach around 18 to 19 months, and then whatever you use, whether chemotherapy, ABCP, Mariposa 2, and combine both these PFSs together, you reach at more or less same point where you could have reached by a combination upfront. And then, I mean, it's not beyond. And then not to forget that all patients, this is probably not the best way. It's not the, you combine two trial sequentially one after the other, because we know in lung cancer, all the patients whom you start treatment today would not be able to receive a second line treatment ever. So you need to understand that caveat. So to that extent, so should we conclude that the upfront combination is the only and the best way, or can we further personalize a little bit better? So what we have understood from the previous study, that presence of baseline ctDNA positivity or failure to clear ctDNA by 3 week or 9 week is a factor which is associated with poorer outcome. In FLAURA2 subset analysis, which shows that whether you clear ctDNA at 3 week or you don't clear ctDNA at 3 week in both the subsets, the chemotherapy combination was a winner. But in Mariposa, it shows that in some of the high-risk subset, which they defined by presence of P53 co-mutation, presence of liver metastasis, presence of baseline ctDNA positivity, or failure to clear ctDNA by third cycle. So these are some of the factors where probably the combination works slightly better than the monotherapy. Are we there yet, and can we make these conclusions based on the subset analysis? In a statistical term, probably no. So that's an important question which is worth answering, and that's what we are trying to answer now. This is an ongoing study which we are currently doing, which is liquid biopsy guided addition of chemotherapy, where we are randomizing these patients into two subgroups. One is receiving chemo TKI combination upfront, and the other, the experimental arm, is being risk stratified based on these alteration, which is presence of P53 co-mutation, baseline ctDNA positivity, or failure to clear ctDNA by 3 weeks. So these are three high-risk features we are considering. If any of these high-risk feature is present, we are considering these patients for combination. In absence of any high-risk feature, we are continuing the monotherapy. So the results of this trial would probably make us more wiser where we can avoid this combination approach for a subset of patients or not. Another problem with using a combination strategy upfront, that when you treat these patients, eventually most of these patients are going to progress, and the resistance mechanism which are going to emerge would be somewhat different if you use a monotherapy versus if you use a combination strategy. And the on-target, the secondary alterations are much more common if you are using monotherapy as compared to if you are using the combination strategy. But now we have learned that how to handle the resistance mechanism. If there is an on-target mutation, we like development of C797S, we can either use a first-generation drug, or we can think of using a fourth-generation TKI. We are still in the trial phase. If there is a bypass mechanism, we can use some combination. For example, if there is a MET amplification, we can use an EGFR TKI with MET inhibitor, or we can use an approach which is agnostic of these resistance mechanisms, like using chemotherapy or a Mariposa 2 kind of an approach. And the number of ADCs which are in development phase, probably we would have more options when we meet next year. And these are the plethora of ongoing trials and some of the early trials which have completed and shown promising activities of several combination strategies and ADCs. Datopotamab is something which have shown promising activity, at least in phase 2 trials. And this landmark study, which was recently published in New England Journal of Medicine, and shows that SAC-TMT is probably has a promising option for such patients who progress after the third generation TKI. So I think the treatment landscape of EGFR mutation positive lung cancer is going to look somewhat more complex in future, and even now something like that. It's not that you have an EGFR del19 and just start them on TKI. Probably you need to consider number of factors like patient-related factors, comorbidities, disease burden, the sites of metastasis, some potential biomarkers like presence of ctDNA, presence of co-mutations, and then take a decision whether to use a monotherapy or use a combination. And based on the type of the first line strategy, probably we would be choosing our second line and subsequent line of treatment for these patients. And in the end, and not, last but not the least, we should not forget the financial toxicities associated with these novel treatment. I do agree that they are all wonderful treatment and associated with significant survival advantage, but not to forget that they are associated with a lot of financial burden to the patients. So I would conclude again here where I started, that this is probably not one treatment for everyone. Again, a shared decision making considering all these factors which I discussed is probably the way to go. Combination strategies certainly have their own advantage, but at the cost of higher toxicities. Patient acceptability, logistic, and the side effect profile remain a major challenge. Individualization and personalization, considering all those factors which I talked about, is probably the best way to go. Thank you very much. I will end here and would be happy to take questions if there are any. Thank you.
Thank you, eminent speaker. May I now call upon Dr. Nagavinash Bonda to present his talk on the topic Breaking Frontiers in First-Line Metastatic NSCLC, Leveraging Anti-PD-1 and Anti-CTLA-4.
Good morning. Thank you very much. This is our first sponsored session, and the slide deck and the presentation have been provided by BMS. Thank you. So I'll try to quickly rush you through the two important updates, or rather long-term outcomes that we got to read in the past few years with respect to Nevo EP in non-driver positive metastatic non-small cell lung cancers. So this is the outline. We'll quickly rush through the epidemiology, the staging, and the unmet need and rationale for first-line NSCLC, and what is the advantage of this synergy of Nevo and EP, and of course the treatment of first-line metastatic NSCLC with these IO plus IO combination and how they entered the guidelines. So all of us know that lung cancer is probably the most common, the most cancer-related deaths worldwide from the Globocon data. And the picture is not so different even in the country. So these are the incidence is about 5.5 per 1 million population, and the deaths and the new cases, you can see the numbers. Of course, it accounts for more annual deaths, than colorectal, breast, prostate, even all these put together. And among men, 1/4 of all the cancer deaths are probably due to lung cancer. So we'll rush through this. All of us know about small cell and non-small cell lung cancers, which are again classified with respect to the histological types, that is adenocarcinoma and squamous carcinoma comprising 80 and 20% of all the lung cancers. And of course, we have certain rarer cancers like large cell carcinoma. And what is important for us to understand is that, majority of these patients, close to 60%, present with advanced and metastatic disease. And it has a 5-year survival of around 5% in US and of course 2% worldwide. So coming to what is the unmet need, or what is the rationale of, incorporating this IO combinations and driver negative metastatic NSCLC, is perhaps we don't have a durable response. So there's a lack of durable response for majority of patients. And certain patients, they drive the benefit and certain do not. So that durability or the benefit is also like, it's based predominantly, at least we take our clinical decisions based upon the PD-L1 expression, sometimes on the histology as well. And all of us, we try to look for a chemotherapy-free option for a significant number of these patients, at least in the first line. And now we have data coming from, trials across, even in, so that is a unmet need that we are actually talking about. And of course, last but not the least, the patients who actually progress on prior immunotherapy is also a substantial group of population where we usually, lack a durable, meaningful therapeutic option. So let's try to talk about the synergistic mechanisms of action of Nevo and EP. And you can see that, all of us talk about the immunotherapy trial curves, merging in the beginning, and at least you see that they separate after the first 1 year or 18 months. And probably there is what is important is to understand the induction of memory T cells or emergence of memory T cell population that actually keeps the curve separated as we go, and people who do well will continue to do well. That's what Dr. Sarvana was also talking in the morning. So on one hand, we have anti-PD-1, that is Nevo here, which actually restores or re-benefits the anti-tumor T cell function, and all the pre-existing T cell repertoire is made active. Of course, it increases the cytokine milieu. On the other hand, your anti-CTLA-4, it also induces de novo anti-T cell responses. It adapts to the clonal evolution of the tumor, and perhaps it induces the emergence of memory T cells, which actually take the patient down the curve of the immunotherapy. So it also causes a compensatory increase in the tumor PD-1 expression, PD-L1 expression, so that actually enhance each other. So this synergistic mechanism is probably what is put forward, and we see this in multiple tumors, whether it is malignant melanoma or renal cell carcinoma, and now later in hepatocellular carcinoma. So understanding this is probably perhaps important for us because, for quite some time, the role of EP was confined to very few cancer populations. So this certain combinations probably can, overcome the limitations of IO monotherapy as such. So if we combine the CTLA-4 blockade along with PD-1 blockade, perhaps there will be a redistribution of the activated T cells to the tumor sites, and that results in better target cell killing in this combination. So the rationale for combining IO, that is Nevo and EP, is with respect to this hypothesis. Now, I will quickly run through the updates of Checkmate 9LA and Checkmate 227, the part 1A, which have published their 5 and 6 year outcomes. And this is the Checkmate 9LA, where the 5-year outcomes of first-line Nivo-EP with chemotherapy was compared with chemotherapy in patients with metastatic NSCLC. This is a study design with just 2 cycles of chemotherapy added to Nivo-3 and EP1, and compared with 4 cycles of chemotherapy plus or minus pemetrexed maintenance as and when required. So the primary endpoint was overall survival, and exploratory endpoint was an overall survival stratified according to the tumor histological types. Baseline characteristics, well matched. Good to see that at least 20% of the patients actually had brain metastasis and were included in the trial. And they had also all the, the population was quite heterogeneous. I mean, in the sense that with respect to PD-L1, we had patients less than 1% accounting to around 40% of the population. So this is the OS advantage in the entire group. All the randomized patients at 5 years, Nivo plus EP with chemotherapy did better than chemotherapy alone. And this is the overall survival in patients with PD-L1 less than 1% at 5 years, 3 times definitely higher overall survival rate with a hazard ratio of 0.63. Now in PDL more than 1% expression, the hazard ratio was 0.73, so at least close to 27% reduction in the risk of death in Nivo EP plus chemo arm. And with respect to histology, yes, again, Nivo EP fared better than Nivo EP plus chemotherapy fared better than chemo alone. And the magnitude of OS benefit was better in patients with, I mean, you can see that in both the histologies. Probably the magnitude is much better in the squamous histology with respect to the hazard ratio of 0.63 when compared to the non-squamous histology. Then if you look at the duration of response in all the randomized patients, it was more than double when we compare with the chemo alone arm versus Nivo EP plus chemo arm. So this is the duration of response in PD-L1 less than 1% patients, and you can see that 25% of the patients, despite PD-L1 being less than 1%, but still in response at 5 years. And remember, all these patients had just 2 cycles of chemotherapy to begin with. And this is, of course, more than a 1% PD-L1 expression at 5 years, and 15% of patients with PD-L1 more than 1% were still in response. Now, this advantage was seen in consistent regardless of the histology. That is, the improved benefit was seen even in non-squamous as well as in squamous, but perhaps the magnitude was more if you look at the hazard ratios. And this PD-L1 population with 1 to 49% and PD-L1 population more than 50%, they were in line with more than 1% of the subgroup which had more than 1% PD-L1. So the efficacy was demonstrated in all the randomized patients in all subgroups by, if you take it with respect to PD-L1 expression or histology, as well as you can see that the benefit which was sustained, and good to see the 5-year outcomes of such a randomized trial. And this is the duration of response. Even the duration of response benefits were also maintained at 5 years in the Nivo EP plus chemo arm. Coming to the adverse effects, I mean, more or less the adverse effects actually reflect the expected adverse effects with respect to Nivo EP, with, if you look at non-endocrine, predominantly diarrhea in the earlier phases, and as we move on, it was predominantly hepatitis. If you look at endocrine abnormalities, perhaps thyroid disorders were most common as the doses increase, and the number of doses of Nivo EP increase. Key subgroup data, I will rush through. The OS advantage was seen even in patients with brain metastasis at baseline, irrespective of the baseline characteristics. And this is the PFS and the duration of response with where Nivo EP plus chemo fared better. The hazard ratios were 0.44, and if you look at the PFS and response without brain metastasis, still the response is maintained. So the intracranial PFS in patients with brain metastasis at 3 years, you can see that the hazard ratio is close to 0.42 in patients with brain metastasis at the 3-year time point. Of course, the numbers at risk were far and few. And so this benefit was actually seen in all those patients, irrespective of the mutations that they harbored, whether it was KRAS, P53, or STK11. And the safety summary, the median duration of therapy was around 6 months for Nivo EP plus chemotherapy versus chemo respectively. But it was if you select the common adverse effects or treatment-related side effects that you see, the dermatological toxicities, as we see in our practice, they are more common, followed by endocrinological toxicities. So if you look at the duration of therapy, as you can see that the 5-year overall survival in patients who actually discontinued the treatment still did not have a negative impact. So people who had response and continued to respond despite stopping the treatment due to the treatment-related adverse effects. As you can see that in this, so the 5-year, the benefit is maintained. So one important thing is this is one of the like a good long-term follow-up data of Nevo EP plus chemotherapy, perhaps the first one, first of the IO combination trials which had such decent or rather long-term data, and it's always good to see the IO curves over a period of time. And it is an efficacious first-line treatment option for patients with metastatic NSCLC, particularly when the tumor PD-L1 expression is less than 1%. So the discontinuation of Nevo EP plus chemotherapy due to the adverse effects did not negatively impact the overall survival or the long-term survival. So the people who do better, the patients who do better will continue to do better. That is what we all see in different IO trials, right? This is another update. It's a 6-year survival and health-related quality of trial update for first-line Nevo plus EP in patients with metastatic NSCLC. That's a part 1 of Checkmate 227. So here we have again patients of stage 4 driver negative NSCLC without any prior treatment, no untreated CNS metastasis, and the part 1 is basically the PD-L1 population more than 1%, and it was randomized to Nevo EP versus Nevo versus chemotherapy arm. The independent primary endpoint analysis was done for Nevo EP versus chemotherapy. So the baseline characteristics were overall matched, balanced across the treatment groups. And yes, again, in patients with the PD-L1 more than 1%, patients, the 6-year overall rate with Nevo plus EP versus chemotherapy were 25 to 16 in non-squamous histology, and it was 14 versus 5% in squamous histology. So this is the 6-year overall survival data. So perhaps tending or pointing towards the fact that probably we can consider a chemo-free option even in this particular subset of patients. If you look at the duration of response and progression-free survival with respect to the PD-L1 expression, yes, the 6-year PFS rates were 11% versus 2%. And if you look at the PFS and the duration of response in the 6-year survivors, the median PFS for Nevo plus EP was 60 months, whereas for chemotherapy it was 9 months. And the safety summary, Nevo plus EP, the adverse effects closely mimicked from what we actually expect. There was no abnormal or alarming safety signals out of this. So probably, this is the longest reported follow-up across the phase 3 studies for first-line IO in patients with metastatic NSCLC, and it can be an option where chemotherapy can be omitted for patients with PD-L1 more than 1%. I mean, greater tumor burden reduction was observed with Nevo EP versus chemo. So the responses were deeper and they were associated with long-term benefit in this population of PD-1 more than 1%. And yes, if you look at the guidelines, yes, Nevo EP is useful in certain circumstances. You can see that it is a category 1 recommendation in the NCCN. And even in the population where the PD-L1 expression is more than 1%, yes, it is one of the important options that can be considered. So this is the, I think, yeah, I'll wind it up. Thank you very much.
Thank you, sir. The next in the list is the panel discussion on the topic Managing Pneumonitis. I request our moderator, Dr. Ullas Batra, along with our panelists, Dr. Bharat Rangarajan, Dr. Narmada Rathinaswamy, Dr. Arun Chandrasekhar, Dr. Riddhi Jyoti Talukdar, Dr. Shashidhar Kaza, Dr. Soumya Parimi, Dr. Rane Bolinini, Dr. Harish and Dr. Shaktivel Mani to please come on the dais.
Okay, hi Bharat.
Okay, good morning. I think so in this panel, we have a combination of medical oncologists, surgical oncologists, radiologists, pulmonologists, and 2 surgeons as well. I have spent the last some time in thinking about what am I going to ask the surgeons actually about how to manage drug-induced pneumonitis. Let me see if I can come around with some question for the surgeons. Okay, so managing pneumonitis, I was just thinking I'll make it some tips and tricks how to manage pneumonitis. When our first discussion basically goes with the patient, we always discuss, immunotherapy, the efficacy, 20% survival, 40% survival, 5 years, 2 years. What we don't discuss about toxicity is, this is, out of syllabus, कि नहीं आएगा, ये exam में नहीं आएगा, I distinctly remember this Bharat telling me during our TMH exam, ये exam में नहीं आएगा. And ultimately that question only came. So this is, the more you tell people that, this question will not come, that is the question which comes, and then it is time to face the music. So today it is time to face the music for all of us. We'll start with this. Let's start with you, Bharat. Some 5 questions for you, and then I have 3 wonderful cases. I have stopped using the word beautiful cases now, because then people will equate me to Trump, which I don't want to get into. So Bharat, in your practice, what is the incidence of IO-induced pneumonitis? Is there a specific agent or combination that you feel will cause more Nivo-EP alone, or Pembro alone, or Durva alone, which will cause? And any risk factors which are there? So we'll start with you.
I think that overall is around 5 to 10%.
Okay.
Not too high, but still significant.
Okay.
Enough in practice, as you say.
How many immunotherapies do you give per year?
There will be around 30 odd patients on immunotherapy. This is not new immunotherapy. A month going on immunotherapy. That is, not new patients totally. 30-35 odd immunotherapy.
So around
patients.
5 to 10% will get.
Around 3 patients or so. Not, of course, every month. What I'm saying is overall 3 to 5.
Any risk factors or any specific agent that you feel will cause more pneumonitis? Maybe a Nivo-EP combination will get more, or Durva will get more?
I have found that if you're using the dual IO combination, the pneumonitis seems to be slightly higher, but again, very limited numbers. We don't have too many of those IO plus
Fantastic.
IO. Secondly, if the patient already has had radiation and that Durva in the post CTRT, that is not a very, actually there is higher pneumonitis.
So let me talk to the radiation oncologists here. Medical oncologists always want to get the put all the blame on the radiation oncologist.
No, it's combination.
It's just a combination.
And of course, our patients have COPD. If they have pre-existing COPD, we don't know what is playing up. What is it the COPD exacerbation or the pneumonitis? But the patient comes coughing, breathing difficulty. You are still, some of the pneumonitis element is there in that exacerbation.
So let me talk to the radiation oncologist here on board. Anybody from the radiation? Yes. Do you think radiation, what is the incidence of pneumonitis that you have seen in the Pacific regimen?
So, the incidence of grade 2 was something around 28%, if I remember correctly.
So you really feel that radiation augments or really puts the patient more towards pneumonitis, or is it something else?
I would answer it in a different way. I would say that most of the radiation pneumonitis that we see in our practice are asymptomatic and barely need treatment.
Okay.
It is obviously complicated when we add immuno along with it. It becomes important to differentiate between radiation-induced pneumonitis versus IO-induced, so that unnecessary
correct
withholding of IO doesn't happen.
Okay, fantastic. Any time frame, Dr. Narmada, any time frame for pneumonitis, whether it will occur, within the first 2 months, 4 months, 6 months, or it can happen anytime?
It can happen anytime, but usually it's between the first 6 months.
Okay.
Yeah.
But what are the earliest that you have seen, or the latest that you have seen?
Earliest, even on the day of infusion, I have had.
On the
but
day of
I couldn't
infusion, wow.
exclude whether it was any other cause.
Okay, okay. And the latest?
Latest is probably in the 6 months timeline.
6 months time. To the radiologist, are there any, sir, are there any typical findings of this which can tell us, that okay, fine, this is a drug-induced pneumonitis, because I have some cases over here. Are there any characteristic feature that we should be aware of? Because, in Delhi in this season, everybody will have some GGOs. I mean, from November till March, everybody will have some GGOs. You do CT scan for me, Prabhat, everybody will have. How do you then differentiate between IO-induced pneumonitis and everything else, sir?
Regarding radiation pneumonitis.
No, not radiation.
It is
IO-induced. IO-induced.
IO-induced pneumonitis, a high index of suspicion has to be there.
Absolutely, yes.
The radiologist, whoever is reporting, must know what are the drugs which are the patient has been treated, and also the duration.
Do you ask your medical oncologist, sir?
And we have.
Or does your medical oncologist write on the file that report is written? Is it? I mean, everybody is really, or that is a problem with the simple NSCLC on treatment?
No, we do have everything in the EMR.
Okay.
So we do have all the information regarding the number of cycles of immunotherapy, chemotherapy, everything is documented.
Okay. So
but we have various CT patterns which are described, characterizing the different drug toxicities with respect to IO. We have 4 main patterns of CT characterization.
I will show that, sir. But there is no characteristic pattern as such, basically, which can really tell us that, is it?
The main issue is differentiating with an infection.
Okay.
Which most of the time we will not be able to do.
Okay.
CT is not very helpful.
Fantastic. So this was a presentation which was made by Jaroshika Naidu in this year's ESMO. They found out in the trials, out of 11,777 patients, only 716 patients basically had some event. So the tune of what Bharat said, around 8%. Some factors which were associated with risk of pneumonitis: age, more than 65, less than 65, smoking definitely, non-small cell lung cancer definitely is more than melanoma and everything, and Nivo EP is basically more than a combination, is more than a single agent one. As sir rightly said, there are 4 different patterns. None of them is pathognomic of a radiation-induced pneumonitis, of a IO-induced pneumonitis. Suspect. I always tell in the tumor board, in God we trust, lest everybody should bring the data on this. That's very, very important. This is the timeline that we were talking about. It starts at 6 months, but it can basically occur any time it comes over there. So there is nothing. It is basically what I say is IO-induced pneumonitis is actually like Trump. It is, absolutely unleashed and unpredictable. It can actually, he can actually wake up on the left side of the bed and say something, and right side of the bed say something.
I hope you don't have a visa application.
I don't have visa application. I have a visa over there. Okay, now let's start with this now. So we will go to Dr. Arun now. Dr. Arun, we have a 55-year-old female, CA breast. For a change, I also treat CA breast, although I speak more about lung. LABC, TNBC, BRCA was wild type. The patient was counseled regarding neoadjuvant chemotherapy with chemo and immuno. They were willing for it. So this is, are there any investigations that you order before starting a patient on immunotherapy?
Yeah, so in addition to the usual CBC, RFT, LFT, we do urine protein examination. Correct. We look at the serum cortisol level.
Correct.
We definitely do a TSH.
Okay.
And I don't do we would have a baseline scan prior to these patients.
You have a PET scan normally.
Yeah.
So do you order, now let me come to this, do you always refer a patient to a pulmonologist or do a PFT with DLCO? And after this I will go to the 2 other medical oncologists and then the pulmonologist. So do you order a patient on a PFT, do you order a HRCT, PFT, DLCO for a patient who is supposed to be given immunotherapy?
No, I do not do it.
We do not do it. Fantastic. Bharat? We don't do it. Dr. Narmada?
No, sir.
We don't do it. Let's say this patient has a lung cancer, COPD. Will you send this patient to a pulmonologist for an opinion regarding PFT, DLCO? Or a fitness for immunotherapy? Bharat, you only said COPD. I'm just putting you into a spot as usual.
No, the patient definitely will go to pulmonologist for the COPD part.
Okay.
All patients who are planned for a surgery or a chemoradiation regime will go get a PFT DLCO. But patients.
So let's say it's a first line. It's a first line lung cancer patient who is supposed to be given Keynote 189 regimen. Patient has some COPD. Will you refer the patient to a
pulmonologist? Yes, but not PFT DLCO.
Not PFT.
We don't
now
get a
let
PFT
me
DLCO.
go to the pulmonologist, because once the pneumonitis develops, everybody will do a PFT DLCO. My problem over here, and this is how I learnt over there, was a patient basically had PFT DLCO which was less. We were not sure whether it was disease. We were not sure because they said you don't have a baseline. And we had a huge tiff in the tumor board at that time that, whether we should do a PFT DLCO at the baseline for all lung cancer patients. I will come to it on this. So, pulmonologist over here, Dr. Soumya.
Yeah, so I think even if you don't ask, we'll probably do it.
Oh, fantastic. If he doesn't refer the patient, then what will you do, madam?
No, this is not fully true, partially true, because everybody who is in COPD with a pulmonologist has a PFT at some point, but they don't have a DLCO usually.
Okay, fine. Let's just get breast cancer over here and then I'll come to lung cancer. CA breast, 55-year-old, 55-year-old female, absolutely no comorbids. You want to give a Pembro, Pacli, carbo-based regimen? No. Dr. Namda? You will refer for fitness for immuno or not?
No,
no.
Not.
Dr. Arun? Dr. Soumya?
Are you asking about fitness?
You think we should, after this discussion, we should have a pulmo consult before we start this?
No, I don't feel strongly that you should. Now, the typical patients that come to us for clearance are the bleomycin, those patients on whom we get.
Bleomycin also, you will say that, PFT is not very diagnostic on that.
We'll do a baseline PFT and DLCO. In fact, that's something I talk to our oncologists regularly about is please let's do a PFT DLCO for baseline.
Prabhat?
This category, I don't know that there is evidence because there's two issues. Post-developing pneumonitis, see, PFT is effort dependent. If the patient is coughing constantly, you're going to get an abnormal result. So if your patient is presenting with grade 2 or 3 with symptoms.
I will tell you what we do. Prabhat, do you do, Prabhat is not there. No, you don't do. But in our institute, actually, because we have had some experience, we actually refer the patient, most of them will be COPDs. We do a PFT with DLCO. Sometimes what happens, their pulmonary function are so bad that, the DLCO is less than 40, 35, their 6-minute walk test is not. We will actually risk stratify the patient and we will always tell the patient that listen dude, you have a higher chances of if you get a drug induced pneumonitis, you might just land into trouble. We do it all the time. We have been saved by this on more occasions than one. So at least in lung cancer, we always do a refer a pulmonologist before to the patient once, take their consultation, have a baseline PFT DLCO, because if it starts coming down, then it's an issue. It's not in the guidelines. We looked at the clinical trials. It's not in the guidelines, but that's a standard institute practice that we have actually done on that. Okay. PFT, yes. So PFTO always happens with DLCO. Only PFT is not important. DLCO is very, very important.
Is there a baseline which you would not give
immunotherapy? Yes, so less than 45, 40 we don't give. We tell the people there is a mild to moderate risk of this thing and then we look at the so let's say somebody has a DLCO of less than 40, PDL1 0. I will actually say, okay, fine, the risk and benefit are not very high.
But is this clinically important in non-lung patients?
Non-lung patients typically...
breast and, RCC, when they are walking, cancer, they have effort tolerance. Would you send for a PFT DLCO
normally
in that
no.
situation?
So normally no. In a breast cancer patient, if the 6-minute walk test is okay, chest X-ray is okay, scans are okay, we don't normally refer. In a lung cancer patient, I will definitely take a pulmo consult once. So this was the patient's pre-treatment CT scan. If you can look over here, there are some GGOs over here, So looked at these GGOs, we referred the patient to the pulmonologist. They said, nahi, non-smoker hai, 55 hai, female hai, okay hai. The tolerance was good. They said, okay, fine, we go ahead with the immunotherapy. They told us, please do an analysis, again a reval analysis, somewhere slightly more earlier. We said, okay. We started the patient on Pembro and chemo. Pacli, Carbo, Pembro. Sudeep sir is there, so I have to be very mindful of the immunotherapy and chemotherapy regimen also over here. This was the scans which were done in the month of April, which said that the GGOs by and large have disappeared. So we were very happy with that. This patient now, 6-7 months later, came to us with mild cough and breathlessness. Now she was getting AC. I still remember this was 9th September. I had just come back from IACLC, so I remember the date also over there. She came to us on that day, there was AC and Pembro. Now somebody on AC and Pembro comes to you with breathlessness and Delhi mein there was a change of season. So I had 3 differential diagnoses. It could be a normal viral induced pneumonitis. It could be a anthracycline induced cardiac dysfunction. And obviously because it is immunotherapy, it could be IO induced pneumonitis, right? So patient had some SOBs and patients, हाँ sir वो थोड़ा सा सांस फूल रहा था, but she wanted to finish with immunotherapy, chemotherapy at that time. So you question them or say, nahi sir, ऐसा कुछ खास नहीं था. So, Dr. Narmada, what would you do now?
Sir, if it is a new onset symptom and not looking...
It's a new onset symptom, mild fever, 100 fever, this is हम
Sir,
सबको दिल्ली में है अभी.
Yes, looking into the counts and looking into the
Counts,
duration,
okay.
if not fever, like an acute infective cause, I would really like to take a pass, evaluate and then proceed with the cycle.
Echo was normal, blood test was normal, procal was done, was normal. Mildly breathless, yes, saturation was I think around 96-95%. One thing which we do it always over there, and I'm sure everybody does over here, is a 6-minute walk test. To me, a 6-minute walk test for a clinical trial patient is a must. I mean, for a clinical trial and anybody and everybody, because there's a waiting time, this keeps them occupied. So once a patient comes, my coordinator basically tells them, "Chalo aap 6 minutes zara ghum ke aao." And we write pre and post 6-minute this thing, which is an absolutely poor man's CT scan, I will say, which really helps us a lot. This lady's saturation actually dropped from 96 to around 91 or 92. And we said, okay, fine, you know, let's just get some more investigation. X-ray was done, which showed some bilateral infiltrates. And Dr. Arun, this is the scans which basically came over here. To the radiologist first, sir. We saw the initial scans and we see the scans right now over here. Radiologist, sir. I'm still thinking about what all questions to ask to my surgical colleagues. I will ask. I'm still thinking about a question. In the meantime, will you operate on that or not somewhere? Darlong would operate on that also, but we'll see. Sir, radiologist, sir.
Yeah, I think I can see multifocal consolidations.
So there is a
most of them are subpleural.
Correct, sir.
And in the left lower lobe, I think this looks like an area of breakdown there.
Correct, sir.
So if that is true, because I don't have the entire data, but
Correct,
if this is a breakdown, then I would definitely think more in terms of a infection.
Correct, sir. So this is what they wrote. Study reveals multifocal peripheral nodules discrete to coalescent consolidation, GGOs, halocine, aggressive fungal viral pneumonitis. GD includes cryptogenic organizing pneumonia, inflammatory etiology, and those 3 magical words after that, clinical correlation suggested. I mean, sir, I had to bring this over there. Sorry for that, but you know. So with this thing, the patient comes back. Yes, sir. You wanted to say something?
Yeah.
Because the radiologists don't have eyes. I mean, see, they're right.
Yeah, presence of multifocal consolidations 6 months following the treatment.
Correct,
IO. Definitely COP stands one of the differential diagnoses.
Correct,
but again, I would, because in the presence of breakdown, I would definitely put it in infection as my first reading, because it has to be ruled out. And for infection to be ruled out, a CT cannot rule out an infection.
Obviously, sir. I mean, sometimes we love to make fun of all these things about the 3 magical words, but how will a radiologist know? And it's a clinical judgment. So all things said over there. So with this, Arun, what would be the grade of pneumonitis? Is it important in the routine clinical management, or you know, it happens only in clinical trials?
No, it's definitely important. This patient is symptomatic right now, so mild, so I would put it as grade 2 in this patient, and because it will help choose what kind of treatment I would, you know, give the dose of steroid per se, and the decision on re-challenging the drug.
Very important for the residents. Grade 1 asymptomatic less than 25, grade 2 25 to 50% symptomatic. Anybody who is symptomatic, grade 2. Anybody who is symptomatic, stop treatment. Anybody who is symptomatic, start steroids. I mean, that is the most important thing which comes over here. So, Bharat, when your radiologist reports, so this patient actually went to tumor board, and we had a lot of issues in that. Do they actually report about the involvement of the lobes, you know, 25%, 25 to 50%? Do they actually report that?
No, they don't. But because we are constantly looking at this grading, we go and ask them.
Correct.
So they tell us at least orally, it may not be there in the report.
So this happened in the tumor board. And we pestered them कि नहीं अब तो immunotherapy अगर लिखा है तो अब तो grade लिखना ही पड़ेगा.
We are in private practice. We can't go and pester anybody. So you know we can ask and then add an addendum. The addendum will be added
report 1. See this addendum. We are also private oncology medical. As Prabhat said, you know, you are your corporate. What was the word? Executive word you used, Prabhat, yesterday. So you know we are also private mazdoors. So we ask them कि please grade 2 लिखवा दो 25 to 50%. Also because for clinical trials it is very important. So we ask them, they oblige for that. So Dr. Narmada, how will you start this patient now? So remember the radiologist has said could be viral, could be fungal, could be bacterial, could be IO.
Yes, sir.
And the patient has mild fever also. And the patient is a Delhi resident.
Yeah, since patient is already on chemotherapy, would like to really rule out an infection as well. So
Correct.
if possible
so
to send
CBC,
for
LFT, KFT normal, Procal normal.
Yes, sir. So still I would like to, if possible, do a biofire and sampling.
Biofire
Meanwhile, I
sample.
would like to start with antibiotic and steroids, at least prednisolone 1 mg per kg.
Okay.
And keep her at least observed in the ward for like 3-4 days to make the initial call to figure out
So
what it is.
admit steroids under the cover of antibiotics. That's what you're saying. Bharat, will you do something different? And a biofire panel. Yes.
Nearly the same. Ask the pulmonologist to get involved, get a BAL done, send
Important
all the
thing.
samples.
Now, do you refer the patients to a pulmonologist right now or later?
Yes, this
Right.
point of time, she is having a saturation of 91. Yes. This point of time is the right point of time because later on, if the patient becomes too sick, they will not know what the temporal progression
Dr.
was.
Soumya, this is the right time to refer to you or?
Absolutely. I agree with Dr. Shashi that there were a couple of areas it's hard to tell, but look like there may be necrosis. It's
Correct.
hard to tell with a single slice. But in a necrotizing, potentially infectious thing, I might not even say start, I mean, this is your patient, but I would be a little bit afraid to start 1 mg per kg of steroid without getting more, like, is she diabetic? Is she at risk
Here is
of
where the
mucor?
problem comes. Because this where the typical dose which is used is omnacodyl 20 mg OD or half dose of this thing. So this half-hearted steroids doesn't really work in IO-induced pneumonitis.
No, I agree with you that if it is confirmed pneumonitis, we should give the full dose.
Correct.
But
you will
not
want
without
to-
ruling out infection when there's a necrosis component in the middle. So that's
Bharat,
what I'm saying. If
agree?
she's at risk of mucor or
But-
something else,
so
we should make sure
the
we've ruled
Pulmo
that out.
wants to, see, it's a real-time case. Pulmo wants to start 20, 30 mg steroids, 60 kg man. You want to start 60 mg. तो 40 दे दें या कैसे करें?
No, I want to do bronchoscopy, then you do whatever you want.
Okay.
Let
Okay, you
the
do
samples-
bronchoscopy, then do whatever you want. Madam,
see
we
the
will come to bronchoscopy also.
The
Don't
only
worry.
thing here is you said the Procal was normal.
Yes, it was.
So all our antibiotics we are giving, so it's not a very significant
Correct.
infection because the Procal is normal. CRP is always misleading.
Okay.
It's high, low. It's not as good as Procal.
I have one more very nice case. Okay.
So maybe we will start 1 milligram per kg because the Procal is
We
normal.
did exactly right. We did 1 milligram per kg body weight. We also put the patient onto steroids, and patient was on 1 milligram. How do you taper the steroids in a IO-induced pneumonitis? That taper is slow. You don't please taper it over 5 days, 5 days, 5 days. You taper it around 4 to 6 weeks. That is what you taper basically across over there. After 4 days, this patient was not admitted. Ceftum and omnacodyl was given. The patient basically came to ER with worsening cough and breathlessness. And this is what my thing exactly over there was. Because the pulmonologist exactly told me to do bronchoscopy and do this. I said, nahi, 1 milligram देंगे, बिल्कुल ठीक हो जाएगा. And this BPO2 low is not patients. This was mine actually at that time. And which was very, very critical. X-ray had actually worsened. So we got a bronchoscopy done over there. Madam, in what all investigations will you send in the BAL?
So,
All the
BAL,
gamut?
the biofire that you were mentioning,
Yes, ma'am.
if you're suspecting viral, then a nasopharyngeal swab is really useful. If you want to do the full bacterial plus viral, the giant panel, please don't do a nasopharyngeal swab. It'll just get you the...
I said biofire from the BAL
Oh, okay. Agree.
for
with
the
you,
BAL
agree with
sample,
you.
okay.
So I think in this patient where speed is important, in a culture in 3 days, you might get some organism,
Okay.
but in the biofire on the BAL, you will get bacteria and viruses
So
immediately.
again, important thing is, because I have one more very interesting case to show, please do a bronchoscopy. Please involve the bronchoscopy, the pulmonologist and the ID specialist earlier. It is a teamwork. Get a bronchoscopy, get a BAL, get a galactomannan, get a, the BDG assays, PCP assays. Please don't leave out anything. So
Yeah.
this is how we did. This is what we basically did. This patient was then treated with methylprednisolone. We admitted. It was a steroid refractory. We gave him methylprednisolone, IVIG also. He did not respond. She did not respond. We actually had to give her IVIG and infliximab also. And Dr. Amish, later on, I have a very nice case. We'll discuss later, please. Later. One. Okay, please. Who can stop you? आप पूछते क्यों हो? आप पूछते क्यों हो?
To pulmonologist, with the peripheral consolidative areas which were seen, how much BAL would be sensitive and specific in picking up the infection?
It would be actually.
It would be.
It would be. I only will tell.
50% is what the literature says.
It is okay. It is still better than nothing. So we will send a galactomannan and we will send a PCP.
No, I think if it is infection I think it would be more than 50% for bacterial. Now, if it's mucor or something fungal, your yield goes down quite significantly. I agree with you. If it is mucor or something unusual like that.
Dr.
If it is
Nirmala.
pneumocystis bacterial, your yield will be very high,
Ma'am, there's
above
a
90%.
very nice case in which you will be involved next time. Yes,
And the bowel cytology, like the sampling which we send, we also look for if it's a neutrophilic or a lymphocytic.
Correct, or a lymphocytic count, and that is what will show. This patient ultimately responded well and did well. So ultimately, most of the characteristics over here are actually grade 1, grade 2. They respond very well. Steroids have to be given. This is a very nice chart, you know. For a grade 2 pneumonitis, start them steroids 1 milligram per kg body weight, and most of them respond. Very few people respond to go on to the level 3 actually over there. And this patient underwent surgery after that. Has a residual disease. Will you utter the R word? Will you re-challenge the patient? The patient has not got a PCR. Bharat, will you give Pembro again to this patient?
This is a curative intent setting.
Curative
right?
intent setting.
And she has received 8 cycles.
She has finished the chemo and the immunosuppressant.
So 8 cycles, the usual. I would be very, very reluctant to re-challenge.
Okay. I also, there's a 50% chance that the patient will get a IRE once again a grade 3 event and more. So typically if it's a less than 1, apna dekh lo. Typically I don't re-challenge with a grade 2 and above over there. Now this is something which is very, very important. This is a patient which happened 2 months back. 45-year-old male, never smoker, dry cough for 1 month with minimal shortness of breath. PET scan was done, which had a left lung, left pleural effusion. Biopsy was adeno-CA, EGFR del 19. The patient had a good amount of left side effusion. And as soon as the report of del 19 came, I told him, congratulations. आपको हम osimertinib चालू करेंगे, tube चालू करेंगे. And that is what happened. So we started the patient on osimertinib on 14th of November. Responded well. He was being considered for a Flora-2 regimen. However, initially responded. On Monday 22nd, I remember when he came, he had a worsening cough. And this was the X-ray which was being done over there. And there was, you know, some amount of new infiltrates which had basically come up. He also had 1 spike of fever. So to the pulmonologist, madam, patient on after ICD has deteriorated now. Osimertinib is being given and has some infiltrates on this. What would you do?
So he has bilateral multilobar infiltrates. Even though there is an ICT, you can have re-expansion pulmonary edema if there is a large effusion rapidly tapped. That does not explain the infiltrate on the other side.
Yes.
So he has bilateral infiltrates. I would worry about obviously pneumonitis since we're discussing it, but infection, pulmonary edema.
So
Does
madam,
he have
we
risk factors for any
agreed
of
with
those?
you and we basically got this CT scan. Now this was a nightmare. Remember the CT scan which he came with? On 14th November, now he has more issues and more things on the left side over here. And the patient was getting a 92% saturation and stuff like that. So, Arun, अब मैं क्या करूं? Patient is admitted in the ward on osimertinib. Patient is continuing to do like this. Vamshi, can I have 2 more minutes extra from your side? Okay.
So,
I know. 2 more after that. Okay. Yes, 1 more.
So I think same as before. Stop osimertinib. We have seen osimertinib pneumonitis in some
Stop
cases.
osimertinib?
For now.
Fantastic.
And
Bharat, stop osimertinib? This is only unilateral, right?
Stop osimertinib maybe,
Okay.
but I don't think this is 2 weeks of osimertinib. I'm
Not
not
even
expecting
8
this
days.
picture.
8
8 days. I'm not expecting this
Correct.
picture in 8 days.
Doctor,
Is it like post-pleurodesis or some
post-pleurodesis
other cause?
changes also can be there. Okay. So what we did is we have great confidence in the capabilities of pulmonologists. We got a bronchoscopy done. And the patient I still remember on a Monday evening I went and said, let's do a bronchoscopy. Unilateral infiltrate se fever tha, cough tha, and we did a bronchoscopy. Post bronchoscopy, the patient deteriorated further. He had to go to be shifted to ICU. Will you continue osimertinib right now? The patient is in ICU now on inotropes and BiPAP support now. Continue osimertinib? No.
What is the
Why?
reports? The bronchoscopy?
Everything else was normal. And this was the report, the beta D glucan basically came as 0.2276, more than 0.1, which could be antifungal, which could be suggestive of a fungal infection. So is it a fungal infection or is it an OC induced? It is a unilateral thing. You will not stop osimertinib.
I will not. No, I will stop the osimertinib. Not because this is osimertinib induced. He is not so sick from lung cancer that
Then-
osimertinib has to go at that dose
Okay.
density or intensity
Fantastic.
at that time.
Doctor-
Stop, treat the infection, come back to oscillator.
Okay.
At least until we figure out what is the cause.
So we
probably
figured out the cause now. The
Yes.
BTG is positive. So can I continue osimertinib now?
No, let him settle down
Let him
for
settle
a few
down.
days.
Any acute setting, I normally can stop
Fantastic.
it.
Fantastic. So this patient was started on antibiotics, PCP, and everything basically started. Continued to worsen. So this was the scan in 2 weeks back, and this was on 1st or 2nd of December. The patient continued, and this basically was a CT scan chest, which basically showed that there were new patches, and now they were bilateral patches. So from 1 week, after giving a course of anti-PCP and antifungal, the patches have become from one side to another side.
So the beta-D-glucan is a blood result. What were the bronchoscopy results? Did you have anything?
Nothing,
PCP
nothing.
was negative.
PCP was negative.
So if your BAL PCP is negative,
So
the
you don't
chances.
really.
I don't
So-
think it's PCP.
So ultimately,
organizing
again,
pneumonia is another thing.
the radiologists, sir, I will just only say, they were still saying infective, but now we had a tumor board discussion. And this was my feelings at that time, ki bas ab is gola pe nahi rehna hai, I am going to leave the job. osimertinib also I can't manage, I don't know what will I do. We had a tumor board discussion, exactly the points which Dr. Soumya said, and we said, let's stop everything, let's put the patient on steroids. And this was 2nd December CT scan, and this is the CT scan which was done on 8th December. The patient responded, patient actually had to go on to a tracheostomy, do suction. We started the patient on steroids, we stopped osimertinib at that time, and this was the CT scan after on 12th of December, I think, which was absolutely fantastic. And this was the second case of osimertinib induced drug pneumonitis that I have actually seen on that. And initial thing which I saw over there, and this exactly was my reaction once I got this CT scan actually over there. And I said, you know, this is sheer immunotherapy that we have all have become better at that time. Last question to the panel on this. Now we have given carboplatin to this patient. Will you re-challenge with osimertinib or geftinib now? To my brave friends, Vamshi is already saying no, please don't do that. No, we have Dr. Sudeep now. No, Sudeep sir will help us out in case of any issues with that now. Will you start?
No.
If we have ruled out all the other cause and it's like a grade 4 and a ventilatory support.
Geftinib?
No.
No.
No, the experience I had with
Re-challenge-
geftinib was within 2 weeks the patient developing pneumonitis. That's
Okay,
it.
I don't think, I
Definitely.
don't have the heart. Although there is a literature, there have been 8 case series which have been published in which people have restarted osimertinib under the cover of steroids actually, which can actually be given. But you know, this is where exactly we are. Yes.
This is your patient, so you know he can afford amivantamab. So in the first
I
slide,
will still not
so-
give amivantamab also, Bharat. I am very skeptical of giving anything to him right
But
now.
otherwise, you know, once he does
Probably geftinib.
Uh,
The
pro-
Narunoha Kumar regimen
yes,
is what I'm talking
geftinib
about.
or maybe afatinib with the steroid cover at maybe slightly lower doses
So-
with very close
Okay.
monitoring.
So conclusions here, with the increasing use of IOs, ADC, TKIs, it is a possibility pneumonitis. Always suspect, suspect, suspect. What the mind doesn't know, the eyes won't see, and it will be idiopathic on the part of everybody. Idiotic on the part of doctor, pathetic on the part of the patient. That is something which is there. Most cases are low-grade steroids, but please, no half-hearted, half-dose, short-course steroids. Please give a proper course steroids. A proper infective work, including bronchoscopy and everything is there. Involvement of a MDT is a must actually, and that is what, once you are giving immunotherapy, this is the serial that you should see every day, and you should actually follow this. And actually it's a teamwork. Every member of this team actually contributed a lot, and that is how, and that is where the magic happens. With this, thank you to all my panelists for a fantastic discussion. Thank you. And Amish, if there's any question, Prabhat will take it later. Thank you. Any questions? Yes. Okay, I think we are done. Thank you. I'm sorry to the surgeons.
Thank you one and all for the insightful panel discussion. We now proceed ahead towards our next topic, extending benefit in EGFR mutated NSCLC, the power of combination by Dr. Vamshi Krishna.
Good morning. So this is a sponsored session, and the slides have been provided by the organizers. So I'll be talking of the power of combination. So we have been hearing of movie references, so I think a jodi is always better than a singleton. That's true in life as well as in our treatment. So I'd be talking about EGFR mutated NSCLC. The basics of EGFR mutation is something that we have been very well accustomed to in the last few years. Presently, we use single agent TKIs, and the outcomes are generally with a third generation TKI, osimertinib, we have around 18 months survival. That's a PFS. Of course, when you look at the OS, it's anywhere around 28 to 30 months OS with a TKI alone. What do you do after the TKI? By and large, all of us knew that a third generation TKI works well and it gives you a good response. But after that, you do not have too many options. So use of TJ, we have T790M, you can check with mutations, you have MET exon, all these can be done. But after that, still the OS is not completely as good as you would like it to be. So the idea is you need something else to improve your initial PFS so that you will get better responses. This is not a new idea. We had several studies with first generation and second generation TKIs with chemotherapy. Of course, one of the best known, as Dr. Ullas keeps calling it, the Norona-Kumar combination, or Dr. Norona's very good paper on pemetrexed, carboplatin and geftinib, which showed a PFS of around 16 months with the combination of chemo plus a TKI. This was not the only paper. This did show a good OS as well with a hazard ratio of 0.45. Similar results seen in the NEJ, though they did not have the OS, they still showed a very good PFS. So the conceptual idea behind using a combination of a TKI with chemotherapy has always existed. Why is it becoming more and more important? And the simple answer is this: brain metastasis. We know that a EGFR well controlled extrathoracically, extracranially will have brain metastasis. So we used to think that if you have a blood-brain barrier, the chemo cannot go in, and preclinical evidence kind of debunked that over time. So we know that even now chemo can enter the brain in these patients, and it has shown responses in patients with brain metastasis as well. There's one study which showed the intracranial PFS advantage when you combined chemo and geftinib as well. So all these bring around to the point that you can combine the two drugs, that is a TKI and a chemotherapy, and that really was the basis for this FLORA2 design. Important things to note in this: the FLORA2 looked at exon 19 and L858R because they are the commonest mutations. They allowed stable brain metastasis. Now, with all due respect to my radiation colleagues, nowadays if it's an EGFR positive, we tend to avoid radiation as much as possible. So whenever a patient has a EGFR and has a stable brain met, we would like to treat them without the radiation, because you're talking of longer survivals. So you don't want those side effects to happen. So FLORA allowed that. And they gave a very simple protocol. You had chemotherapy plus osimertinib versus osimertinib alone. So standard of care osimertinib versus standard of care plus chemotherapy, followed by chemo plus osimertinib. So a very straightforward, simple study. The baseline characteristics showed around 40% of patients had CNS metastasis. Something we know in EGFR that happens. So the trial showed an early separation of the graph and a median PFS of around 25 months, benefit of 8.8 months. More importantly, that progression-free survival was sustained on BICR. And when you looked at the subgroup analysis, again, busy slide, but just look down at the bottom, the CNS status. Whether the patient had CNS positive or negative. In fact, in the negative subgroup, they actually just touched the unity. So we don't know what that means, but in the CNS positive subgroup, clear benefit to the combination over a single TKI. And this was also seen in other studies. They looked at time to first subsequent therapy, time to second subsequent therapy. Everywhere they were showing a benefit. The overall survival, which came a couple of years, just I think a year back, and that again showed a benefit of around 9.9 months. And the survival is now 4 years. So metastatic lung cancer, 4 years, median survival, I think that's a huge progress. And that is something which we are now seeing. The benefit starts after 2 years and continues to maintain beyond up to even 4 years. Across subgroups, when you see, again, this is maintained specifically in the CNS subgroup analysis. So the CNS group benefits a lot. PFS in patients with CNS metastasis actually is around 25 months. So again, brain mets we used to think do badly, but here they're doing well. The CNS PFS also was significantly better for the combination, and a higher CR rate was also observed. Subsequent development of CNS metastasis also reduced when you use the combination. So these are all, all the things that we used to talk of. You have a CNS met, we'll give you we don't need to give you chemo, TKI is enough. It's actually kind of again a full circle for all of us. So those who used to say don't give chemo, we'll give it the tablet. Now we say no, we'll give you both. So it's taken a little bit of adjustment in how we tell them. The exposure of the drugs again is good. So we know that these all respond. And the FLORA2 showed that subsequent treatments were similar in both the arms. So safety wise, no major side effects, no extra signals that were found. And again, this is kind of repeating the obvious, but again, as medical oncologists, we can manage the chemo, we can manage the toxicity. Rarely you are as unlucky as Dr. Ullas and get somebody developing pneumonitis like that, but touch wood, I have not seen so far. So hopefully we will not see, and if they see, we'll put them on a flight back and send him to Delhi. So that's what we will do. So again, AE's management was simple. So to summarize, osimertinib plus chemo demonstrated a median OS of nearly 4 years compared to 3 years with only osimertinib. And the additional follow-up continues to say that it is a good first-line therapy, especially for those patients who have stable brain metastasis. So thank you so much. And I think now we'll move on to the main topic of today, or the main highlight for which we have been all waiting. So over to the organizers. Thank you.
Thank you, sir, for sharing the insights. Thank you, our dear chairperson as well. I now request Ms. Viva to lead us through the inauguration and oration.
A very good afternoon to you all, ladies and gentlemen. I am Vibha and I work in the operations team of this prestigious hospital, AIG. To formally commence the proceedings of this Cancer Summit, it is my honor to invite our esteemed dignitaries to the stage for the inaugural lamp lighting ceremony, symbolizing knowledge, hope, and collective commitment in the fight against cancer. May I respectfully invite Dr. Sudeep Gupta, Dr. G.V. Rao, Dr. Sam Rizvi, our CEO, Dr. Kaushik Bhattacharya, Dr. Vamshi Krishna, Dr. Sridhar Dasu, and Mr. P.V.S. Raju sir, our Vice Chairman, to kindly join us on stage and light the ceremonial lamp. Your presence adds immense value to this summit, and we are deeply privileged to begin this important gathering under your guidance and leadership. Ladies and gentlemen, following the auspicious lamp lighting, it is now my privilege to introduce Dr. D. Nageshwar Reddy sir, a visionary leader whose contributions to healthcare, medical education and institution building have been truly exemplary. A globally respected clinician and academician, Dr. Reddy sir's unwavering commitment to advancing patient care and fostering excellence in medicine continues to inspire generations of healthcare professionals. His guidance and leadership have been instrumental in shaping platforms such as this Cancer Summit, dedicated to knowledge exchange, collaboration, and innovation in oncology. We are honored to commence today's proceedings with the welcome address of Dr. D. Nageshwar Reddy sir, delivered via a Zoom call. May I now request the AV team to kindly connect us with him, please. Thank you.
Yeah. Thank you very much. And also, I'm extremely sorry that I'm on a virtual call because I'm in another meeting in Chennai at the same time. First of all, on behalf of AIG and all the faculties of AIG, I'd like to welcome all the delegates for this very important oncology meeting, which is held annually at AIG. We'd like to welcome you both to AIG and to Hyderabad. Oncology, and both medical oncology and radiation oncology, has become a very important aspect of our hospitals. And what we have seen in general is a dramatic growth under the leadership of Dr. Vamshi, Dr. Kaushik, and of course we also have Hem-Onc now with Bala. All of them together have raised the standard of oncology to a very high level. We have seen that they not only do very ethical oncology practice, but even scientifically the quality is extremely high. They have, I think the board meetings they have are again of extremely high quality. And we found that in general, I think the overall treatment of patients who come to us with cancer of various specialties has dramatically improved. I think oncology in general is making dramatic progresses, both in terms of what is available in drugs, I think the new forms of therapy, the CAR-Ts and so on. And I think also radiation oncology is making a huge, tremendous advances. In fact, the proton beam therapy, which we are going to get shortly at the AIG, is going to add another value to oncological treatment that's going to happen here. So all in all, I think it's a very exciting field, dramatic responses, a lot of science, a lot of research in this area. And I'm sure this meeting will add further in terms of these discussions. And I wish the meeting all the best. Thank you very much. Again, extremely sorry I can't be there. Right now I'm here, another conference. And therefore I'd like to wish all of you a very happy and very fruitful conference. Thank you.
Thank you, sir. May I now call upon Dr. Vamshi Krishna for the introduction of the orator, Dr. Sudeep Gupta. Thank you.
Thank you, everyone. It is my privilege and honor to welcome Dr. Sudeep Gupta, sir, our teacher, our mentor, and presently the Professor of Medical Oncology and the Director of Tata Memorial Center, Mumbai. So it is all of us in medical oncology have been looking up to Dr. Sudeep for the last 20-30 years because he has been a leading figure in medical oncology for India. He has done his MBBS, MD and DM from the All India Institute of Medical Sciences, New Delhi. And following that, he has been a faculty member in TMH for the last 25 years. He's an internationally renowned figure. He has a prolific clinical researcher, a prolific researcher in basic sciences, and he has been a principal investigator and co-investigator in multiple trials. More than 380 papers in peer-reviewed journals. He has special interest in breast and gynecological cancers. His research themes include implementation of science, like including access to medication, guidelines development, testing concepts and technologies in clinical trials, innovative therapeutic strategies, quality of life studies, and pharmacokinetic and other studies. All these are things which we can keep talking about, sir, and if we give a list of all his achievements, I think it will be forever. As a student, something that we all remember him for were his excellent remarks and his very interesting comments on patients. And this is something which we would be talking to him on the phone and telling him this case, he would say, just do this. And the first reaction of all the residents would be, what, why, and why did he say this? It would take us a while to actually understand that what he was talking about was the latest research on some paper that would have probably come a day before, and which we would understand after 10-15 days, oh, this is the reason why Dr. Sudeep had told us to do it. This ability to foresee what is the next generation and to understand before anyone else is a great hallmark of a great teacher and a great academician, which Dr. Sudeep is. I would just end with one small anecdote where I remember there was an international speaker, the PI of a trial came, and he started speaking and we listened, and then so Dr. Sudeep got up and said, it's a very good talk, I have a very small question. And the next 5 minutes later, the entire hall could not understand what statistics were being discussed there, because the depth of the discussion was kind of beyond us, and that's really the, again, mark of a great personality. Without further ado, sir, I would request you to kindly come and deliver the oration.
Good morning, friends. Thank you very much, Dr. Vamshi Krishna, for your very kind introduction. Before I begin, I would like to thank Dr. Vamshi and everyone who's organized this meeting for inviting me here. So I bring you greetings from all the hospitals of Tata Memorial Center. We are now located in 7 states of India, and you see our hospitals. So we were created in 1941 by the House of Tatas, but since 1962 we are with the Department of Atomic Energy. And as it happens, we are actually one of the 29 institutions of the Department of Atomic Energy, the Government of India. My gratitude to the AIG Hospitals for the privilege and honor of delivering this oration. In Latin, cogito ergo sum. In French, it is called Je pense, donc je suis. I think, therefore I am. So before you start accusing me of having turned into a philosopher, this was said by René Descartes, who was a 17th century French philosopher. Can we ever be certain about the truth of any belief? The unreliability of our senses and reason can lead us to doubt every belief. However, if I think and doubt, I must exist. Descartes attempts to rebuild all human knowledge from this first principle and establishes proof for the existence of, among other things, God. The epistemological lessons of cogito is that if certainty is a necessary requirement for knowledge, we are left with very little knowledge. The challenge, however, is that if certainty is not required for knowledge, then what is? And this was memorably captured in this wonderful movie more than 25 years ago, which is one of my favorites. I have also had the opportunity to ruminate over these things in a couple of editorials, and I will quote myself. The human affect is deeply antithetical to uncertainty and probabilities. Our species is more comfortable with certainties, including discomforting ones like death. And average individuals like you and I are not alone in our distress. Albert Einstein, no less, famously lamented that God cannot play dice. As it turns out, God does play dice. So Descartes was not only a philosopher, but he was a mathematician of the first order. And many of you will know the Cartesian coordinates that we routinely use in our work. And he connected the previously separate fields of geometry and algebra into analytical geometry. So ladies and gentlemen, I will share with you a few beliefs with the caveat that they do not satisfy Descartes' exacting standard of knowledge. Patients come to me for succor and solace before they want treatment. And I will again quote myself from another editorial that I wrote for our journal. There is an unforgettable sequence in the movie Cat on a Hot Tin Roof, and I'm not sure how many of you have seen it, but I recommend that you do. The Big Daddy character with terminal cancer refuses to accept morphine from his son. You get the pain and you know you are alive. The quest to live is the most potent emotion in humans. and it is sometimes difficult to endure when projected onto oneself from another. And many of us in the field of oncology will empathize with that sentiment. I believe that much of the intuition in medicine is the skill of integrating prior probabilities with the current information about the person in front of us. This is the Bayes theorem, and this is implicit, if not explicit, in the cognitive processes of all great clinicians. So let me come to the subject matter of my oration today: clinical and translational research in breast and gynecological cancers. And over the next about 35 or 40 minutes, I will share with you what we have done in our institution and in my group in these fields. So we try to research new treatment strategies, improved treatment delivery mechanisms, affordable technologies, population-based interventions, and translational research, all tested in robustly designed studies. This is an old cartoon, but a very important one. This shows the time-dependent influence of estrogen receptor status on prognosis. Estrogen receptor negative breast cancer has a higher initial peak of recurrence after surgery, but the risk of recurrence declines to very low levels once the patient survives for the first few years. Estrogen receptor positive breast cancer, on the other hand, while having a good overall prognosis, continues to have a reasonably substantial probability of recurrence far into the future. So in Tata Memorial Center, we have been very interested in researching both estrogen receptor negative and estrogen receptor positive breast cancer. This is an audit of a single year's data that we conducted more than 15 years ago, and we showed that almost 30% of our patients had a triple negative breast cancer, which is substantially higher than the proportion that is seen in many Western populations. We also showed that this was age dependent. The proportion of women with TNBC was much higher among younger women compared to older women. More recently, we tried to research the risk factors for triple negative breast cancer. So ordinarily, when you talk of epidemiological risk factors, all breast cancer is lumped into one entity, which actually is not how it should be. We showed that central obesity, as measured by the waist-hip ratio, seems to be associated with non-triple negative breast cancer, mainly ER positive breast cancer, while lower socioeconomic status was very tightly associated with triple negative breast cancer in this 1,000 patient study in 2 institutions in our country. Recently we presented, and then more recently, a couple of months ago, we published this randomized control trial of the use of platinum in patients with triple negative breast cancer in the neoadjuvant setting. And as luck would have it, this year has been the heyday of platinum in triple negative breast cancer. We have almost 4 to 5 studies that have more or less shown us how to use this drug in this particular disease. So what we did was to conduct a randomized control trial in 720 patients. The patients in the control arm received the standard neoadjuvant taxane anthracycline chemotherapy, while patients in the experimental arm received carboplatin in addition to paclitaxel as part of the neoadjuvant regimen. Now, what was different between our study and many others that have been reported, and the others were not phase 3 studies, they were phase 2, was that we used paclitaxel and carboplatin both in a once per week regimen. We reported the results with a median follow-up of more than 5 years, and you see the characteristics of these patients. These are really advanced stage disease while being non-metastatic. So almost 90% of patients had clinically node positive disease, and almost 80% had tumors that were larger than 5 centimeters. And this is different from the case profile that you see in the other studies that have been reported from Western countries. We showed that the pathological complete response was statistically significantly and clinically meaningfully higher with the addition of platinum. But very importantly, and much to our surprise, we found that the benefit of platinum in terms of pathological complete response was largely confined to either women who were young or those who were premenopausal, while postmenopausal or older patients derived no benefit whatsoever from this drug. Overall survival was the key secondary endpoint of our study, and we showed that there was a substantial and significant improvement in overall survival in the full study cohort, but again, the benefit was almost completely confined to younger or premenopausal women, and older or postmenopausal women had no benefit whatsoever. This is the test of interaction, and we see that the test of interaction between the benefit of platinum and either menopausal status or age was significant for both those covariates. We have speculated on the reasons why the benefit seems to be confined to younger or premenopausal patients, and that's in the full paper in JCO. But suffice to say that our results are very stark and clearly suggests that it is the younger patients who actually derive the benefit. This is the editorial in JCO that accompanied our study, and the editorialists, Dr. Miller and Dr. Yadav, actually seem to agree with our suggestion that perhaps it's a time to rethink the routine use of platinum in older patients, and that platinum should be routinely used in all premenopausal or younger patients. We were also interested in looking at the biological makeup of triple-negative breast cancer in our patients. So this is the work of my PhD student, and this was funded by the Department of Science and Technology as a grant to myself. We looked at the natural history of germline BRCA1 or BRCA2 mutated or wild-type triple-negative breast cancer in individual patients throughout their life course. So what we did was to sample the tumor and the corresponding blood from individual patients from the time of their diagnosis through to the time of their first relapse, second progression, third progression, through to the time of their death. And we collected this longitudinal series of both tumor samples from accessible metastatic sites as well as corresponding blood. And then we subjected it to high-depth sequencing using multi-omic assays, including SNP arrays for copy number analysis, whole exome sequencing, and then an ultra-high-depth sequencing of a somatic panel of about 1100 variants that was culled from the exome data. So I'll show you the results. The tumor mutational burden was on an average higher in metastatic sites compared to the same patient's non-metastatic diagnostic at the time of diagnosis tumor. We also looked at the mutational signatures, and all tumor samples from all patients throughout the life history actually retained the signature 3 and signature 13. So some of you know that there are these mutational signatures that are associated with the causation of cancer. So for example, tobacco-related cancers, ultraviolet-related cancers have different different gene signatures. So all tumors from all patients actually retained the signature 3 and signature 13, which are BRCA-related signature throughout their life course. Now this is the mutational profile from the tumor and the corresponding blood, the ctDNA from the blood at each time point. The upper panel is the somatic tissue and the lower panel is the ctDNA. And you will note that ctDNA presents or represented a more complete profile of the mutational burden of the patient compared with the corresponding somatic solid tumor biopsy. And that stands to reason because you can biopsy potentially only 1 or 2 of the many different metastatic sites that the patient might have, whereas the blood is a sink where all metastatic sites will actually release their ctDNA into. We also constructed the clonal map of all these tumors longitudinally in individual patients, and you see the pink clone here, that is the mother clone or the stem clone that persists throughout the life history of triple negative breast cancers in these patients and is not extinguished by repeated treatments of different kinds. It gives off daughter clones at various time points after the patient has received several treatments. These daughter clones actually arise and then get extinguished, but the stem clone persists throughout the life history of these tumors. This suggests to us that the mutations that comprise the stem clone actually confer resistance not only to the initial treatment, but to all subsequent treatments that one might throw at the patient. The mutations that comprise the stem clone continue to be expressed at a high level compared with the mutations that were in the daughter or the subclones at all time points during clonal evolution. This paper was published in the Journal of the American Association of Cancer Research, and this analysis gave us a significant insight into how and why tumors actually either derive resistance or are ab initio resistant to many different treatments that we routinely use in the clinic. There's another chain of thought that we have had in our department for a long time. Most of us believe that surgery is a physical act. The surgeon removes the tumor and sends it to the pathologist. But we have been interested in the molecular perturbations that happen in the tumor during the act of surgery. So, can we modulate some of these molecular perturbations that happen in the tumor during surgery? And can we exploit the perioperative period for long-term outcomes? So we performed 2 studies, one in breast cancer, the other one in head and neck cancer or oral cancer. And we sampled the tumor at the beginning of surgery, in the middle of surgery, and at the end of surgery. The tumor at the beginning of surgery is fully vascularized, fully oxygenated, as much as it can be. The tumor in the middle of surgery is derived from a tumor that has approximately been devascularized in half, and the tumor and the sample from the tumor that is already out of the body is from a fully devascularized tumor. And then we subjected these 3 samples from each patient to high depth RNA sequencing. So we performed RNA-seq at 50 to 100 million reads per sample paired end sequencing. We performed a companion study in oral cancer, and there we performed the gene expression profile using microarray. So let me just summarize the results of these studies. We found that even during those 60 minutes that the surgery was being performed, the genes involved in inflammation, epithelial mesenchymal transition, hypoxia, and immune surveillance escape were significantly deregulated. Some of them upregulated, others downregulated, even during that 60-minute period. The genes belonging to the AP1 transcription factor network. So some of you might know, but many of you might not, that the AP1 FOS-JUN family of transcription factors actually confer survival advantage on the cells. They were consistently deregulated during surgery, and this deregulation was organ agnostic. In our study, we found it to be true in breast cancer and in oral cancer. We also looked at the TCGA data where a similar experiment has not been done, but for each cancer in the TCGA, some samples belong to the diagnostic biopsy, other samples belong to the surgical specimen. So they correspond to sample A or sample C of our study, and we compared within each cancer those 2 samples, and we found that the same findings, identical findings, were present in esophageal cancer, cervix cancer, and in many other cancers. This was also found in the surrounding normal tissue. Now, most of us also know that the routine gene expression profiling studies that we do are either done on diagnostic biopsy or on the surgical specimen, but not on both. And so therefore, our results do have implications for tumor biology and how our studies are carried out. This was the work of my second PhD student. This was also published in the Journal of the American Association of Cancer Research, Molecular Cancer Research, last year, and it has received widespread publicity as well as significant attention. What are the clinical implications of these findings? This is a review article from Nature Cancer Reviews 2018, and here the reviewers have very nicely suggested what are the mechanisms by which surgery can confer stress on the tumor and how this surgical stress might actually stimulate the metastatic cascade. So what we also did was another randomized control trial. This was also published in the Journal of Clinical Oncology, where half the patients just prior to their surgery received the local anesthetic drug lidocaine all around the tumor, and the other half just underwent routine surgery. The reason why we use lidocaine was that it blocks the voltage-gated sodium channels and is downregulates some of the findings that we found in our perioperative tumor study. And again, both for disease-free and for overall survival, as well as for local and distant recurrence, there was a statistically significant and clinically meaningful improvement in survival with the lidocaine all around the tumor. This was the editorial that accompanied our paper in JCO, and Dr. Mittendorf and her colleagues seem to agree with us that this could be a useful intervention to reduce the long-term recurrence rates in breast cancer patients. So I told you that estrogen receptor positive breast cancer continues to have a substantial risk of recurrence in the long run. I coordinated and conducted a study with colleagues from 4 other institutions funded by the Department of Biotechnology, and this was multi-omics analysis to decipher mechanisms of hormone therapy resistance in breast cancer. And my collaborators were from ACTREC, the National Institute of Biomedical Genomics in Kalyani, the National Center for Cell Sciences, and the KIT University in Pune, and the Institute of Bioinformatics and IIT Bombay for the proteomics. So what we did was to sample tumors that were proven to be endocrine therapy sensitive and endocrine therapy resistant, and this was by accepted international definitions of resistance and sensitivity. And I'm not sure whether you can read in the small font there, but we subjected these tumors and the ctDNA to whole exome sequencing, whole genome sequencing. We created patient-derived xenografts from these tumors, and we also conducted eye-track proteomics on these samples. So let me share with you some of the results. We performed a ctDNA analysis of patients who had endocrine therapy resistant and sensitive disease. This was published a few months ago in Breast Cancer Research and Treatment. We were able to perform ctDNA on minimal quantities of circulating nucleic acid. This was a custom designed in-house performed assay. We carried out the entire extraction of the ctDNA and its sequencing in-house in ACTREC. We found that about 60% of the patients had potentially actionable alterations. I'm not going into the details of all the results because of the paucity of time, but let me share with you the fact that again, as with the TNBC, we had 20 patients in whom we had paired samples from the time of their initial diagnosis and at the time of relapse, and we again found branching evolutionary pattern of clonal evolution in these patients, and the stem clone in almost 2/3 of these patients comprised of either PIK3CA or TP53 or both. And very importantly, in 19 patients who had just received surgery for and adjuvant treatment for their non-metastatic breast cancer were in remission at the time that we collected their blood sample. In 10 of these 19 patients, we found driver mutations in about half of them, and of these 10 patients, after we enrolled them in our study in the subsequent months, 2 of them actually suffered a relapse. So this again suggests to us that ctDNA can actually anticipate clinical and radiological responses in many patients with ER positive disease. But of course, the ability to pick up a relapse early, even with an ultra-sensitive technology like ctDNA, is not equivalent to being able to do something about it. That, of course, is another question that needs another study to decipher. So in collaboration in the same study, with our colleagues from the National Institute of Biomedical Genomics in Kalyani, we performed high-depth whole genome sequencing. This is the largest study of whole genome sequencing from tumors in India to date. So 20 patients with resistant disease, 20 patients with sensitive disease, we tried to find out what are the genomic correlates, and this was published in Communications Biology earlier this year. And I will walk you through the results. They're not very difficult. On your left are sensitive patients, and on your right are resistant patients. So with respect to the total mutational burden, there is no difference between resistant and sensitive tumors. With respect to expressed non-silent mutations, there is a substantially higher mutational burden in resistant tumors compared to sensitive tumors. With respect to structural variants such as deletions, duplications, etc., again, the number is higher in resistant tumors compared to sensitive patients. The telomere lengths are much shorter in resistant tumors compared to sensitive tumors. And if you look at the copy number variation, that is much higher in resistant compared with sensitive patients. So we actually found out a 3-gene signature of PIK3CA, ESR1 and P53, which conferred resistance in these tumors. We found that the tumors that were destined to be resistant, they had impaired DNA repair mechanisms, primarily homologous recombination pathway, and there were features of genome instability like high copy number variation, telomere shortening, and chromothripsis in the resistant tumors compared with the sensitive tumors. We also found that the survival of patients who had the resistance signature was much shorter than those of patients who did not have this signature. We, as part of the same study, we collected the live tumor from 28 patients, and we constructed patient-derived xenografts in ACTREC. And you can see that these are all the patients from whom we have collected the tumors. There were 28 of them. We were finally able to construct the patient-derived xenografts in 4 patients. And believe me, if some of you have done patient-derived xenografts from slow-growing tumors like ER-positive breast cancer, it is not easy, it is extremely painstaking. So these are some of the xenograft models, and they are growing well, and they can be sustained beyond the G3 or G4, the 3rd or the 4th generation of mice. And the tumors in these 3rd or 4th generation of mice very faithfully recapitulate the original patient's tumor. So here you have a virtually inexhaustible supply of endocrine treatment resistant tumors from 3 patients and endocrine treatment sensitive tumors from 1 breast cancer patient in these 4 patient-derived xenografts in ACTREC, and many of my colleagues from ACTREC, from Tata Memorial, and also from a couple of other institutions are now regularly accessing these tumors for their both biological studies as well as to test drugs. The last bit of this DBT-funded study was the proteomic analysis of resistant and sensitive tumors. So we had originally planned this with the Institute of Bioinformatics in Bangalore, but it did not happen with them. So we collaborated with IIT Bombay to do this. And this paper is the last paper of the series. It is under communication just now. What we did was again to take tumors from 20 resistant and 20 sensitive patients and subjected it to eye-track proteomics. And you can see that there were 178 proteins that were significantly different between the resistant and the sensitive tumors, and 17 of these 178 proteins were able to cleanly segregate the resistant from the sensitive patients. So if you looked at the expression of these 17 proteins either up or down, you could put the samples into one of these 2 buckets. Now the 17 proteins are listed on the slide. What we found that these proteins belong to some of the known signaling pathways that are known to be deregulated in breast cancer. Very importantly, some of the downregulated proteins were the ones that were involved in the structural integrity of the extracellular matrix. So if you have these proteins that are downregulated, if the structural integrity of the matrix becomes compromised, then you can imagine that it stimulates or facilitates the metastatic cascade. Now, one of the proteins that was the most highly significant in the survival analysis from the corresponding TCGA data is a protein called ACO2. It is called aconitase 2. And if you remember your biochemistry, it is the enzyme in the Krebs cycle that facilitates the conversion of citrate to isocitrate. And this is involved again in cell survival and confers metabolic resilience on the cells. So we believe that this is a very useful and important target. Of course, while targeting this in the tumor, one should not have off-target effects, but that remains to be seen. So with the help of this DBT study, DBT funded study, we were able to decipher some of the known some of the mechanisms that are associated with resistance to endocrine therapies. So the last bit of research that I will share with you is the fact that there are some very useful treatments, but they are useless if 99% of our patients cannot access them. Now, some of you know that trastuzumab is now a very affordable drug, or a reasonably affordable drug, but it used to be very expensive until about 8 or 10 years ago. We conducted an audit in 2 years of our patients, and we found that only a small minority of our patients had access to this drug in 2009, and that increased to about 60% in 2016. In collaboration with our colleagues from PGI Chandigarh, we conducted a cost effectiveness analysis, and this is as per the prices of biosimilar trastuzumab about 3 years ago. The full 1-year protocol was not cost effective at the then prevailing prices. I think it has now become cost effective. So now we have recommended to the National Health Authority to include the full 1-year protocol as part of their treatment. So the question was whether a shorter duration of trastuzumab was acceptable. And many of you know about this analysis. The reason why I'm showing you is not merely to show you the results, but to tell you that our group actually pioneered this method of individual patient data meta-analysis, where we extracted individual patient times and events from published survival curves, even without getting the raw data from the principal investigators. And we were able to then reconstruct the survival curves, recombine the data, and do that individual patient data meta-analysis. And of course, we showed that the shorter durations of trastuzumab were non-inferior to the full 1 year, at least for some low to moderate risk patients. And at least until recently, based on our results and the cost effectiveness analysis, that was what was recommended as part of the Ayushman Bharat. We have subsequently conducted 2 other meta-analyses in ovarian cancer, one with PARP inhibitors in the first line, the other one with secondary cytoreduction. And we have again sort of produced results that are clinically actionable as well as meaningful. Now, of course, after we first published the trastuzumab meta-analysis, there are a number of other reports by other groups that have used the same methodology of extracting individual patient survival times and events from published curves and recombining them for meta-analysis. In passing, I will say that our group has also produced meaningful results in cervix cancer. This was the study that was presented at ESMO and then published in JCO, where we showed that concurrent chemoradiation produced better results, superior survival results compared with neoadjuvant chemotherapy followed by surgery. Now, these are not only results. Subsequent to the publication of our results, the guidelines were changed by ESGO, ESMO, Latin America, and many parts of the world where neoadjuvant chemo and surgery were being routinely practiced. We also more recently showed that intensity modulated radiotherapy resulted in clinically meaningful and statistically significantly lower toxicity compared with 3D CRT. And this was again published in JCO. So let me end, and I will share with you a few thoughts about mathematics, beauty, biology, and disease. So when you take 2 numbers, you add them up, and when you take the ratio of the sum to the larger number and the ratio of the larger number to the smaller number, and when both of them are 1.62, it is called the golden ratio. So for example, on the right, If you have 61.8 and 38.2, they add up to 100. If you divide 100 by 61.8, it is 1.62. And if you divide 61.8 by 38.2, that is also 1.62. This is called the golden ratio, and not without reason. There's another series of numbers called the Fibonacci sequence. The first two numbers are 0 and 1. Each subsequent number is derived by adding up the two previous numbers. So it is 0, 1, 1, 2, 3, 5, 8, 13, 21, 34, 55, 89, and so on. And some of you who have conducted early phase clinical trials know that the dose escalation happens by the modified Fibonacci sequence. So the reason why I'm sharing with you is that there is another property of these Fibonacci numbers beyond the first 3 or 4 numbers, that the ratio of the next number to the previous number is also the golden ratio, 1.618 or 1.62. And the reason why this is interesting is that the golden ratio and the Fibonacci numbers seem to be widespread in nature. So the numbers of petals in a leaf, in a flower, the leaves that sprout from the stem, all of them seem to follow the Fibonacci sequence or the golden ratio. So let me then bring you to this article in NEJM about 10 years ago by Mike Baum. And some of you know that Michael Baum is a doyen of breast cancer surgeons from UK. Why does the weeping willow weep? And on the right is a picture of the English weeping willow, and I will quote Mike Baum. If you look at the weeping willow tree in my front yard and measure its branches and feathery hanging leaf clusters by extending your arm and holding up a pencil, squinting one eye, you will find that the ratio between the lengths of the proximal and distal branches at each bifurcation is the same as that of the length of the trunk to the length of the first branch, approximately 1.62. This also holds for second, third, and fourth order branches. So this is the golden ratio, and this repetitive golden ratio at ever smaller scales is an example of what is called fractal geometry. So fractals are a complex geometric pattern that repeats itself at infinitely smaller scales. It exhibits self-similarity, meaning that each smaller part essentially recapitulates the whole. And this property makes fractals visually captivating and mathematically intriguing. So this is a whole slide mount of a breast, and as by now you might imagine, the lobules and the lobular structure of the breast also follows a fractal geometry. This is a 3D rendering of a high-resolution CT scan of the chest, and as it turns out, in this picture the pulmonary vasculature, but otherwise also the pulmonary bronchial tree also follow the fractal geometry along with the golden ratio and the ratio of the first order to the second order to the third order. It turns out that breakdown of fractal geometry and organizational beauty of the tissue is an early event in cancer, and pathologists have long recognized it. The more distorted and ugly looking the tumor on gross, the worse is the prognosis. So the question is, can we mathematically model the breakdown of symmetry and fractal organization to peep into the origins, prognosis, and patterns of recurrence in cancer? And this is a thought that I will leave some of you with. Let me end with this story. This guy is Stephen Jay Gould. He was an American philosopher, mathematician, and paleontologist. He worked at the Harvard University. He was diagnosed with peritoneal mesothelioma in 1982. And that time, his doctors told him that the average survival is about 8 months. So let me quote him. He wrote a very famous article that I will show you in the end. I immediately recognized that the distribution of variation about the 8-month median would almost surely be what statisticians call right skewed. After all, the left of the distribution contains an irrevocable lower boundary of 0, but the upper or the right half can extend out for years and years. And then he goes on to say, by his reading from the library of Harvard, that that the distribution was indeed strongly right skewed, with a long tail, however small, that extended for several years above the 8-month median. I saw no reason why I shouldn't be in that small tail. And ladies and gentlemen, Stephen Jay Gould eventually died in 2002, not of mesothelioma, but of a second cancer, lung cancer. And this message is in this famous article that I very much recommend that some of you read. The median isn't the message. So statistical averages, the reason why I told you, or why I shared this story with you, is that these days our conferences are full of medians and you know what, and comparison of the medians. So they are statistical averages, useful abstractions, but by themselves do not encompass our actual world of variation, shadings, and continua. So I would like to thank many, many collaborators who have been with me throughout my journey, both in clinical medicine as well as research. Not all of them are listed on the slide, but I'm very grateful to them. I'm also very grateful to my institution, without which I would be nothing. It has enabled not only me, but numerous colleagues over generations to express themselves and to do what they wish to do and to contribute to our society. And I also strongly suggest that you visit the Metropolitan Museum of Art in New York on your next visit to that city. Thank you very much for your attention.
Thank you, Dr. Gupta. Ladies and gentlemen, it is now our privilege to proceed with the felicitation of our esteemed orator, Dr. Sudeep Gupta, in recognition of his exemplary contributions to medical oncology research and academic excellence. May I now request to do the honors, may I respectfully invite Dr. G.V. Rao, sir, Director, AIG Hospitals, Chief of Surgical Gastroenterology, onto the stage, sir. May I also request all our oncology doctors on the stage. Thank you. May I now request Dr. Avinash Bonda onto the stage to deliver a vote of thanks.
I mean, being a student, it is phenomenal. Still the hairs are on the end, so it was quite overwhelming. Thank you very much, sir, Dr. Sudeep Gupta, Professor Dr. Sudeep Gupta, for visiting us and allowing us and giving us this opportunity to host you and listen to you. It was reminiscent of all the years that we actually spent in TMH when you were our prof and then we were your students. So thank you very much, sir. At the outset, I also want to thank our chairman, Dr. D.N. Reddy, sir, our vice chairman, Dr. Raju, and our director, Dr. G.V. Rao. Thank you, Sandeep, sir, for visiting us, and thank you very much. All the delegates, the dignitaries, and everyone, thank you very much for attending this inaugural function. And I would like to announce that the lunch is probably ready, and after that we will continue with the academic feast. We have lots coming up in the afternoon in terms of sarcoma and the genetics workshop with the entire breast portfolio tomorrow morning. So thank you very much. Please enjoy the lunch. Thank you.
Ladies and gentlemen, just a quick update. We will now be breaking for lunch. I request all the faculty members to kindly proceed to the 5th floor of Tower A Library Lounge. All delegates are requested to have lunch in the pre-auditorium area, right outside the auditorium. Additionally, I would also like to inform you all about this genetic workshop which will be held at 2 p.m. on the 10th floor of Tower A. Thank you.
అక్కడ అక్కడ మరి మనకైతే తెలియదు మరి.
వచ్చింది కదా దాంట్లో క్లియర్లీ రాదు చాలా
Good afternoon, one and all. Welcome back for our second half of Cancer Summit. I am Shumana Kail.
And I'm Naimrachi Mok.
I'm sure we are all now energized the sumptuous lunch. Moving forward, I cordially invite our chairperson, Dr. Sanjeevi Kumari and Dr. Ashwin Shah to grace the dais. For the first keynote lecture, may I call Dr. Siddhartha Laskar to present the topic, Evolving Role of the Particle Therapy in Sarcomas, and sir, please request to you stay back after presentations. Thank you, sir.
Okay. Thank you very much. Thank you, Kaushik, Sujanna, Nandita, and the entire team of AIG for the invitation to be here today. First of all, congratulations for this wonderful institution that you are working in and the kind of work that you are doing, I saw in the morning. So Kaushik asked me to choose a topic of my choice, and I think the most appropriate topic I thought would be proton therapy, because I know that you are also on the path of having a proton therapy facility here. So, and this is a sarcoma session. So what I'll do in the next 15-20 minutes is to look at what is the evidence that we have to support or refute the use of proton therapy in sarcomas. I'll restrict my discussion to osteosarcomas, chondrosarcomas, chordomas, and soft tissue sarcomas, and I'll leave behind rhabdomyosarcoma in this discussion today. I know there may be surgeons here today. So what is the big thing about particle therapy or proton therapy? So there are two things. There is a physical and there is a biological benefit of proton therapy. And if you compare protons with X-rays, the big benefit is the Bragg's curve that we keep bragging about. And because of this physical property, we are primarily being able to spare the surrounding normal structures, and because of which we expect there would be some amount of benefit. But besides the physical benefit in terms of conformality, there is probably also a benefit in terms of biology. Although we consider protons to be almost equivalent as photons, but I think there is some potential biological advantage of protons when we compare with photons, and I will highlight that as I speak, as I go along the talk. So what are the clinical implications of this conformality that we are talking about? Because we are able to conform to the target volume better, we hope that we would be able to reduce acute toxicities, late toxicities, and because we are able to reduce the dose to surrounding structures, we may be able to escalate doses and have better disease control. We may be able to do hypofractionation. It could be useful in re-radiation, and of course, finally, better disease control and a better therapeutic gain. One big thing that we've been talking about in protons is about the late toxicities and the incidence of second cancers. Although we do not have large, robust data to support it, but there is some evidence that has come which I'm going to share with you. And of course, finally, there are some aspects of immune modulation and cell kill that people are talking about with protons. So bone sarcomas that I'm going to talk about to you today is Ewing sarcoma, osteo and chondrosarcomas, and chordomas. They are seen in both age groups. Ewings and osteos are seen in the younger age group, and there's a second peak also as in the late teens and adulthood. Chondrosarcomas and chordomas are seen in a slightly older age group, and as you can see from this plot, they form a very, very small proportion of the total number of malignancies that we've seen in both adult and pediatric age group. And that is why we do not really have robust clinical trials to answer questions that we are looking for. If you look at this graph from the National Cancer Database from the US, there has been a steady increase in the use of proton therapy for sarcomas. And there has been a significant steep rise from 2015, 2016 onwards, where the number of proton therapy machines have been expanding, and the indications, if you look at the ASTRO guidelines also, soft tissue sarcomas is currently included as one of the indications that have been reimbursed in the United States. This is data from the Proton Therapy Cooperative PT-COG from the PROS database and the European Proton Therapy Network database. And if you look at the pediatric age group, you would see that most patients with chordomas, chondrosarcomas, and a large number of rhabdos, Ewings would be treated with proton therapy, and that would be the recommended treatment in children as of today. So let us see what is the evidence in Ewing sarcoma. Now, this is the second most common primary osseous tumor in children, and almost 65% of them are seen in the second decade of life. The pelvis and the spine are the most commonly involved sites, and these are difficult for surgery. And these are also sites where delivery of radiation therapy is challenging without causing significant toxicity. So the standard treatment for Ewing sarcoma includes combined modality chemotherapy, which would be followed by local treatment. And the preferred local treatment as of today would be surgery with or without radiation therapy. And if you look at the large cooperative group trials, what is the proportion of patients who undergo surgery? It's almost about 40% of them. Another 30% would have surgery followed by post-operative radiation therapy. And about 30% of them would be treated with radiotherapy alone. So almost 60% of our patients with Ewing sarcoma in the large cooperative group trials would be treated with radiotherapy. Now let us see what happens with the outcomes. The graph on your left are patients who are treated with surgery. On your right are the patients who are treated with radiation therapy. And if you look at the outcomes in terms of systemic relapses, there is not much difference between these two groups. That is a very important message. The second thing, the incidence of second malignant neoplasms in this large group of patients is not really different between the patients who are treated with surgery versus the ones who are treated with radiation therapy. The only difference that is significant is that the local relapses are higher in the patients who were treated with radiation therapy. And how high are they? If you look at definitive radiotherapy, it's almost about 15 to 20% local recurrences after definitive radiation, and all kinds of other treatments where you have either surgery alone or a combination of surgery and pre or post-operative therapy, the recurrence rates are anywhere between 5 to 7%. So that's the kind of statistic that we are talking about. If you go from Europe to the United States and in children, you would see a pattern. And why is it that radiation therapy results in inferior outcomes? Is it a poorer treatment modality for local treatment? Probably not. And that is seen because all patients who've got tumors involving the pelvis or the spine would primarily be treated with radiation therapy, whereas patients who've got diseases involving the extremities and small tumors would undergo surgical resection. And that is the reason you see a difference in the outcomes in terms of local control between radiotherapy, surgery, or a combination of surgery and radiotherapy. And expectedly, the outcomes with surgery and radiotherapy would be better than the ones who had radiotherapy alone, because these were the patients who had large disease, unresectable disease, and with poor prognostic factors. If you look at Euro-Ewing data again, the same kind of outcomes that you can see, 5-year local recurrence rates, the ones highlighted in green. With local radiotherapy, the local recurrence is at 5 years is 40%, with surgery alone is 33%, and the best outcomes in the Euro-Ewing study came from a combination of surgery and radiotherapy. And the same results actually translate into an improvement in event-free survival and also overall survival. So do we have radiotherapeutic strategies to improve these outcomes? One of the things that we can do is escalate dose. And this is one data came from the US, where tumors larger than 8 centimeter in size were receiving 64 gray instead of the standard 55 gray of radiation. Less than 8 centimeter tumors would get 55, and the patients with the R1 resection would get 50.4 gray. And as you can see, the local control rates, local failures at 10 years was 4.4%. And the patients who received a dose of 64 gray had no local recurrences. So this gave us a hint that probably escalating doses actually improves local control. So we did a randomized clinical trial to try and prove whether escalating doses of radiation therapy in unresectable Ewing sarcoma does improve outcomes. So we wanted to use an escalated dose of 70 gray instead of the standard 55 gray for unresectable Ewing sarcomas. And we proved that after a follow-up of almost 60 months, the local control rates improved from 59% to 76%, which was statistically significant. And this was the first randomized clinical trial ever to show that there was an improvement in local control with escalated doses of radiation. Similar kind of outcomes were seen from another study from the Euroewing database, where they saw that increased doses of radiation above 59 gray actually improves local control. And there was another study from St. Jude Children's Hospital, again, where they showed that escalating doses improves local control. But there is a worry. If you increase doses of radiation, there is also data to show that there is an increase in the incidence of second cancers. And this was seen in the study in Ewing sarcoma, where they showed that more than 60 gray of radiation does increase the incidence of second malignancies. Do we have the same data that could be reproduced elsewhere? This is data from a systematic review, which again showed that the incidence of second cancers was about 8% at 5 years, which could increase to about 20%. But could we attribute this to radiation therapy? Now, this is the more recent Euroewing trials data of about 4,500 patients. And this is very interesting. And this is important when you are discussing radiotherapy versus non-radiotherapeutic modalities in Ewing sarcoma. And this showed that the incidence of second cancers is about 2.1%. And there was no difference in the incidence of second malignancies based on whether you treated the patient with surgery versus radiotherapy as the treatment modality. So, coming to the question, with these kind of results, can we improve outcomes in Ewing sarcoma with protons? Now, we do not have randomized clinical trials, but this studies, these are single-arm retrospective reviews and reports, show that the local controls with standard dose of radiation with proton results in local controls of about 80 to 85%, which is extremely good local controls. Similar outcomes for axial skeleton and the pelvis. With the standard dose of 55 gray, the local controls reported at 5 years was 81% from Paul Scherrer Institute using protons. The toxicities were not higher than what we had documented earlier. Again, more data from Jacksonville and US. Again, standard dose of radiation of 55 gray. The 3-year local control rate was 92%. So all this data shows that the local control rates, when you treated with definitive radiotherapy with protons, the local control rates were above 80% and 90%. So that is extremely, extremely good. And that is the reason I said probably there is something to do with the biology with proton therapy when you compare with photons. More recent data from Florida, same for paraspinal disease, 50 gray of radiation, 5-year local control rates of 92%. So these are kind of unheard of even with surgical resection. So there is something that happens with proton therapy that is probably not happening with photon radiotherapy. In children, this is from the European group from Germany. Again, a slightly escalated dose of radiation, 4-year local control rates of 80%. And similar data that has come from a combined group published more recently, again, the same outcomes, 4-year local controls of 82%. So all these studies of protons that I showed you, these are non-randomized trials, single-arm studies, but they are all reporting 4 to 5-year local control rates of 80% and above, which is very, very good. So there is also some interest in using preoperative radiation therapy in pelvic Ewing sarcomas using protons. And data from Birmingham shows that using proton therapy as preoperative therapy for pelvic Ewing sarcomas actually improves outcome with the same doses of radiation. So currently there is a lot of interest in using preoperative proton therapy for pelvic Ewing sarcomas that are resectable. What about osteosarcomas, chondrosarcomas, and chordomas? These are radio-resistant tumors, and they require high doses of radiation in the range of 70 to 75 gray. And they are at challenging sites like the pelvis, paravertebral, and the base of skull. Very difficult to deliver that dose of radiation. When we didn't have proton at our center, we tried to escalate doses to 72 gray. So our standard was to use 72 gray using helical tomotherapy when we had it at that time. For osteos, we used to do 70.2 gray, and chondrosarcoma also 70.2 gray. Our outcomes that we published a couple of years back, 3 or 4 years back, for chordomas, our local control rates was 75% with photon radiotherapy, and we did not have significantly high complication rates. What about data from other centers in children? These are small series, not randomized, delivering doses of anywhere between 70 to 74 gray, 5-year local control rates for chordoma that they have reported as 81%. So all these seems very, very good and very, very encouraging. And these are reports from, again, another report from Mass General Hospital reporting 5-year local control of 70%. In Clivus, in the cervical spine, with a 73 gray, the local control of 85%. There were very few patients who actually had more than grade 2 or grade 3 toxicity. So the toxicity was not high. The local control rates, we are talking about 80% in all the base of skull chordomas and the peripheral chordomas. Dose escalation is important. In chordomas, if you are compromising the dose, there is data to show that if you're using doses less than 70 gray, the 5-year overall survival is lesser compared to the patients who had doses more than 70 gray or equal to 70 to 72 gray. So it is important to be able to maintain that dose intensity, dose levels, if you want to achieve good control rates. Now, this was a more recent meta-analysis that was published of a large number of patients from well-conducted single-arm studies where they showed the local controls at 5 years and 7 years to be in the range of 70 to 77% and overall survival of 80 to 89%. And the grade 2 and grade 3 toxicities were very, very few. So the message from the global message regarding definitive radiotherapy with protons for chordoma and chondrosarcoma is that for non-resectable disease, you could achieve a local control of 70 to 80% with definitive radiotherapy with protons. What about survival outcomes? Is there data to show that use of proton therapy, when you compare with photons, there is an improvement in survival? Because we always tend to discuss that survival is the main endpoint. And this very recent data, which was published in September last year, comparing the outcomes of sarcoma using protons versus photons in both adult and pediatric age group, there is data to show that chordomas, chondrosarcomas, rhabdomyosarcomas, and some other soft tissue sarcomas, there is an improvement in not only local control, but there is an improvement in overall survival. The last part is on soft tissue sarcomas. There are some dosimetric studies where they looked at the ability to spare the surrounding non-target soft tissue using protons and also the bone-related complications that would probably reduce with the use of proton therapy. And this is a dosimetric comparison of the same. You can see that the CTV coverage with protons and photons are primarily the same, but there is a greater ability with protons to be able to reduce the dose to the non-target soft tissue and also the bone. Based on that, there are studies now. People are looking at hypofractionating proton therapy as preoperative treatment for soft tissue sarcomas. This is an ongoing study called PRONTO, and the accrual is going to end sometime late of 2026 and early 27. People are looking at how the outcomes would be. And the dose of radiation that they have used with protons is 5 fractions of 6 gray per fraction, so 30 gray and 5 fractions with hypofractionation. So we set out by saying that probably protons, because of the lesser spillage of dose in the surrounding area, you would be able to reduce second malignancies. So this is a large database of 9,71,000 patients Some treated with 3D conformal, 1,51,000 patients. IMRT, 2 lakh patients. And proton beam therapy, 5,000 patients. So let us see what happened in them, comparative risk of second malignancies. So if you look at the chart on the right, and you look at the bone and soft tissue tumors, there is a clear indication that proton beam therapy actually tends to probably reduce the incidence of second cancers compared to photon. So there is some evolving evidence to tell us that proton therapy probably is beneficial in terms of the risk of second cancers. So to end, I would summarize by saying that radiation therapy still contributes significantly in local disease control for sarcomas. Almost 30 to 40% of patients of all histological subtypes would probably require radiation therapy, either as a post-operative means or a definitive treatment. The delivery of radiation therapy in these patients is challenging because these are radio-resistant tumors and you need to escalate doses to high levels, and that could be associated with significant toxicity if you were not able to spare, and that's where proton may benefit. Definitive radiation therapy, when compared with local surgery, definitely results in better functional outcomes compared to surgery. Dose escalation does help, we saw that. There is some evidence to tell us that using protons probably compared to photons would reduce the possible chances of second malignancies, but we need to wait for a longer time. We do not really have studies directly comparing the quality of life and functional outcome when we are doing photons versus protons. That is one area that we need to look at. And having said that, with all the good things that we see in protons, the good conformality, disease control, lesser toxicity, probably lesser second malignancies, we still have certain uncertainties in the form of dosimetric uncertainties. And of course, finally, the cost of treatment is high. And at the current moment, we need to choose our patients appropriately. And it's not that every patient would benefit. And the challenge is to be able to identify which are the patients who would truly benefit with proton therapy. So with that, I will stop. Thank you very much. And this is the Proton Therapy Center at TMH. We started treating our patients since August of 2023. We've treated almost about 800 patients now. And we treat all sites. The major site being treated with protons at TMH is CNS, and that is followed by bone and soft tissue tumors and pediatric tumors. But we are also using protons for head and neck tumors, for GI malignancies, for urology, for prostate, and we are also treating lung tumors with protons. So, we have already initiated a few randomized clinical trials. We have 3 ongoing randomized clinical trials currently ongoing for CNS, head and neck, and GI. We have another 3 or 4 randomized clinical trials coming up. And I'm sure as we move on and once AIG is also on board, probably we'll be able to expand and have multi-center trials and answer some questions which are still unanswered. So with that, I will stop and thank you very much once again for the invitation, Kaushik. Thank you very much.
Yeah, we have time, so we can have questions from the audience, please. Siddharth, this was a fantastic, man. You made many things very clear. We are not still exposed to the proton therapy in Hyderabad so far. We're expecting 2 protons coming up very soon in 2 or 3 years. I think that's quite a eye-opening for us. Thank you.
Thank you. I'm sure if you ask me one word, is proton there to stay? You can be rest assured it is there to stay.
Cost is the only issue.
Cost will come down. Cost will come down. Yeah. You know, Kaushik is so smart that actually I take his advice to what to do right now. So so if you ask me, see, in a government center, like if you ask me, of the 800 patients that we have treated at Tata Memorial Hospital till date in the last 2 years, 35% of those patients have been treated 0 cost, no cost at all. Okay, and the remaining, Our charges are, for the general patients who pay, it's 5 lakh rupees. All those patients who are supposed to pay 5 lakhs actually don't pay anything. We pay it. The private patients, we charge 15 lakhs, 1.5. It's a one thing cost, 15 lakhs. And the foreign category patients, we charge them 25 lakhs. So that's the kind of thing. And I can tell you, I'm not going to reveal the numbers, but I can tell you that my CMC and my operational costs are already covered by the revenue that is being generated with the model that we have been following right now. Actually, it's way more than that we are doing. So if you ask me, do we have the bandwidth in our country to do it? 100% we have the bandwidth to do it. It all depends on us choosing the right patients. But it is clearly there. And I can give you the numbers. I'll not announce it here.
Do you practice preoperative chemoradiotherapy or only preoperative radiotherapy
for sarcomas?
Yes.
Yes, we do. So we are for the soft tissue sarcomas, we were traditionally very brachytherapy even now. So that's why we don't do preoperative radiotherapy as the West would do. Ewing's, as I showed you, this group from Birmingham, they have shown that proton therapy for some reason results in better local controls compared to photons with the same dose for pelvic Ewing sarcomas. So we are currently looking at doing preoperative proton therapy for pelvic sarcomas. So we are looking at that. So that would be one of our studies that we will initiate soon.
Days we are hearing about this lattice radiotherapies.
Lattice, my group, we are not doing. Lattice was originally being used for palliative treatments. There is a group in our institute where they are interested in doing lattice. We are doing lattice, but it's not, that we have a huge experience of doing lattice therapy. People have shown interest, but personally, yes, we haven't been doing it. And even in places where they are using it, they have traditionally used it for palliating large sarcomas, things like that, and it's a good modality for palliation. And if you want to escalate doses to things, but now we got so many modalities to, But yes, that's another area of research. I know there are many people who are actually doing it. There is a group from Varian actually. They have a study that is going on for lattice. So oligometastatic sarcomas you're talking about? Yeah. See, in oligometastatic sarcomas, there is definitely a role of local treatment. If you ask me whether you should go palliative for all oligometastatic disease in sarcomas, the answer is no. Do we have evidence to say that what is the best form of local therapy for oligometastatic disease? Actually, there is a study where they compared surgery versus radiotherapy for oligometastatic pulmonary metastasis in soft tissue sarcomas. And what was seen is that the outcomes, the overall survival, was actually better in the patients who were treated with not protons, but photon radiotherapy. So yes, we do not. But I mean, it's not a single factor. These are multifactorial. In Ewing sarcoma, if there is a relapse, if there is multiple sites of disease, we are still not sure about what is the exact number, 3, 4, 5, where we should have a cutoff and say that beyond this the outcomes are poor. But we know that in disease like we can't generalize everything as sarcoma. You'll have to take it as Ewing's or a osteo or a chondro, because the natural history of each one of them is different. For a Ewing sarcoma, if you have a relapse, local relapse is actually a bad prognostic indicator for Ewing sarcoma, and the outcomes are actually in the range of 20 to 30% overall survival salvage rates after that. So it comes really down. So that's why sometimes when we debate that we should we use radiotherapy, not use radiotherapy, whatever you do, you have to do the best form of treatment up front. You cannot wait for the first relapse to happen and then you say, okay, you'll salvage. You cannot salvage. Yeah. For everyone, the difference between carbon and proton is that carbon obviously is a heavier particle, and because of the heavier particle, it has got greater ionization per unit length, so it's a greater LET, and because of the greater LET, it has got a greater RBE. So when we talk about RBE, photon is 1, proton is supposed to be anywhere between 1.2 to 1.3, and carbon is supposed to be 3. So in layperson's language, carbon is expected to be 3 times more biologically effective compared to photon. So yes, that way biologically, yes. There's a lot of work being done at Japan. There are a few centers. The downside is that it's a huge thing. The gantry that is there in Heidelberg is 600 tons. And in Chiba, they have come up with a smaller gantry, which is 250 tons, which is the smallest one gantry. And as things get better, probably yes. So it is not only carbon now, people are looking at multi-ions. And actually we are also one of those who are looking at a multi-ion facility in the future, which includes, preferential use of either protons, carbon, helium, oxygen. So you have targeted therapy or customized or, personalized drugs that we use. Probably in the future it will be personalized radiotherapy based on the kind of tumor that you are treating. Thank you. Thank you very much. Thank you.
Thank you, sir, for sharing this content. I kindly request the chairpersons to honor our speaker with pulk and shawl. For the second presentation, may I invite Dr. Samir Rastogi to present how much pathology is too much.
Good afternoon, everyone. So I'm a medical oncologist who will be talking about pathology, sarcoma pathology, which is a quite unique and intriguing topic for a medical oncologist. But I guess the question is that how far do we go for pathology in sarcomas? It's all blood, sweat and tears. It's extremely rare cancer. It is so heterogeneous, more than 100 subtypes, limited expertise, and now given the fact that NGS, methylation studies are all around, too difficult to point on the right diagnosis or targets. So this is the year when we don't lump everything. Sarcoma is just not sarcoma. What kind of sarcoma? This is the year we split everything. Is it synovial, leiomyosarcoma, ASPS, or what kind of sarcoma? So why is it important? This is important because misdiagnosis is rampant, pervasive in sarcomas. We get to know new entities day in and day out and almost every day. Now taking in a complex clinical picture, it's too difficult to define. And now the treatment is solely dependent on pathology. So this is a paper which shows it's the most recent paper that in high volume versus low volume center, the discrepancy of pathology is almost 50%. And such papers keep on coming. High volume center versus and expert pathology versus low volume center and non-expert pathologies, there is a huge discrepancy, and almost 50% will have change in decision making. The similar paper we presented in ASCO in 2017, and that almost 37% patients had major discrepancy and 24% minor discrepancy. 50% of patients are likely to get misdiagnosed if sarcoma pathology is not accurate. Now, the deeper you dive into sarcomas, the rarer kinds, the more is the discrepancy. We published this in 2020, 20 patients with epithelioid sarcoma, and almost 9 patients presented with synovial, alveolar soft parts, squamous cell, and whatnot. So almost 50% of discrepancy. Similarly, in desmoid, 100 patients and almost 50 of them presented with some other diagnosis, which is, so significant. We can't have misdiagnosis, and it alters the patient management dramatically. So this is an example of 20-year-old kid who first showed in Nepal and then India, and this is the swelling. So he came with foot swelling. This is the pathology, and EWSR1 fish was positive. So I think Dr. Shantvir is there today. So Dr. Shantvir, you agree on this? Like three places, synovial, Ewing's and rhabdomyosarcoma. And EWSR1 fish positive, yet not responding to any chemotherapy. Yeah, so it came out to be HMB45 positive. And this was EWSR1 ATF1 positive. So after coming this close, the diagnosis were all clear cell sarcoma. The patient, by the time the diagnosis was made in our hospital, he was stage 4. So these small things and the diagnosis, they just alter the management so dramatically. Now what about newer entities? Almost every day these newer entities are coming. So there are 2 patients, one with multiple scalp swelling, another with arm swelling with axillary lymph node. And they both present with the epithelioid component, round cell component with undifferentiation. And if you see, the pathology was INI1 retained, there was no diagnosis. Our pathology told us to do NGS, and it came out to be an extremely rare subset of sarcoma, NR1D1 MAML2 sarcoma. It's INI retained, and nothing works in this kind of sarcoma. So instead of trying tezumetostat or doing something else, probably we need to know the exact diagnosis. Similarly, this young guy presented with neck swelling, and it was labeled as low-grade sarcoma. Now, Dr. Bharat Rekhi reviewed the swelling, and this was very similar to sclerosing epithelioid fibrosarcoma, but he said cyclin D1 is positive. There might be something called YEP KMT2A, in which cyclin D1 is positive, and that entity is very less known. We got NGS done, it came out to be YEP1 and KMT2A sarcoma positive. And why is it important? If someone is saying it's low-grade sarcoma, what do we get after knowing it is YEP KMT2A? Because these are very aggressive group of sarcomas, and they behave just like high-grade sarcomas and are again chemo-resistant. So patient is on follow-up. Again, next case, 30-year-old male with myxoid liposarcoma but translocation negative. Now, what's the diagnosis? Myxoid areas are there, pleomorphic areas are there, we don't know what is it. And for all these entities which I have described, not more than 50 or 60 cases are reported. So this case was sent for MSKCC path review, and it came out to be something called pleomorphic myxoid liposarcoma. Not more than 50 or 60 cases are reported so far. And this girl, again with similar picture, next year presents to us with neck and mediastinum swelling, same myxoid liposarcoma but no translocation. So this time our pathologist could make the diagnosis, and this is associated with Life-Romani syndrome. We got P53 mutation and it came out to be positive. This is the beauty of knowing right sarcoma, right pathology, so that we can go ahead with these testings, and Life-Romani syndrome was picked. So recently we saw few cases with bony rhabdomyosarcomas. So the first case which we saw was around 2-3 years back, and young male, thigh swelling, and second case was this. This is alveolus, and then these cases were MyoD1, CK and ELK positive. So rhabdomyosarcoma, it was difficult to make the diagnosis in the first go, but then it's not rhabdomyosarcoma. This is completely different entity, and this entity is EWSR1 TFCP, which typically happens in head and neck, typically happens in bone, typically is chemo-resistant. No rhabdomyosarcoma protocol works. And if you get to know this CK, the triad of CK, MyoD1 and ELK, and no ELK inhibitor works. So perhaps right now we don't know the treatment. and the literature is again less than 50 or 60 cases are reported. And we tried cabozantinib in one patient after seeing the biology and everything, and one patient had partial response. This is the only case of partial response reported so far in this rare entity. So there are so many entities like this that are coming up every time. This new entity, less than 50, less than 60 cases, no guidelines. Perhaps sarcoma pathologists, apart from misdiagnosis in common like leiomyosarcoma, liposarcoma, synovial sarcoma, it is good to know what next. How does histopathology lead you to the molecularly defined entities? So also this is just a step. We have to get to the diagnosis ultimately, and FISH or NGS might be the next thing, or methylation studies in this day and age. So yes, sarcoma pathology has its caveats, even if the best sarcoma pathology of the world is there. So this is a study, French sarcoma pathologists, expert for years. This tested fidelity between sarcoma pathology versus FISH for molecularly defined sarcomas like synovial sarcoma, alveolar rhabdomyosarcoma, D-differential liposarcoma, myxoid liposarcoma. And what they found, even if sarcoma pathologist is one of the best sarcoma pathologists, dedicated for years in the best centers in the world, it might lead to change in diagnosis in 10 to 13% of patients. So you don't know, out of every 10 synovial sarcoma, alveolar rhabdomyosarcoma, unless translocation proven, 10% will be changed to some other entity. Routine NGS, should we do NGS in all cases? If resources are there, probably yes, but it might lead to diagnosis again in 10%. And if pathology, if it is reported by sarcoma expert pathology, then only 4%. But it might cost billions of dollars. So we don't know so far which are the cases in which NGS should be done and shouldn't be done. So we did this study, prospective study of NGS under multidisciplinary tumor setting. And so since so far data about NGS is just routine NGS in sarcomas or with molecular defined. So we did molecular multidisciplinary tumor board based NGS testing, and this was a prospective single institute study, and we had almost 68 patients. Round cell tumors were 17, undifferentiated sarcomas were 19, and other subtypes were 34. We did NGS only if there was discrepancy between pathology, morphology, clinical behavior, or pathologist is saying that yes, do NGS. So as you can see, for undifferentiated sarcomas, we got so many strange things. WWTR1 CAMTA, SS18, SSX, NR1D1 MML, and for round cell tumors, we got EWSR1 PET-Z, which is absolutely different from EWSR1 WT1, EWSR1 FLI, CISDUX, FUS, EWSR1. So round cell tumor is probably the subset in which largest, if it is not characterized by FISH or morphology, then probably NGS should be done routinely. And other subtypes, we had osteosarcoma patients with IDH1 mutation. Because one was from jaw, one was from chest wall, flat bones. It turned out to be chondrosarcoma. Similarly, ESS turned out to be something else. And DFSP turned out to be PDZR and mutated sarcomas. So if there is any discrepancy, pathologist is on the same page, we have tumor board, probably you should go for NGS for diagnostic purpose, especially when you are suspecting under the umbrella of tumor board. So as you can see, in round cells, almost 68% of patients come out with some kind of translocation. Similarly, the treatment was changed in almost 26% of patients. Thus, probably doing NGS blindly or routinely might not be the appropriate thing. But if tumor board, pathologist, and there is clinical discrepancy, or patient is not responding, like Ewing sarcoma, not responding to first line, probably the diagnosis needs to be revisited. So what about treatment? Is it really pathologist based? Because I heard just outside the room that in sarcomas, we don't do anything. We just give ifosfamide and doxorubicin. And this is our routine thing. So is treatment histology specific nowadays? Perfectly. This is all histology specific. Last few trials in the world have been histology specific. Trials in leiomyosarcoma, liposarcoma, synovial sarcoma, desmoid, TGCT. There are new drugs for almost every other entity. Similarly, the approval of tezimetostat in epithelioid sarcoma, BRCA2 inhibitors in uterine leiomyosarcoma. I mean, this PARP inhibitors and NYESO, MAGE4 for synovial sarcoma. So right now everything is histology based. This is the single most important thing. Probably pathologist helps us to converging the right pathology. How it might lead to dramatic alteration of therapy in few patients. This lady came to us, 48-year-old, PS4, breathless, was labeled metastatic DFSP with CD34 and S100. If your pathologist give these two, CD34 and S100, there can be three things. Either RET mutated, RAF mutated or NTRK mutated. So once we got this CD34 and S100 positivity, this is the lung mass of this person and patient was breathless. So CD34 and S100 co-positivity. And this is the mutation that came. This is PDZRN3 and RAF1 mutation. So as per, there are hardly 5 or 10 cases reported with this rare mutation. And we started trametinib plus low-dose doxorubicin. And the response was tremendous. You can see there was excellent response, almost complete response for 6 months. Similarly, this is a patient with lung sarcoma who had CD34 and S100 positivity, came out to be NTRK IHC positive, NTRK mutation positive, pre-crizotinib and post-crizotinib. Excellent response. This is patient with infantile fibrosarcoma, NTRK positive, still in CR 4 years since larotrectinib. Similarly, again, some patient with lipofibromatosis, NTRK IHC positive, NTRK3 positive. This is excellent response with crizotinib. And now patient is operated. At some point of time, this baby, we were planning amputation. We could salvage the limb. DFSP, similarly, some sarcomas like DFSP, they have excellent response. This sarcoma was diagnosed schwannoma by outside, but came out to be DFSP, excellent response to imatinib. Simple drugs. In chordoma, if pathologist says that EGFR IHC is present, they might respond nicely to erlotinib. So this list is endless. I think there is no limit to pathology. There is no ceiling to pathology. I think pathology should be mixed with good clinical discussion and with NGS and methylation studies wherever possible and wherever appropriate. So I think pathology is infinitely needed. So we have also discussing this pathology favored like specific trials in synovial sarcoma, in desmoid, specific the drugs which are pertaining to pathology, and these are the studies going on in AIMS. So I'll be happy to answer anything. Thank you.
Can we have a quick question, one or two? We have exceeded the time.
So Dr. Samir sir, excellent talk. I am a medical oncologist. I practice in Raipur. So based on your presentation, what I can understand is that there's everything histology specific. But then if you look at the study which was published and which compared standard chemotherapy versus histology specific chemotherapy, that study clearly said us that both ways histology specific chemotherapy did not yield additional benefit. That is number one.
So I'll just answer this. Yeah.
Let me complete, then you
can.
Yeah,
yeah, sure.
It's just a comment because you are expert in this field and we hardly see few cases. So your thoughts on that. Second, though you talking about NTRKs and that, and you showed 3 cases of NTRK. But then if you look at NTRK positivity in sarcomas, it is 1%. So if you look at overall sarcoma. So I think these are very selected patients which are benefiting. So let's say if you're seeing 100 patients, then 4 or 5 may benefit. But those rest 95 still fall into that good surgery, good radiation and IFOS adriamycin based protocol. Thank you.
Yeah. So the first question, I mean excellent questions. The first question was neoadjuvant study published by Italian sarcoma group and Spanish sarcoma group where they compared IFOS epirubicin with histology tailored treatment. There were only 5 subtypes. Those subtypes were synovial sarcoma, for which IFOS epirubicin was compared with high-dose ifosfamide. There was leiomyosarcoma, IFOS epirubicin was compared with gemcitabine docetaxel, MPNST, IFOS doxorubicin compared with IE, UPS, IFOS doxo compared with gemcitabine docetaxel, myxoid liposarcoma, IFOS epirubicin versus trabectedin. Now, elimination of doxorubicin in all these 5 entities is almost impossible. In leiomyosarcoma, how can you eliminate doxorubicin in the first line? Gem-dacarbazine or gem-docetaxel can never be taken in the first line. So first thing, trabectedin was as good as IFOS epirubicin in the myxoid liposarcoma arm. Synovial sarcoma, doxorubicin is one of the greatest drug. Avoiding doxorubicin doesn't make sense. So this study was first not powered for individual thing. Secondly, replacing doxorubicin in first line might be a tricky thing. And this is, we are talking about 5 sarcomas. Now they constitute 70%, but there is still 30% of sarcomas where probably clear cell sarcoma, ASPS, and so many chemorefractory sarcomas where IFOS doxo don't work. So this is the answer to first question. Second question is that these are only 5%. So do you know how many patients of NTRK are reported from India? NTRK sarcoma. We are the most populated country in the world, undeniably, but I think only 1 or 2 cases. We are missing everything. We don't have rate mutated sarcoma. I think Dr. Shantveer has seen that rate mutated sarcoma, but the number of publication or number of cases are so less. I mean, we were collecting data for NTRK sarcomas across 10 institutes. We could get 10 patients, of which 6 are ours. So big centers, hardly NTRK sarcomas, because somehow these things are missed. I get it, there might be 5%, 6%, but for a person with NTRK sarcoma, there is a transformative shift in the treatment. You start with larotrectinib, the child does well for years. So probably unless we do pathology or NGS, we will not get to know anything. In India, there is hardly treatment outcomes are reported from lots of sarcomas. I mean, there are very few sarcomas which are named. We don't have single trials. We don't have, so I think we understand, yes, 80-70% fine, it might work, but even 30% in a country like India is huge. So probably we need to be specific, and at least pathology, like my topic, the sarcoma pathologist is non-negotiable. I mean, this is my thinking, but it's out. So, any other question? Dr. Shantveer? I mean, he's the only sarcoma pathologist amongst us.
Thank you, Samir, for stressing the importance of pathology in sarcoma. I feel, as he rightly said, many of the times what happens is even in a general pathology work, they don't concentrate much on typing these sarcomas. That is very important to see that how best you can type these sarcomas, because it can lead to a lot of treatment variations and all. I think now in the present situation, we should try to see that it is properly diagnosed with all available morphology, IHC, plus FISH or NGS, whichever is modality, because the treatment, if we find a specific thing which can have a targeted or a specific drug, that is nothing to replace that. That is what I second with Samir on these aspects.
Thank you. Thanks a lot. Thank you very much.
Thank you, sir, for this comprehensions. Please note, there is a no feedback putty would be available outside of auditorium from 3:30 p.m. onwards. I now invite Dr. Avijit Salunke to guide us through the topic extended to resections in extremity sarcomas.
So, thanks to the organizers, Dr. Dasu and team AIG. So, after hearing the medical and radiation oncology talk, I think surgical oncology is a bit easy. Just either you save the limb or cut the limb. It is very tough to do medical oncology, pathology. So, it's quite easy branch. So, greetings from GCRI, the place where I work. So, quite similarities between Hyderabad and Ahmedabad. Both are quite historic cities. And this slide just summarizes whole presentation. So, there is quite consensus on sarcoma. There can be debate on resection and reconstruction techniques. So, ultimate aim is to save the limb, give good function, and improve the life of the patient. So, there are no financial disclosures. Few patents have been granted to me and my team. So, the surgery can be divided into 2 types. One is limb salvage and second is amputation. In limb salvage, you save the limb, you protect the artery, vein and nerves and give excellent function to the patient. In amputation, either you do complete amputation of the limb or you do some modifications in amputation. That we will see subsequently. Next, there are 2 terms, wide resection and compartmental resection. So, wide resection, you remove the tumor with good margins. In compartmental resection, you remove the whole compartment. Not commonly done, so wide resection is what commonly followed by all of us. So there is a past, present and future of whole surgery. So we evolved from amputation, then limb salvage, modified amputation. Now we are in the era of 3D printing, augmented reality and virtual reality. So subsequently we will see what it is. So we go directly to few cases. So a gentleman with a tumor in the humerus, it was quite big tumor, quite fungating. We resected the humerus, clavicle and the scapula. So the conventional treatment for this tumors was 4/4 amputation. But we thought that something newer things can be done. So we saved the artery, vein and nerve, coiled all these three, and we attached the humerus to the remaining clavicle with the help of a proline mesh or a Trevera tube. So that was done for this gentleman. It was a 65 years old gentleman. This was the immediate follow-up of the patient. We can see that there is wrist drop. The wrist drop sign is there. And we had attached the humerus to the clavicle. So simple schematic diagram, how it is. We attach the humerus to the clavicle. We can see the function of this patient. And so this was nearly 2 years plus follow-up of this gentleman. So there is wrist drop, hand is small, but still functional. He was quite happy, able to hold the glass, do his basic activities of living. Other treatment would have been a 4/4 amputation. So he is happy, hold his pant, trousers, wear it. We go to next case, again a lady, 65 years plus, tumor involving the humerus. This was chondrosarcoma, high grade. We resected the tumor, again did same similar procedure. We attached the humerus to remaining distal proximal humerus. And if we can appreciate, our plate was placed between the distal humerus and the remaining bone. This was the immediate follow-up. Lady was 65 plus, able to hold the glass, do all the basic activities of daily living. This is the follow-up of this lady, and this was the immediate follow-up. All nerves are saved, artery, vein, nerves. This is her function. Limb is small, able to hold the glass. This is nearly 5 years plus follow-up of the lady, able to hold the glass, holding a weight of 4 to 5 kg in her limbs, and she is quite happy. So we have just submitted this paper to a journal, and we have titled it as Pushpa. So inspired from Hyderabad only, Pushpa, the man with a druge limb. So this is the third case, again similar type of a big tumor, but in this case we were not directly able to save the limb. The artery, vein were encased in the tumor. So we did a bench surgery like thing. Remove the tumor, kept it on another table, prepare the artery, vein and the nerves, and then re-anastomosis was done. So this is the procedure and a small video of it. So this is the tumor involving the humerus. It's not resectable. Treatment would have been 4/4 amputation. So proximal incisions were taken. This was the proximal incision. So whole limb is excised. You just detach the elbow and the forearm, keep it on another trolley. So your second incision will be on the elbow level. So this is how the tumor is resected. Your artery, veins and nerves were prepared. So for this case we took help of our vascular surgery colleagues. So this was the artery and vein. And the remaining limb was prepared on a different trolley. So it's like a bench surgery. People do for liver and other cases. So similar type of thing was done. So we cut the ulna, attach the proline mesh to it, because plate fixation and other things will be a bit tough. And this way it was attached to the remaining part of the shoulder girdle. And artery, vein and now anastomosis was done. So this is the final thing, how it was done. So nearly 13 cases of this have been performed and it is under review. So can all limbs be saved? No. So in one of a case, this was done and next day the artery, vein got thrombosed. So we had to cut the limb. Second option can be you can convert a 4/4 amputation into above elbow amputation, and a myoelectric hand can be placed here. So that can be one procedure. Next we go from upper limb to lower limb. So two videos are there. One is rotation plasty. Both animations are there. So what is done in rotation plasty? So this is a simple animation. This is the tumor. You resect the tumor. Say only artery, vein and nerves. Rotate the leg by 180 degrees. And your ankle joint works like a new knee joint for the patient. So similar way what we had done in upper limb, same procedure can be done in lower limb. And your ankle is at the opposite knee level. If the patient wears the prosthesis, it's an excellent function. Cosmetically bit not that great, but functionally it is excellent. So this is how your artery, veins and nerves are saved. Preserve that. And this is the function of the kid. So when he wears his trouser, we are unable to identify what procedure was done for him. So we have done few modifications in this surgery also. We are cutting the toes, chopart and other things we are doing. So it's cosmetically excellent. Not that excellent. Functionally it's a super procedure. Bit tough to counsel. You need to show the photos, videos to the patient, but they agree for this procedure. So this is the kid, and this is nearly 5 years plus follow-up of both the patients. So after lower limb, so we thought that we should do something new and some innovative things. So we thought that we use augmented reality, virtual reality and some next things. So like previously you used to buy a shoes from, you go to the shop and then buy it. So now you can just scan your foot, print your shoes with a 3D printer. So are we becoming God? We really don't know. So this is a small 3D printer what we have in our OPD. You just give a command to it and you can print a small knee model for it. So the patient is having some tumor into the knee, and this takes 5 to 10 minutes to print a knee model. So this is how the knee model is printed. So it's less than 1 inch by 1 inch size. So this is good for patient counseling and other purposes. To putting into the patient, you have to use titanium metal implants. So this is a small knee model which can be used. So next is augmented reality assisted surgery, some extended indications. It's like a Iron Man movie that we wear the glasses and we do the surgery. If someone is sitting here, like Dr. Dasu is sitting here, I am in Ahmedabad, both can wear the glasses and we can be on same page. So it's like a Jarvis of Iron Man. So for this technology, we are using HoloLens by Microsoft. We get the 3D printed model, segment it put into the computer, and these are the HoloLens glasses what we are using. So you segment the model. So here we printed a scapula for the patient. So this is the computer aided design pattern. We need to resect this tumor and we will be getting a new 3D printed scapula made up of titanium material. So this is the final implant and this is the HoloLens I am wearing. So all things are sterile, just it's like Iron Man. I can see all X-ray, MRI, CT scan in front of my eyes. I can just superimpose one object over object. So it's like making a Google map of a surgery. You know where your artery, veins and nerves are there. So very good technique. Here I can scoring all the CT, MRIs and all things can be done and you can be on same page. So this is how we are superimposing the scapula over the scapula. This is a scapular tumor what we are resecting and we are superimposing the scapula and artery, vein and nerves can be superimposed. So this is augmented reality assisted surgery. Again some extended use of technology here. Next we go to hand tumor, metacarpal. And previously if this was a tumor, one option would have been fibula, second would have been a metatarsal. We thought that we print our 3D printed metacarpal made up of titanium material. Again we can appreciate it's a lattice structure here, honeycomb pattern. We get the X-ray, MRI, CT scan done. And these are all the options. So if you want to buy the oil, we have these two people who are troubling the world. So previously we used to do curettage, orthodesis, iliac crest graft, metatarsal, we have done all the things. Allograft we don't have. So this is the planning how we do for the cases. And this is the implant which was designed. So it took around 1 month to plan a design, a newer implant. So totally a newer implant in the world. So you resect the tumor, you place the metacarpal, and we can appreciate here there are multiple holes available so that a capsule can be reconstructed here. So in initial cases it was getting dislocated. We learn from our own mistakes that how capsule can be reconstructed. And this is a special material, PET material, which was used to reconstruct the capsule. And these are the final X-rays. So after hand we go to talus. So previously one option was doing arthrodesis for talus tumor. So we again designed our own talus implant, and this is one of the case where talus replacement was done. You resect the talus tumor, and this is the implant which was placed. So we can appreciate it, it's a metal, poly and metal implant. So again a newer design implant what we designed for our patients. And this is the intraoperative video. It's nearly 5 years plus follow-up of these cases. So all are indigenous things. Next we go to growing or expandable joints. Again extended use of technology. This is warm gear technology mechanism. You give small incision and expand the limb. So one turn is 1 millimeter. So you have to turn 10 turns, the limb will get by 1 centimeter expansion. So case of proximal tibia tumor in an 11-year-old girl. You resect the tumor, and this was the resection of the tumor, and this is how the implant is placed. This is how we rotate the gastrocnemius flap, and every time you have to give a small incision here. That can be done. Next we go to hemipelvectomy, again a complex surgery where type 1, 2 and 3 hemipelvectomy was done. So type 1 is ileum, type 2 is acetabulum, type 3 is the ischium bone. So this was one of the case where it was dedifferentiated chondrosarcoma, tumor involving ear to ear, and this is a skin incision, what we plan. This was the resected specimen. So we can appreciate a ileum, ischium, pubis and femoral head is resected. These are the artery, veins and nerve. So in this case we have to reconstruct the femoral head and make a new capsule. Hip joint we have to make it. So in this case we had used a tube which is called Trivera tube made up of PET material. So this is the femoral head which was reconstructed. It's like a socks. You wear it on the femoral head and one part will be attached to the acetabulum. So last 1 minute, sir. And we are using ICG technology to know the flaps, vascularity and everything. We are using AR/VR technology. Lastly, something newer technology, that is PEEK material, that is polyether ether ketone. It's a carbon fiber material. Like Mr. India movie, it's invisible. So advantages, you can pick the local recurrence very easy and the union areas can be picked very fast. So the scapula is resected and not seen on the X-ray. Lastly, we are using bioabsorbable scaffolds, which is made up of 3D printed technology, tricalcium phosphate material. And we have developed our own bone biopsy gun. We have got a patent of it. So it has multiple sensors, goes into the bone, stops automatically and comes back. So we are working on the robotic arm for it. That is the last innovation. And this is the latest thing what we are working is a myoelectric hand. So you cut the limb of the patient and based on the sensors, here it works. And there is a life after Krukenberg surgery. So only 2 arms are there. If you can appreciate here, still the function can function. So there is life with or without hands, what we can say. So what is the future? It is, you can print artery, vein and nerves. Extended limb salvage surgeries are possible. So thank you very much. Thanks for considering me.
Yep. I think Dr. Abhishek, great talk.
Thank you, sir.
Extremely stimulating, and I actually wanted, extended resection in soft tissue sarcoma, but I think you have gone a step further, and
so I included all.
You have included everything, yeah. So I just wanted to know, when you have all these implants which are 3D printed, and how are do they have any rejection rates which are more than the standard synthesis implants, or are you finding?
No, it is similar. We are using same material.
Or in leaching or anything?
No, leaching is minimal because it's all of titanium material. Okay. We had breakage of the PEEK plate.
Yeah.
So the PEEK plate I showed implant, that we had breakage 1 case. So yesterday we revised it.
Okay. Because the material that you use for the
is titanium.
Is titanium.
Titanium, that is done.
Okay. So that's what.
And all is indigenous. So previously we thought that we collaborate with someone outside India. So we tried with Israel and other people. Problem is the time duration. It takes 1.5 to 2 months to import the thing.
And is it covered under the government schemes?
All things are done free at GCRI. So none of the patient has to pay anything. So it's either government supported or some NGO supported.
Great work.
Thank you, sir. Yes, sir. Yes, sir. Yes, sir. Yes. That will be really great, sir. No, as a government cancer center, sir. Definitely. So I'll take the contact from you, sir. Okay, sir. I'll take the contact from you, sir. Thank you, sir. Thank you, sir.
Thank you, sir, for the enlightening lecture. For the next lecture in this segment, I humbly call upon Dr. Shraddha Patkar to speak on the topic, Does Histology Guide Extent of Resections? Thank you.
Good afternoon. Good afternoon, everybody, and thank you, Dr. Dasu, for this kind invitation. After Dr. Samir Rastogi has guided us regarding how pathology has driven the extent of medical oncology and the planning, we will now look at whether histology actually guides the extent of surgical resection. I'm going to cover retroperitoneal sarcomas in general. So the evolution of surgical procedures for retroperitoneal sarcoma actually moved on to involve the organ, which is mostly the tumor. Then we moved on to what was called as compartment resection, which was popularized by Alessandro Gronchi from Italy, and a recently instituted concept called as histology tailor-guided organ resection. We'll touch upon all of these in brief. When Professor Gronchi from Italy actually brought into vogue the concept of compartment resection, it was actually extrapolated from the extremity sarcomas, which showed that we could achieve a greater local control and a reduced local recurrence rate with compartment resection, which essentially meant that you remove the tumor en bloc with the adjacent organs, whether it looked grossly involved or no. The safety of this kind of approach was established in large volume series, both from Italy as well as France, with an acceptable mortality. The principle was again based on the principles of surgery for extremity sarcomas, which is a liberal en bloc resection. However, it was faced with some criticism that although it reduced the local recurrence rate, it didn't turn out to be beneficial in the long run. That is, it did not provide an overall survival benefit. And though it was termed as compartment resection, it was still selective in some aspects, that when there was a major blood vessel or there was a high risk organ which was needed to be resected, surgeons were still little skeptical. So this approach also needed some kind of refinement when we understood how each of the histologies, common histologies in retroperitoneum behaved. We saw that the overall survival was not different. Whatever you did, there was a benefit in local control. Again, this was evident in grade 2, grade 1 tumors, because again, with high grade tumors, we are looking at distant metastasis as a more limiting factor. So then came the concept of a histologically based classification to guide our resection strategy. What essentially this meant was that if you look at the most common 5 histologies which we encounter in retroperitoneal tumors, that is the liposarcomas, whether it is well differentiated or dedifferentiated, the leiomyosarcomas, which are usually arising from the vessels, SFT and MPNST. The intraoperative findings of these were actually very classical. In well-differentiated, in liposarcomas mainly, whether well-differentiated or dedifferentiated, you had this huge tumors with indistinct boundaries, often multilobulated, with the fat straddling major organs. And in this case, doing a compartment resection with removal of the ipsilateral fat in the retroperitoneum made quite good sense. However, in leiomyosarcomas, which invariably arose either from the IVC or the renal vein, it was a distinct tumor with well-defined borders. And when we looked at the biology of these tumors, it was seen that leiomyosarcomas seldom failed at local sites. It was the distant metastasis which actually mattered in these tumors. Again, in SFT and MPNST, they were absolutely well localized tumors. So just removing them and preserving other uninvolved adjacent structures made sense, because the pattern of recurrence in these tumors differed. So again, the group which propagated compartment resection also had a thought about how this could be factored in and how you could use histology as a driving factor to determine the extent of resection. Then came the concept of something called as the HOI, which is histopathological organ invasion. So this essentially was developed by Mark Fairweather from his group, and what I said initially, that a less aggressive approach to a primary tumor may be considered, knowing that ultimately it is the distant metastasis which is going to drive the survival outcomes in these tumors. And when the histology or where the pathology was looked at, it was seen that histopathological organ invasion was present in close to 60% of the patients. It was an independent risk factor for poor overall survival, and the likelihood of organ invasion could be predicted by the subtype. And these are the various rates of HOI which are seen in large volume centers which have looked at the pathology. As evident that the dedifferentiated liposarcomas top the list, there is a 61% chance that the adjacent organs, whether they are grossly or at naked eye, whether they look involved or no, you will find them involved in final pathology. Further refinement came in this when there were different classifications of HOI where you could see whether the adjacent organ involvement was only due to either end organ vascular supply involvement or whether it needed an organ resection due to for a complete microscopic resection, or there were other reasons for which you had to embark on an extended resection. Again, this is just a reflection of how the pathologies behave. As you can see that the dedifferentiated liposarcoma is the predominant histology which shows higher rates of HOI. And for dedifferentiated sarcoma, something which is of note that HOI was present even when it was not suspected intraoperatively. That is why there is a reason why we need to develop a data-driven and histologically specific rationale for removing adjacent organs. So this is a very nice article which is written by Mark Fairweather himself, and where they have looked at the organs which were most commonly involved on histopathology. As evident, kidney and colon are the two most common organs resected because the morbidity is not as much if you as against if you have to remove a pancreas or a major vessel. So a surgeon's intraoperative assessment that if you have a frank invasion, it's usually an HOI is present in 65% of the resected organs, and if you, as opposed to if you just have an adherence where it is 26%, but that means 1 in 4 patients will still have histopathological organ invasion in final histopathology. So now we have realized that compartment resection improves local control but does not give any survival benefit. It does have its flip side with increased post-operative stay, longer operation times, maybe increased blood loss, and a slightly higher chance of morbidity. So looking at all this, how do we make our decision regarding removal of adjacent organs or no? So when we published our experience with close to 500 patients of retroperitoneal sarcomas, which we had looked at in the past 6 to 7 years, we have summarized our approach based on these 3 principles. That is, it is standardized to anatomy, tailored to histology, and guided by rationale, which includes all the 3 aspects which I have covered till now. Again, our study also mirrors what has been shown in literature, that HOI is seen in close to half of our patients. Again, colon is the most common organ involved, followed by the kidneys. And if you look at the histology, except in the case of dedifferentiated liposarcomas, no adjacent organ resected was found to have HOIs. So And also, irrespective of the histological subtype, the duodenum was histologically involved only in 2.3% of the cases, and pancreas in 2.7%. So these two are the major hindrances to doing a compartment excision, especially for right-sided tumors. In left-sided tumors, you can get away doing a distal pancreas resection safely, but if you have to add a pancreatoduodenectomy, especially for a right-sided tumor, then the skepticism is there, because it adds to the morbidity. You are adding on high risk anastomosis, and hence the worry about a turbulent post-op course. Again, the three main factors which have affected survival in our series was again histology, HOI, and whether we could achieve a margin negative resection. So some of the images from what we are doing for a histological guided resection. This is if you have a well differentiated liposarcoma, we embark on what is a standard compartment resection, that is R-block resection of the tumor with hemicolectomy and nephrectomy, along with the entire fibrofatted tissue area between the psoas and the mesocolon. The more aggressive surgeons also remove the entire psoas muscle right from its origin to insertion, which may not be needed in a well differentiated lipo. But a dedifferentiated liposarcoma is something which one must be very careful of. An aggressive resection, try to remove as much as fat from the retroperitoneal compartment as possible. No attempt should be made to separate an organ which seems to be adherent to tumor. And in this case, if for a right-sided tumor, it needs a pancreatoduodenectomy, that is what is done. But a basic minimum is R-block resection with the kidney and the colon. This is an example where we have added a pancreatoduodenectomy as well. In left-sided compartment resection, our life is relatively simpler. The kidney and colon are again low morbidity surgeries. Even a distal pancreas, if we have to resect, it is not as bad. The leak rates, even though they are little high, it's a bland leak and it's usually controlled. Sometimes extensive tumors which involve the diaphragm also require excision and some kind of patch repair, but these are surgeries which can be managed. This is a unique feature. Sometimes you have a LPS which is encasing the common iliac vessel. So if it is the internal iliac artery, we usually ligate it. But the external iliac artery, obviously because we need to salvage, we need to preserve the supply to the limb, needs to be reconstructed. And this is an example of a graft reconstruction for an external, for a common iliac artery. In liposarcoma, the aim is to remove the tumor R-block with the vessel of origin, either the cava or the right renal vein. If it is the cava, it usually, we decide whether the patient needs reconstruction or no based on the level of involvement, and also whether there are robust collaterals. These tumors are often long-standing and have developed collaterals by the time they present to us. So as you can see, if you have such kind of tumor and you you can safely transect the cava here, transect the left renal vein and inferiorly the cava, and you don't need to reconstruct it, because these patients will invariably have a good robust collateral supply either from the gonadal or the lumbar, which takes care of the lower limb venous drainage. This is again a unique scenario, but you have tumor reaching right up to the hepatic cloaca, pushing the porta. In that case, you need a suprahepatic caval control, maybe sometimes even a cardiac bypass. And if the hepatic cloaca involvement is doubtful and the venous drainage is at risk, it is always safer to reconstruct. Sometimes a pelvic sarcoma deep in the pelvis can be excised. The iliac, as I said, if it's an external iliac, it needs to be reconstructed. Internal iliac arteries can be safely ligated, and this is a resected pelvic tumor bed. For other histologies, our policy has been complete R-block resection, and if you have organs that are obviously infiltrated, they are resected. And as long as this can be achieved without breaching the tumor capsule and avoiding the risk of intraoperative tumor rupture, this is a safe strategy to follow. So to summarize, these are the most common histologies we encounter in retroperitoneum, and our approach now has been tailored to what kind of histology the tumor is. So most of our patients do get a biopsy preoperatively to determine which histology it is, so that we can guide our resection policy intraoperatively. Thank you so much for your kind attention.
Madam, amazing talk, and I'm sure you are known as the authority right now in retroperitoneal sarcomas in the country and probably Asia, especially pelvic sarcomas, madam. Do you have any case where you would you consider it inoperable by particular? You said that if the vessels are involved, you can reconstruct them. If the nerves are involved, you can probably sacrifice them. So then, when do you say that a large retroperitoneal sarcoma going to the pelvis? Is there any time where you claim that it is inoperable, upfront inoperable, or so anything on the imaging which will say that it is actually inoperable? So
right now, probably only 2 or 3 criteria which will deem it inoperable. If you have a big pelvic tumor with bilateral ureter involvement, you may resect it, but you are going to leave the patient anephric for the rest of his or her life. So in those cases, we don't embark. Again, if you have a dedifferentiated tumor which is crossing the midline and involving the root of the mesentery with involvement of either the SMA or the celiac, then that would consider inoperable. And multiple, if you have something like a sarcomatosis, you have multifocal disease, and you are going to end up removing a large part of the bowel and leave the patient with short gut syndrome. They are technically not unresectable, but we need to balance what kind of patient population we are looking at and how the patient can manage his or her lifestyle post-operatively. And again, nerve root involvement probably going into the spinal canal is something which
I just had one doubt. I'm sorry. If there is bilateral sciatic notch going into bilateral sciatic notches, or both the hernial orifices are involved, then that per se would not make that particular tumor because it's not within the compartment. Essentially, it's gone beyond the compartment.
Yeah. So in dedifferentiated lipos, usually you don't get this kind of picture. You may get them in MPNST where you have. So MPNST, again, if you have a biopsy of a particular tumor which is malignant, our strategy would be to probably resect that. The other in which you get this kind of probably is NF1, and you know that these patients ultimately are going to have a poor prognosis. So give them adding morbidity to their life and ultimately not changing their overall survival is not going to be beneficial.
Great, thank you.
Thank you. Thank you once again.
Thank you so much, ma'am. The next in the list is the panel discussion on the topic localized sarcoma, extremity sarcoma. We have our moderator, Dr. Sujana Priya, along with the panelist Dr. Mohit Sharma, Dr. Madhuri Poppana, Dr. Bindu Venugopal, Dr. Keshav Ramgopal, Dr. Shivendra Alapati, Dr. Shantived Uppin, Dr. Srimanth B.S. I request you all, please come up on the stage.
We need to stay here. Excuse me. Hello. The panel discussion is on. Do we need to stay here?
Yeah. Yes, sir.
Okay.
We request you to kindly stay, sir. Yeah.
No.
Can I have my slides? Yeah, thank you. A very good afternoon, one and all. So after many thought-provoking and very high-on surgery presentations, we'll just go with a very simpler panel discussion, the extremity sarcoma. So we have an equitable distribution of all our panelists here, so whom we have already introduced. So we have 2 medical oncologists, 2 radiation oncologists, 1 surgical oncologist, 1 orthopedic oncologist, and 1 pathologist who is supposed to be an authority in sarcoma pathology. Okay, so let's quickly start the panel. So normally whenever I do a presentation, talk or a panel, I don't like talking about the statistics, incidences or prevalences. But here in this case, I kind of made an exception today. I'll tell you the reason why. So sarcoma as such, if you look at the data from all the hospital-based evidences, databases, registries, etc., etc. So as such, the incidence of sarcomas are quite rare, less than 1% of cancers. Most of the data is from the hospital-based registries, including our own data, which has been published from TMH by Dr. Anant. So if you look at the Rare Cancer Network group or the NHS group, which has been, which said that the sarcomas are as such less than 1%. So which means that unlike breast or unlike head, neck, lung or prostate cancers, the evidence is there, but scant. So from there, that is where I would like to emphasize and start. And also at the same time, you have some compelling evidence with respect to local treatments in sarcomas, like Dr. Laskar has already shown us. But most of the evidence is from retrospective databases. Now, let's quickly go into the sarcoma per se. Sarcoma as such is broadly divided into bone sarcomas and soft tissue sarcomas. So a quick disclaimer as to what I'm not covering. I'm not going into Ewing's sarcoma, rhabdomyosarcoma and sarcomas in unusual sites. So I'll be discussing in depth about the soft tissue sarcoma, and if there is any time left, we'll be discussing about osteosarcoma in the end. Now, let's get to the meat of the matter. So now, this is the first case. We have a 25-year-old male presenting with swelling in the thigh with pain for the last 1 month. On local examination, it revealed a 5 by 7 centimeter size swelling in the left lower thigh, hardened consistency. Skin over the swelling appears taut and glistening. The distal neurovascularity is normal. So these are the cases which tend to gravitate to the surgeon in the beginning. So that's the reason I'll start with our surgical colleagues first. Yeah, Dr. Shivender. So what are the differentials you can think of when you see a case like this in your clinic?
First thing is the duration, it's only 1 month. So because it's a short duration and it's about 5 into 7 centimeters, definitely I would think in perspective of some malignant tumor. Mostly as soft tissue sarcoma is the first option here. And maybe some, if there was any history of trauma or something, maybe some hematoma which is evolving.
No, there is no history of trauma.
Yeah. So something very suspicious, I would, first option would be a sarcoma here.
Okay. I mean, I think there are a few residents also in the audience. Can you elaborate on quick differentials as to what you can think of as soon as you see in the clinic, in the surgical clinic? 1, 2, 3, 4.
Yeah, I would, could be some, see this 5 into 7, sarcoma would be my first differential. And as I told you, trauma would be another, trauma related hematoma or something that would have, that would be another differential. So maybe something, what do you call, aneurysm developing there, unusual, about 5 into 7 centimeters in size. Maybe a again, benign neurological tumor, but 1 month history, unlikely. So I would boil down just to sarcoma as one of this thing.
Okay. I would just add a couple of things to your list. Maybe a lymphoma or a soft tissue deposit from an unknown malignancy also can be added. Anyhow, let's leave it at that. So now, how will you proceed? You've seen this in the clinic, how will you proceed?
Yeah. So first,
I just want to add one thing.
Yeah, sure.
I had a similar patient, and what we found out is on the PET scan there was a inguinal lymphadenopathy. It did not, the resident did not examine it, but on the PET scan we found out the inguinal lymphadenopathy, and with the excision biopsy, and it came out to be NHL.
Yeah, that's what. Lymphoma is definitely a differential diagnosis here. The young age
exactly
and yeah, absolutely, totally agree. Point taken. So yeah, how are you going to proceed with this patient? Yeah.
So first, after clinical examination, I would also see a local office ultrasound to see what is the plane it is arising from.
Yes. So ultrasound is your first investigation.
Yes.
Yeah.
And then an MRI to see at what muscle and how is it closely present to any vessels, and if there are associated lymph nodes present along with it, any bone involvement.
Okay, I'll let you hold your thoughts there. And why do you think an MRI is essential and not any other investigation?
Yes,
and what are the important features you look for?
Because MRI will delineate about soft tissues much better. And as we know, this is not a bony swelling or bony hard swelling. So in order to delineate better about the soft tissues, I think MRI would be the investigation of choice.
Yeah. So the quick one-line answer is MRI is really useful to differentiate between benign and malignant. That will be the first one-line answer. So yeah, like you already mentioned, vascularity, neurovascular bundle involvement, skip mets, and involvement of marrow or medulla. So now this is how the MRI actually looked. So it showed a large 9 into 10 into 14 centimeter lesion, anteromedial compartment of the left side extending up to the mid shaft of the femur. The lesion is having solid and necrotic components, and there is no bone involvement. Yes. Now we are kind of, after looking at the image, we are thinking in the lines of malignant tumor. We have
yes. We have a lot of heterogeneity and definitely in terms of malignant picture.
Correct. Yeah. So we thought we'll just do the metastatic workup also, and the CT chest was also done.
Okay.
Dr. Srimant. So any other relevant investigations you want to think of before you proceed with further management?
Yeah, first and foremost, as you said about the MR, you put the right sequence on the axial, which is a contrast, but an MR with contrast is mandatory for a soft tissue sarcoma. You can't do a plain MRI and get away with it because characterization is actually difficult, and the neurovascular, bundle delineation is very important. No other investigations per se. You've done a staging for a CT chest, and I would definitely like to look at the, examine the inguinal region for any lymphadenopathy and look at USG abdomen, groin and abdomen pelvis to ensure that there is no nodal involvement which is missed, because that definitely changes the staging nowadays.
Yeah. So the staging is already, it's not put, but staging is done, like you mentioned. So before proceeding with the surgery or any other treatment.
Yeah. So the next step would be a biopsy, please. Okay, that would be an image-guided biopsy.
Yes. Okay. So so now you mentioned that the role of biopsy, and what are the necessary precautions, because we know most of the time we've been taught that you be careful whenever you are biopsying a sarcoma. So what are the necessary precautions you usually take when you're biopsying, or when you're taking a biopsy rather?
Okay, I appreciate that you put a few points there.
Yes, I'll discuss that.
Yeah, so from my point of view, we are good enough and competent enough to do a core needle biopsy, which is with a TrueCut gun, and it's a very minimally invasive procedure, and that can be done very safely with a local anesthesia or sedation as and required. The necessary precautions is that to ensure that you do not go in the non-surgical plane. What I mean is, the person who puts the needle in, or whether the radiologist or the surgeon, should know where the final incision is going to be taken care of. That's the most important precaution we would look at. That means talk to the radiologist, find out where the actual solid component is there, then understand where an incision is going to be, and then go ahead and do the biopsy.
So basically, image-guided core needle biopsy would be our best option.
So is there any role of, say I'm not a surgeon, but is there any role of angiography in this day and age before going ahead with surgery in this day and age? I don't know, I'm just asking.
From my point of view, no.
Okay, so you just stick to your MRI and a biopsy and then proceed further?
Yes, please. Okay. Until unless there is an actual encasement. Okay. And in that case, a CT angio would be more than sufficient to help her out.
But not in all cases as a blanket?
No, we don't do that.
Okay, fine. So finally, the HP came as high-grade sarcoma, and the case was discussed in the MDT, and our surgeon has seen, and it was decided to proceed with surgery. The surgeon was confident that they'll be able to take it out, so it was decided to proceed with surgery. Now we have a barrage of questions for both the surgeons, because we have taken to the route of the surgery. So now how do you manage? So we had a detailed discussion before in the preceding talks. Dr. Abhijit has shown clearly about the differentiation between wide local excision, radical excision, marginal intralesional. But in this particular case, I'm a non-surgical person. I think you would be going ahead with a wide local excision, isn't it?
Sorry if I may interrupt.
Yeah,
I would definitely want a immunohistochemistry and a characterization before I proceed.
Okay.
Because there's a lot of neoadjuvant treatments also available for soft tissues.
Correct.
I wouldn't take a high-grade sarcoma and proceed with it even though the staging is done.
Okay, so you would want an IHC before.
Definitely.
And then
or a karyotyping, whatever comes out. I want to understand what we are dealing with, and then only go ahead.
Okay.
Because the tumor volume is pretty large. It's
Correct.
a huge tumor.
Correct.
It's kind of enveloping the anterior. It's like anterior and the medial compartment, pushing the vessels down. So there's going to be a lot of treatment given for this patient. So I want to understand the biology and the histology of the disease.
Okay, so if you have a targeted mutation or something, do you have a role in adding something neoadjuvant here, that is what you're trying to imply?
Yes, please. Especially if it turns out to be a synovial sarcoma, I would like to think of some sort of neoadjuvant chemotherapy.
Okay, fine. Okay, point taken.
As per MRI, if you see the picture, if you go with a proper wide excision, you may not be able to get a functionally outcome limb at the end of the surgery because it's actually very huge.
Okay, okay, fine, got it. So anyways, so you've already mentioned about the factors, and whenever you decide about going ahead with a wide local excision versus radical excision in these kind of cases, just for the sake of discussion, so what are the factors you usually consider whether you go ahead with wide local versus radical excision? How do you decide?
So again, the margin has to be wide.
Okay.
I follow the Kawaguchi concept of curative margins. Depending on the anatomical barriers, whether it would be a compartmental section or an extra compartmental section, the margin has to be given. So for me, WLE and RE both nearly are the same as long as I give it a good tissue margin.
Okay.
We are actually not doing the compartmental, the entire
compartment.
radical excision. We are only sticking on to wide excision.
Okay.
And we are looking for functional outcome. So we have to plan after the margin, whatever the residual muscle is there, and we are able to approximate the muscle and at least get a functional limb.
Okay.
That is when we think about surgery. If we are not going to achieve this, then definitely neoadjuvant is an option.
Okay, yeah. So Dr. Srimant has already spoken about the role of upfront surgery versus surgery after neoadjuvant. You've already spoken about the histopathology and IHC and histology, which will decide as to neoadjuvant treatments. So now, Dr. Srimant, what is the role of periosteal stripping and when do you do it?
Yeah,
do you do it now?
In this case, again, there are two ways of looking at it. This is a case of a tumor which is encompassing more than 180 degrees around the femur cortex, and it is abutting the periosteum. The one section is not enough for me to understand what is the length of the periosteum which I am going to strip and how much is the circumference of the periosteum I am going to strip, whether it is up to be 1/3, half, 2/3. So length and the circumference are the two important factors to understand whether I am going to do a periosteal stripping along with the actual margin on the MR. So I could see that it was abutting, but I was not able to appreciate whether the tumor would be abutting the femur with just a pressure or the periosteum is involved. It's very difficult for me to tell. Are you asking me to let you know that my management here,
yes.
or just the
when do
periosteal
you?
stripping?
I would just like you to elaborate on what are the cases when you think about doing a periosteal stripping, or do you do it regularly to achieve a margin? That is the question.
Yes. So when I look at the MR, if something is abutting, a fat plane is there, I feel I can get away with margin with the periosteal stripped. So this case would definitely require a periosteal stripping if you're asking.
Yes.
Because it is too close for comfort.
Yes, the posterior fascia is too close, I believe. Yes.
And in this, I guess from about 1 o'clock up till 7 o'clock or 6 o'clock, I will be stripping the periosteum.
Okay.
That's about nearly more than 50% of the periosteum cover.
Okay.
The length I don't know because I don't have the sagittal to see.
Okay. So now, if you have done a periosteal stripping, you know that this is a high-grade sarcoma and definitely it's going to go for radiation though. So do you regularly practice prophylactic IM nailing for lower limb tubers for better stability when you send them for radiation?
Yes. So when we do a stripping of more than, I guess I would say from my point of view 50%, but technically about 2/3 is what we call it. A prophylactic nailing is required post resection of the sarcoma.
Okay. So prophylactic nailing is needed to achieve better stability and avoid fracture at a later date.
Definitely, because late fractures are seen with. See, the tumor volume is larger.
Yes. Yes.
So I guess we're missing on the point. The patient will have lesser morbidity with preoperative radiotherapy here compared to postoperative radiotherapy. So we need to understand whether this patient is going to go for neoadjuvant RT or adjuvant RT to understand the limit of periosteal stripping and the risk of fracture.
Understand. So these are the reason why we are discussing all this, to enable people to think about nuanced thinking.
So this means in this case, irrespective of the IHC, you were talking that you'll want to get an IHC done in this case. But this in such a case, high grade sarcoma, irrespective of the IHC, I think preoperative RT treatment should be taken up for preoperative RT prior to surgery, irrespective of the
yes.
IHC.
Okay, let me put it again in perspective. In this special case, tumor is reaching up to the skin, both on the anterior surface and the medial surface. Tumor is reaching up to the periosteum, abutting the periosteum, and having a more than 180 degrees of circumference of involvement. In this case, for me, the margin is narrow. In that sense, I would like to have a sterile margin component and see if I can subject the patient to preoperative radiotherapy as a priority irrespective of the histology. And if I get a subsequent histology, if there is an option, I would like to concur with my tumor board whether neoadjuvant chemotherapy works. If not, I'll keep it later, because this is a non-metastatic patient. The vis-a-vis chemotherapy neoadjuvant will always be debatable, but definitely neoadjuvant RT has a role. I do neoadjuvant, not neoadjuvant, nailing is definitely recommended in this case. Okay. That's how I would put at it as my way of managing things.
Okay. Sometimes if the patient is quite symptomatic with rapidly growing tumor, so do you still advocate for neoadjuvant, or you just straight away go ahead with surgery? I'm just putting different perspectives into play here.
I would still go ahead with the surgery and strip the periosteum and nail it. And
no, it's not about periosteal stripping, it's about the decision making. If the patient is...
This is excisable upfront.
Yes.
Better off if I can give a neoadjuvant radiotherapy.
Okay. So now that you have stopped at the concept of discussing margin, so let's look at the data as to what is the width of resection margins which is usually advocated, and what is the evidence behind, and why are we so particular about having margins. We all know that margins definitely have a better prognostic and predictive value for local relapse. And if you look at this particular data which is published from Austria, compared to the control arm, the R0 arm, the R1 and the R2 have fared bad with respect to the local relapse. So all the evidence has been compiled, and if you look at it, the positive margins have got bad outcomes with respect to local relapses. So, and just going ahead with that particular data, so they have looked at, different group has looked at different clinical scenarios where they asked a very interesting question, whether a positive surgical margin sometimes can be optional, or can you leave a positive margin just in case if you have a very closely abutting critical structure. So they have taken 169 patients with positive margins, and they have stratified into 3 clinical scenarios: a critical structure positive margin, the tumor bed positive margin, and an unexpected positive margin. Of all these 3 clinical scenarios, you are okay actually to leave a critical structure positive margin just in case if you want to spare the critical structure. That's what this data emphasizes on. And other thing is, if you again look at the local recurrence-free survival of all the 3 clinical scenarios, the unexpected positive margin has fared bad with respect to the critical structure positive margin. So the control group is quite strong. Almost they have compared it with 1200 patients, odd patients, where the margins were negative. Now, anyhow, the patient underwent a wide local excision, and the postoperative histopathology came as high-grade spindle cell sarcoma with a differentiation score 3, mitotic count 3, and necrosis score of 1. Margins were negative. And FNC-LCC grade 3 and score 7, LBSI was negative. Yeah, Dr. Shantivir, would you please elaborate on this report and the importance of FNC-LCC? So back in the day, we were just only looking at the tumor, and we were not looking at any other variables. And the only thing our professors used to ask in the clinics when I was training is, there are 2 malignancies in the body where the grade is very important. One is the brain and one is the sarcoma. So I'm just reiterating the same thing what my professors used to emphasize on, but yeah.
Yeah, this is important. Apart from that, now means the FNC grading system is what you follow, because that guides them their management. And also I would like here, as was rightly being said, I would like to try and classify these tumors, just not like spindle cells. So after doing all the markers and all, if I can't say which differentiation is there, it is different. But if you can try to, because histology also makes a lot of different type of tumors. Spindle cell sarcoma can be anywhere from MPNST to a synovial sarcoma to any other sarcomas with spindle cell morphology. So when grading system is very important, that is definitely important. At the same time, I would like to classify this tumor, try to subcategorize even on a lineage differentiation and also molecular differentiation. That is also very important, because if you want to further manage, or if you have some new adjuvant,
you mean you want to keep it ready for the future?
Yeah. Anything. Just a broad category of diagnosis would nowadays in this setting would be the last option. Okay. You try to subcategorize what type of histology we are looking at, because the same spindle cell with different mutations may have some specific targeted drugs, and also that I would like to further classify apart from the grading system.
Okay. So now this is how the FNC-LCC grading system looks at. So like I said, back in the day we were only looking at the tumor size, and the depth, whether it is superficial compartment or the deep compartment. So now we have a barrage of other variables like the differentiation criteria, the necrosis component, and the mitotic index also. Based on that, you finally get a histological grade of grade 1, grade 2, and grade 3. So now let's quickly, so now we have kind of moving from group to group. Now we've finished the surgery and now comes the role of adjuvant treatments for this patient. Dr. Bindu. So what is the role of preoperative radiation and rationale? Dr. Srimant has already spoken a bit about it. And so whenever you see a patient like this and when you're sitting in the MDT, so what is the rationale you would like to propose to your colleagues, and what are the pros and cons of preoperative radiation?
Yeah, before I jump into preoperative radiation per se, I would like to, in the MDT itself, categorize the tumor better and get a proper histological diagnosis before advocating for any sort of radiation, mainly because there are certain histologies such as myxoid liposarcoma which are extremely radiosensitive, and giving preoperative radiation in those patients translates into better overall survival in literature. So that is my first point. And secondly, we have evidence both for pre-op and for post-op radiation, with different centers practicing different modalities. And it again depends in the MDT on the comfort of the operating surgeon. And I have seen both practices. In the West, as Dr. Laskar rightly pointed out, they go for preoperative radiation more often, simply because it is smaller volumes at the time of radiation, and the long-term outcomes, despite poor wound healing rates post-surgery acutely or subacutely, are excellent with pre-op radiation as compared to post-op radiation. Post-op radiation, we have to give a higher dose, and there is a component of hypoxia which we have to overcome, and the volumes of radiation also are bigger. Because we have to encompass a larger volume of tumor bed.
Yeah, so you've already discussed, that was my next question actually, but anyhow, you've already spoken about that. Thank you so much. So now, Dr. Keshav. So, I mean, we all know about the indications of radiation, but can you just quickly summarize the indications of radiation in the post-operative setting?
Yeah, before going to the post-operative setting, I just want to add one point regarding pre-op RT. So it's like many people are going towards pre-op RT than post-op RT today. So we have to choose the right patient for pre-op RT. That is the most important thing. So when we are talking about lower dose or wound complications, you have to choose a patient who will not have post-op wound complications. Exactly. That is the most important point of choosing pre-op RT. So if you see upper limb versus lower limb, the data says that if you take an upper limb sarcoma for pre-op RT, the chance of wound complications are very less compared to lower limb, and the age also, and other factors like diabetes, etc., or vascular insufficiency. These all things should be taken into account before taking up a patient for pre-op RT. You just can't take every patient for pre-op RT. That is one point. And regarding post-op RT, the indications are very clear. One is the size, that is size more than 5 centimeter, deep-seated tumor, positive margin, and the grade also. Grade is also taken for as an indication for post-op.
So now this patient has come for a post-operative radiation, there is no doubt about it.
Yes.
So now let's quickly discuss about, I think we are running short of time, let's quickly discuss about margins and the volumes and the dose what you're going to give for this patient. This patient, remember, is, just reiterate, is a margin negative patient. And is there any role of hyperfractionated RT here?
No, in the post-op setting, especially for extremity sarcomas, there is no role of hyperfractionated RT. It's not proven.
Okay. So so what margins do you follow in your
So we still follow the shrinking field technique, that is 5 centimeters superior inferior and 2 centimeters radially for 50 gray, and a boost with 2 centimeters radially and 3 centimeters.
Okay. So what technique do you do? What is the technique you follow?
We do the IMRT, or the intensity modulated radiation therapy.
Yes. So do you think there is any role of newer modalities? Dr. Laskar has given a very elaborate presentation about the role of newer modalities. So do you think there is any role of newer modalities?
Depends on the site. That is the most important thing. If you have a paraspinal sarcoma, where you
we are very clear on what we are discussing.
Yes.
It's an extremity sarcoma panel.
Yeah, that's what. In extremity sarcoma, we don't have an advantage of doing with the newer modalities. Only say paraspinal tumors which are close to spinal cord, that's where proton therapy will be used.
Okay, thank you. So now Dr. Bindu has very rightly pointed out about the role of having a proper histological diagnosis beforehand. Because if you look at the data about the tumor volume changes following pre-op radiation in borderline resectable patients, either be it in the limb or in the trunk. So again, if you look at all the evidence, so most of this evidence after the preoperative radiation, there is a very good pathological and radiological tumor response. But having said that, all this evidence comes from one particular histology, which is the myxoid liposarcoma, which in general have an inherent radiosensitivity. So that is the reason we actually need to know the exact pathology and then go ahead. So histology is the main driver before you decide on the preoperative radiation, and whether the location is also plays a major role, like Dr. Srimant was pointing out. Surgical margins, and also if the patient is borderline resectable as per the surgeon, then better to go ahead with preoperative radiation. So now as to why do we advocate for postoperative radiation? First and foremost, radiation is a local treatment. We have to be very sure on that. It has no benefit on overall survival with respect to extremity sarcomas. Initially, when the surgical modality was used alone, the loco-regional relapse rates were close to 30 to 50% based on multiple publications from 1970s and 80s. And after that, with that premise, they've started an randomized control trial which showed a 20-year follow-up. The initial idea was to reduce the local relapse rate to less than 10% by addition of local treatment. But they have done fairly well. So they've reduced the local relapse to close to 1.5%. Of course, there was no effect on OS. Just going further to that, brachytherapy, of course, I'm not trained in doing a soft tissue sarcoma brachytherapy. Even the long-term results of brachytherapy in the adjuvant setting, the local control was definitely better compared to surgery alone. So now Dr. Ram Gopal has clearly discussed about the role of margins and etc. in post-operative radiation setting based on this trial. This trial has clearly looked at reduced margins versus conventional margins. Of course, they did not find any difference in limb function at 2 years based on the test scale, the Toronto Extremity Salvage Score or the local recurrence-free survival. So, and he's also emphasized on the fact that they're doing IMRT. So this IMRIS trial is an RCT looking at IMRT versus conventional radiation. The primary endpoint again is a local relapse. Even though the IMRT arm has bad patients, like older patients with high-grade lesions with close or positive margins, the IMRT has fared well. So now coming to the role of hypofractionated radiation, what I asked, so there is evidence which is upcoming, small studies with most of them are prospective databases. As on today, there is no definite conclusion available. The evidence of hypofractionation is still evolving. So now Dr. Laskar has spoken about the role of proton-based radiotherapy, and data is definitely emerging for proton therapies, but mostly in difficult sites like pelvis and spine. Now, let's quickly move on to the next group of our panelists. The patient successfully completed adjuvant radiation. Now, Dr. Madhuri, what is the role of adjuvant chemotherapy here, and how do you decide what all patients are going to benefit? Do you offer adjuvant chemotherapy for this patient?
This particular patient, if histology is there, it would have been more helpful.
Yeah, that is the histology we have. No, yeah, patient was operated outside. So.
Yeah, so large tumor size, higher grade, deep tumor, and again histology. All this are indications for adjuvant chemotherapy in this particular patient.
So is there a role of NGS or molecular in the adjuvant setting based on which you make up your decision in the adjuvant setting?
Not in the adjuvant setting.
Not in the adjuvant setting. Okay. So yeah. So we typically use this app regularly in our clinic. So initially I thought this was some app which has come out of thin air, but no, it has clearly been validated in multiple cohorts, like large cohorts rather. It was an Italian study to start with, and even I didn't know, so our medical oncologist colleagues they were very nice and they shared this with us. And if you, there are other multiple nomograms also, MSKCC nomogram to predict the loco-regional relapse. If your tenure, so based on this app, you basically input all the characteristics. Initially it was validated for extremity sarcoma and later on came to RP sarcoma as well. If you look at the 10-year overall survival as 60%, then there is some benefit of adding adjuvant chemotherapy. So now let's quickly, I just need 5 minutes, sorry. So let's quickly go to Dr. Mohit. So now patient presented with a lung met after a DFI of 1 year. So now how will you proceed? Staging was done. There are no other lesions. Only one solitary lesion. So
One solitary lesion.
One solitary lesion in the lung after a DFI of more than a year. So the patient has come to you, and do you want to send this patient to your surgical colleague who's sitting next to you or your radiation colleague? Yeah. Remember, the moderator is a radiation oncologist.
Surely I'll like to explore the surgical option here.
Okay, so why not radiation? I mean, you're sitting in an MDT now. It's a small tumor. Clearly saberable. Yeah. Dr. Bindu can. Dr. Bindu, you want to take this question? Do you think you can saber it?
I mean, technically yes, but
Okay.
I will still take the surgical opinion.
Yeah, surgeon is there.
Mastectomy.
It's a peripheral locating
Trumps.
tumor, and it's a very easily amenable for surgery. I think
It's
surgery would be the
wet.
first, provided there are no metastases elsewhere.
No, there's single met in the lung, peripheral.
So
Yeah, Dr. Shivendra want to
yeah,
dissect it.
definitely amenable for surgery.
Okay,
I
so
would also
Yeah.
take the patient's
Consent.
I mean,
that's always
give both options. To
give
the
both the
patient,
option. Okay. Okay, fine. So you will have a combined MDT with a patient, or a combined discussion with the patient rather. Okay, fine. So now if you look at the guidelines, yes, surgery is the first thing, but yes, you can also do a saber. And the chemotherapy here is optional. Of course, the patient underwent a metastatectomy. So Dr. Mohit is sitting very close to Shivendra, and we sent the patient to Shivendra and he operated. And the post-operative histopathology came as metastatic deposits of sarcoma. Again, IHC confirmed the same. So no chemotherapy was offered. Now the patient came back with multiple lesions back to Dr. Mohit again. So after 8 months from the last treatment, now how do you want to go ahead with this?
See, I'll in this case I'll now do an NGS.
Okay, great.
And then proceed regard the palliative setting, like palliative chemotherapy.
Okay, so what chemotherapy do you want to offer here?
See, I'll discuss with the patient that the chemotherapies they don't work very well in sarcomas. Is what we have seen, except for very few variants in sarcoma like synovial sarcomas and all. Otherwise, they very poorly respond to the chemotherapy.
So is there any role of targeted therapies in the first line?
In the we don't have a concrete evidence regarding this, but yeah, we have seen patients like I had a patient who was red positive on NGS and was given a trial of serpelcatinib.
Serpelcatinib,
So
yeah.
and he responded very well. And
Yeah.
we had an ALK positive patient and started on crizotinib and had a very good response.
So in the first line, you mean?
Yes.
Yeah.
If you have a target, and then definitely you discuss with the patient, and because patient does not respond very good to chemo also. If you have a target, then definitely why not to use that?
Okay, but I believe still I'm not a medical oncologist, but I know there are lot of targeted therapies available, but still I think the evidence still points towards the chemotherapy in the first line and then go ahead with.
But the evidence is evolving. I mean,
Yeah.
we have to give the options to the patients, because we know that the patient will not respond well to chemotherapy.
Okay.
So the ifosfamide and idriamycin based chemotherapy is an option, and we know that we will discuss the toxicities with the patient also. He's a young patient, 25 years old
Yes.
patient, and a high dose of adriamycin steroid, and this fertility preservation is also very important in such
Yes,
patients.
yes,
So all
yes.
these things keeping in mind, so we have to discuss this with the patient regarding the feasibility of chemotherapy versus the targeted
Yeah.
therapy, if the target is available.
Yeah. So I think we are running out of time. So now,
Sorry,
yeah.
what did the histology turn out to be finally? You got the patient twice back to you.
Sorry?
What did the final histology turn out to be?
So
The patient came back
unfortunately,
twice.
this patient got operated outside and was referred for radiation here.
Okay.
So we couldn't get to the bottom of it, and the NGS and all. I mean,
No,
I'm
it should
not-
have turned out to be at least one of these diagnoses.
Yes, one of these diagnoses for sure. Yeah. So yeah. Anyhow, thank you so much. So I'm sorry we did not have much time to discuss the next case. Anyhow, so to conclude, there is a significant evolution in the management. Limb salvage has now become the standard of care. So Dr. Mohit and our radiation oncology colleagues also have discussed about the new radiation techniques, and there'll be a significant change in the future as to how we manage the sarcomas. And thank you so much, all my panelists and all the audience. And if you have any questions, we can probably take it later. I think we are running short of time. And yeah, thank you for your incisive and insightful comments. Thanks again.
I thank our chairpersons, moderator, and our panelists for the insightful comments during the panel discussion. For the forthcoming sessions, I graciously call upon our chairpersons, Dr. Srikant and Dr. Yugandhar Sharma, to grace the dais. I now call upon our next speaker, Dr. Shumar Sekhar, to guide us through the topic intraoperative therapies in RP sarcomas.
Thank you very much. I know it's a fag end and everybody needs a strong double espresso, double shot black coffee. But always the people, the birds which stay last get the best feed. And those who are staying at this time will get the best knowledge. Thank you. So I bring warm regards from my institution, Aster International Institute of Onco. This is essentially a work of my radiation oncology team. I'm a surgical oncologist. So Dr. Belliyappa, Dr. Sunita, and then Dr. Ram Alva, and Dr. Jayant, and there are 6 of them who got trained in intraoperative electron radiation both in Spain and Italy. And we took the first intraoperative electron in India. So done more than 218 cases, and I'm just borrowed a lot of liberal slide and radiation onco component from them because I may not know too much, but this is a protocol which has been made and we follow. So I'll try to introduce to this topic, and in the coming time when we complete maybe 5 years, we'll know the DFS and OS benefits. Retroperitoneal sarcoma are inherently totally different than a peripheral. Peripheral are usually operable. If a limb salvage issue is sorted out, if patient can afford a good prosthesis, or if it is chemosensitive, you have a new adjuvant, it's fairly easy. Neurovascular bundle, if you can sort of maintain, most of it is easy. But retroperitoneal sarcoma is totally different. There is no limit. There is nothing called non-operable in retroperitoneum, but then patient should survive because duodenum, pancreas, all the vital organ goes, you add a morbidity, it's gone. So the concept of compartmental resection retroperitoneum is limited by a lot of vital structure where you may cross the thin line of benefit versus complication morbidity outweighing the benefit. That is why even though you may have a master super type A egoistic best surgeon, but you can't do it because you can remove the tumor from the patient, you can't remove patient from the tumor. So that is why surgery is a key element in retroperitoneum, but R0 resection, selected cases, selected way, most of the R0 would be R1, and when you say R1 it could be R2, and then unlikely those patients will be cured. So we know that most of these patients are asymptomatic, so they come with very big tumors. They will find all the gutter that they want to go, and the favorite gutter for these sarcomas, if they are on the right, is the paraduodenal area going, which is a nightmare for all of us, and left is the easy because you can salvage almost left part of abdomen, everything, including stomach, spleen, distal pancreas, left kidney, left colon, happily. But the moment they are in the right, it's a tough issue. So which means there is an inherent problem. That is why the local recurrence, now exploration has been happening. Can we give a component of neoadjuvant radiation followed by intraoperative? Because if you try to give everything neoadjuvant, then the dose limiting factor of the kidney, duodenum, small bowel do come in play. Is there any way we can stop little early at 4,000? And then if you have an intraoperative machine, can we do the remaining only to that area where you think posteriorly you are close or you may be R1? So the evolution of surgical procedure is involved organ resection, compartmental, even though it gives DFS, local control, OS is yet to be fully proved, and histology tailored resection. So we moved from this to NGS era. So we all know these are the types of resection. We would love to do R0 in retroperitoneal. Quite often you may end up with R1, and when you think it is R1, probably those patients will keep ending up with multiple surgery without cure. So is it possible to always do this extended resection with a negative margin posteriorly? Because the vertebra, pancreatic head and duodenum are the limiting factor. It is not that you can't resect, then those patients will start having mortality which is not accepted today in modern surgical era, and the morbidity which will be so high that actually whatever benefit survival you may get go off. So if you look back the algorithm, we always consider what is the patient characteristic, performance status, function, priorities and goal for that patient and the comorbidities. Then tumor characteristics, so you look at what is the grade, what is the IHC, what is the NGS, what is positive. then you decide what is that needs to be removed, anatomical, vascular, because the vascular structure, number of mesentery, short bowel, gut, and pancreas duodenum are becoming a limiting factor for you to do. Then look that are you lucky, are they one of those which are sensitive for neoadjuvant, then you tailor-made them. Then look who are radiosensitive for radiotherapy. Then balance the systemic mat sources local. If something is loco-regionally aggressive and systemic disease is not, you should do everything in your limit to achieve that. If a tumor sarcoma is aggressive systemically, then you have to take a thing, the local risk heroic surgery may not translate because of distant metastasis that may happen. Then you look at the systemic. So these are one of the algorithm you will take. So these are some of the myth people have. I know all surgeons say sarcoma is not sensitive for radiation, but that's a myth. We all know that there are some sarcoma which are highly sensitive, which is very important. I will tell you that if you go to a surgical oncology conference, IASO, my colleague, 99 out of 100 will lift a hand as a surgeon that it is not sensitive. It's a myth. It's very important to understand tumor board is required. Don't say, oh, sarcoma, and what will medical radiation do? We just cut possible. Don't do that. There are a lot of sarcoma highly sensitive, remaining borderline, and depending on what you can do, they can help you. As we all know, myxoid liposarcoma highly sensitive, hyperfractionated component now is coming up. Concurrent radiosensitivity is not yet started. Unresectable, if you can't operate, don't call it today. They may still benefit and individualize future tumor biology. So these are the clinical questions you ask, and there are strong answers to all of them here, which means we are not tapped and explored this. So that is one of the reasons when we look at the various factor, you just look at which is the patient which has the lowest recurrence and which has got the highest recurrence. If you can do compartmental good, but OS benefit is not yet proved, but you may still achieve, if you can come out with less to low mortality with very acceptable morbidity, beautiful. But most of the patients sit between these two curves. You can do a good wide excision with the organ, may not be actual truly compartmental, but a partial. And then if they recur locally, able to re-excise and salvage is a very important OS factor today, definitely. So you look at where we are, and take my word, very few are like this. Most of them come between these particular curve. So we all know typically depends on the left and right. You start from here central, medial to lateral, because once you have a vascular access, kidney preserved, not preserved, duodenum, paraduodenum, portal vein, rest part, as you go to periphery, God has disposed them off. You can remove a lot of them and get away, because God is there and takes care of most of our patients, whatever we do as a surgeons, provided central area. So that's one of the concept of retroperitoneal sarcoma. Go from medial to lateral, and then as you move from medial to lateral, morbidity, mortality starts coming. I will not worry, because everybody may not be surgeon here, how to do, what to do, where to do, everything. But just slowly, if you come down around, somewhere around this area, good planning, what are the limiting factors for the right, how to approach the psoas, because kidney and colon, adrenal easy, and how you go on the left, which is one of the easy sarcomas to do. But then looking at middle 1/3 and how you handle IVC, because if you are at the lower part, it's quite easy. You do a cattle brush maneuver, vena cava, you control above and below, quite easy. But as you go up, you must be ready for complex liver resection. So these two areas, so the location right or left, upper or lower, histopathology, able to resect or not. This was already shown by my colleagues previously, including Shraddha, what constitutes a compartmental for right, then left. As we know, left is the easiest, right lower part is easiest, and as you move upper part, then you need to decide what you want. Do you want to add a colovipulse or not? So like for example, the most important is functional preservation, removing the organ intact. So this is a typical way, like the colon, then the kidney and the sarcoma in one. But you should be lucky. 1/3 of the time you will not get a beautiful specimen like that. Take my word. You will have multiple pseudopoda like projection posteriorly, and you lose a conclusion where there is a fat, where there is any fat you leave in the posterior potentially will recur. So this I told you, left part is quite easy. So that is why more extensive resection, more morbidity. And this morbidity can increase as and when you start knocking off more organ. So if you see the large resection, 30-day morbidity today really goes up to 16 to 8% for patients who undergo multivisual resection. So these are all the rationale. All of you have read this landmark paper. You look at the category 1 to 6 and look what is the reason to remove these organ, the tumor or you. Because you in retroperitoneal sarcoma, sometimes you sacrifice some organ because of surgeon-induced trauma or the encasement or adherent, or just you presume that it is there. So if you look back, which are the one which has got the highest invasion, this has been showed already. So de-differentiated, so from here to this. So you know the disease which recurs loco-regionally with less chance of system metastasis is where local aggressiveness carries. So I'll not bore you. So this is what the factor. So what are the alternative option where one size fits compartmental cannot happen? Where you do histology driven, data driven, different modifications. Surgeons have been doing this for donkey years without any improvement. So what is it? Because surgical skill has improved, what more can you remove? You remove everything and you manage come out safely. But is there any other way now looking at the histopathology where local recurrence is high, less systemic metastasis, we can modify our surgical technique. That is why the role of radiation came. Why pre-op radiation? We know that in human solid tumor now, if there is an indication for radiation after surgery adjuvant, take my word, it is better delivered pre-op except breast, and now already neoadjuvant RT trial in breast has also started. So you can very clearly see gross tumor volume GTV, well vascularized. But the problem is, if you complete the full 5000 or 5040, you will end up with toxicity. So that is where high electron energy beam came in. So if we can stop at 4000 or 4500, then operate, and while operating, you know that posterior margin, we know anteriorly, right lateral, left lateral is not the place which is the risk for a surgeon. It's the posterior. So what is the update that we have at this point, and how these fundamental particulates can improve? So, you know, this is a very famous saying which comes for every non-breast cancer sarcomas, you know, anywhere in this. So whatever you achieve local control, eventually should actually change survival. If it is a low grade, every recurrence you prevent for once patient's life is saved, and if it is a high grade, it is 1:2. So is there any way we can integrate radiation during surgery and tailor-made it post? So lot of work has happened, pros and cons against this. What to use? Brachy was traditionally used, and we know it's not a, you know, you cannot cover a very wide area. Low energy, not a very great way. Electron beams can actually, by radiobiologically, beautiful way, you know, it covers excellent. So that is why it came. Typically, Mobitron and SIT Sordina are the two machines which are available worldwide. When I was in Mayo Clinic, Mobitron was like one big machine, only one OT you can use fixed to, and I really hated that machine. So when I took the machine, I was very clear, I need a machine which is movement, which can move from OT to OT, and you don't have to shield and make a separate OR, which can be moving everywhere. Beauty is, imagine that if you have given neoadjuvant and you know which is the risk at the posterior, if you can give 10 to 20 gray, you know, neoadjuvant or adjuvant, so if you can do this particular area. So vasculature where you cannot achieve R0 or paraduodenal area or retroperitoneal area or on the spine, if we can do to achieve. Beauty of the IOERT I have, and which everybody uses society world, is multiple applicators, side bevel, front on, left, various sizes, beam, you know, field in a field, multiple area you can do, and you can shield the nerves. You can wrap it and take the nerve obturator nerve out. You can take the retroperitoneal nerve. You can take the vena cava, and then you can take the periparantic area, colon, everything, because this whole treatment takes 35 seconds. So in 35 seconds you can always do, there is no fluid. This is how the machine looks. So you have multiple applicator on the docking, and then there is a treatment planning unit which is a 3D ultrasound which is built in that, which it gives. And this particular machine is 500 kg, mobile unit, OT modification is not required, it can be used. There is a beam stopper below, and then it is plug and play. It is just the same one which you use for your hair dryer, and no disposable item per patient to be built in this. So this is the machine I have, which is SIT Sordina. And then the TPS unit will give a 3D. You know, you just do an ultrasound, there is a treatment planning navigation which comes with this, and it will give a 3D of what it is, and then you can actually decide how to do this particular area. So all of you, if you have not read this phase 3 STARS trial, to look at, you know, randomization where you use neoadjuvant RT surgery plus IOERT to do that. So intraoperative radiation in soft tissue, recently ESTRO and IORT recommendation has come. What should be the dose in soft tissue sarcoma and retroperitoneal sarcoma? And you can go back. So this is a good paper which showed a good combination of intraoperative radiation by electron with or without EBRT, adjuvant or neoadjuvant, had a significant benefit. So significant benefit in survival using surgery combination in retroperitoneal where you can't achieve, where the Kaplan-Meier curve separated off. But this is something which is controversial. We need to prove overall survival benefit in all soft tissue sarcomas, which needs to be built up. So preoperative radiation, so Strauss trial, Ursus structures, if you read the difference between the both of them, currently there is no overall survival, you just have a good loco-regional control. So this is where the intraoperative trial, old one came when IOERT machines were not there. Now IOERT in retroperitoneal sarcoma is moving towards organ preservation and oncological outcome. Like my machine is 2-year-old, so all my data is only 2. We have done around 216. So it's too early because 5 year, 10 year, 7 year is required. But the Italian group and the MD Anderson group in Spain, they have a large data where a lot of publications have come which looked at this particular. So now the current indication which would have is as a boost with pre-op EBRT. Or during operating you end up with a R1 margins, close margin, which is that area, intraoperatively you can give a good boost. Or for recurrent sarcomas, you are going back and operating, or already radiation is exhausted. So these are the 3 areas which I get referred all the patients across India where you can look. Then we looked at recurrence is where is the initial site, where the recurrence has happened, where distal. So we set up a tumor board and then we look and we decide how to look at this operative radiation to come. So histological type tumor grade initially was not a significant overall survival. But as we know, a sarcoma which has a systemic high potential, then loco-regionally it may not be. I think most of you must have read this post-operative nomogram 12-year sarcoma specific death, which was published in Journal of Clinical Oncology 2022. It's a little useful, various size, depth. All retroperitoneal sarcomas are depth. Then histology, age, total, and you add the points. And if you go towards this, and then the nomograms adds the more point, and then the more the risk. So has the outcome has changed over last 15 years. So this is, the study showed that the surgical techniques improved, so chance of ending up with positive margin has started coming down. So if you look back in the retroperitoneal sarcoma referral center, 61% patient who had surgery, 79% of these patients won this period. So if you look back, slowly local recurrence has come down. But is it adequate? Not yet. So this is at my center in the Bangalore. I borrowed this slide from my radiation oncologist. So we went through this rationale. We do a histopathological analysis, grading, IHC, wherever necessary, NGS, a better imaging. We have a tumor board and then we look at this. What is this particular? We adopt routinely neoadjuvant radiation followed by surgery and IOERT. So typically, 45 to 50 and then 1.8 to 2 gray. So we do, and bowel is all taken out. So the wound related issue, actually in all the cases we have done, we were worried wound related issue would be there, seroma, fibrosis, but it's quite good so far in 2 years. So this is the technique. So what it means for us surgeon, multivisual resection, we know where is anticipated complication. I can take them away from radiation field and I know where I'm going to end it up. So this is my OT-OR1. It's a 500 kg machine, multiple applicator. This is a beam stopper. These were some of the preliminary evidences which we discussed in a tumor board when we made the protocol from various other institutions of using IOERT integrated with neoadjuvant RT. So what is the concept? Single high dose electron, typically 10 to 20. Remember this 10 to 20 biologically is a very high dose, what you deliver in this. The machine we have can give in excess of 30 gray if you want, but it is not used because for a boost we typically go between 10 to 12, and then if it is as a single dose in a recurrent, we normally don't go beyond 18 or 20. So so it can even give up to 30 gray. So surgical step is we resect, we identify where it is possible, then we move all of them, and then the IOERT is actually done. So we have done for retroperitoneal sarcoma alone about 34 cases. All the patients that came were liposarcomas. One patient had undergone 5 surgery previously. Most of them, some of them were treated by prior RT, and if it is come de novo to us, we do neoadjuvant TBRT following this. Dose of 18 day was given in the cases. Multiple applicators were used. Sometimes we can do field in a field, pushing the nerve. And then we analyze the patient. So, some of the sarcomas, you can see extensive resection and we know where it is retroperitoneal on the spine, psoas, where you may think you are there. Multiple applicators are available. The whole Duration takes 35 seconds to complete, and you don't have to change the OT. And this unit is mobile, move from one unit to unit, moves to GI unit, breast unit, our unit, because in our institution, all the intraoperative breast conservation boost is through IOERT only, and eligible patient go for APBI. So this machine moves from everywhere. So we identify, label all of them, then all the structure are moved away, wrapped away for 35 seconds, and then we deliver it posteriorly. So this is one of the case we did about 2 weeks back. So because surgeon can control the structure for 35 seconds, usually you can actually give back. So historically, these were some of the evidences we have discussed. Typically 10 to 20 gray. You can use depending upon a boost, because we use neoadjuvant EBRT in our patients. So these were some of the practical rules. When does it help? Usually posterior, vascular, psoas margin, where R0 may not have been achieved. Typical dose 10 to 20 electron. Almost combined with EBRT before. Main risk, neuropathy, fistula, but you shield them. Does it improve survival? Today no evidence, but locoregional can benefit. Who should go to IORT? Unresectable gross disease should not undergo. You need to at least do a R0 or a R1. So what is this? Pre-op shrinks, margins are sterile, and during surgery it gives a R1 dose. So this is the algorithm we have, last 3 slides. Retroperitoneal sarcoma, we work up completely, metastatic cervix core biopsy, then IHC wherever feasible, and NGS. We put in multidisciplinary sarcoma at our center. We look at the histopathological, well differentiated, low grade, yes. Tumor large, posteriorly close, yes. Then pre-op RT with IOERT. No, then pre-op EBRT usually not recommended. Then we restage, plan surgery 4 to 8 weeks. If it is intra-op assessment, suddenly we call, not fit into one of them, then we assess where is the high risk. Yes, expected R1, then we displace everything and we do the complete closure. Combined strategy, selected case of pre-op EBRT, planned resection, posterior margin, yes, add IORT, no, then we don't do that. So these are some of the evidence that are coming up with IOERT and neoadjuvant EBRT. I don't want to bore you with this, you can go back and read. I wanted to introduce the technique we have been following. So how this changes, histology driven, anatomical situation, counseling the patients against pros and cons, and then you can try to achieve more posterior R0. So this is where we are able to do with a high dose, very short treatment duration, low cost, and we can stop high away. So what are the current trends? Move towards centralization, high volume sarcoma centers, which has all the anonymity. Use of pre-op RT, try to do it. Histologically driven. Rather than post-op RT alone, try to integrate intraoperative if you have an IOERT machine, and follow all the guidelines which are created. So conclusion. Outcome is, if a surgeon cannot resect it with a R0, no matter what you do, unlikely that patient is cured. A good strategy with radiation oncologist will help you to achieve a good negative margin. At present, surgical clearance with clear margin is most important. Rather than adding anything adjuvant, try to see if we can add new adjuvant. Thank you very much. And I invite everybody to HIPEC Congress, which we are hosting in Ahmedabad in 2027, first time from Pesogi. Thank you.
There's hardly any time for questions. If there are any questions, you can ask Dr. Somashekar at a later session.
Thank you.
I will proceed on to the panel discussion now.
Thank you, sir, for this informative talk. We now proceed further for the panel discussion on the topic RP sarcoma. I request our moderator, Dr. Sridhar Dasu, sir, to please come up on the dais.
Yeah, I think the mic is on right now. So at the end of a very engaging session, I think I'll have to do something to spice it up. I'd like to call all my panelists on stage So, Doctor, we have two surgical oncologists today. Dr. Rigved, who is a surgical oncologist. He was previously at Homi Baba and right now at KIMS Hospital, Begumpet. Dr. Ajesh Raj Saxena, close friend and senior surgical oncologist from Apollo Hospitals, Jubilee Hills. And then we have, I think we have three radiation oncologists. Dr. Vijay Karan Reddy, who is a senior radiation oncologist from Arit Hospitals, Hyderabad. Dr. Bharat Gurram, senior surgical oncologist, senior radiation oncologist from Yashoda Hospitals. Dr. Anusha, who is a radiation oncologist from Vijayawada, and is something unique that in an age of social media, I could not find a single picture of her to put something unique. And Dr. Anuradha, who is our clinical head and head of the Department of Pathology at AIG Hospitals. I welcome all the panelists on stage. A few house rules. The questions will be directed towards the panelists, and then the floor will be open to the chairpersons of the house. And in the interest of time, we would. I'm sorry, I forgot Ravi Jaiswal. I'm so sorry. The lone medical oncologist, Ravi Jaiswal. No. We need a medical oncologist. Yeah, I'm so sorry. Ravi, I forgot. Yeah. So, in the interest of time, we would try to. We have about 4 cases, and in the interest of time, at least for the sake of discussion, I would like to discuss at least 3 cases, time providing. So the first case is a 36-year-old gentleman, IT professional, presented with abdominal pain, lower limb pain, and he has a vague abdominal fullness in the suprapubic region and the right iliac fossa. His examination is normal, external genitalia, hernial orifices are normal. As is the case in most of our clinics, we actually get a patient coming with a scan, and I actually request the surgical oncologist to have a look. The first questions will be directed towards them. So this scan is going to be kept in a loop. All the panelists can have a look at it, and we'll wait for about 5 or 10 seconds. And once they're comfortable, I will ask the questions to the surgical oncologist. So I think one more last loop, and should be fine. So to Dr. Rigved. So what next? What do you think you're actually dealing with right now? You've seen the scan.
Yep. So it's quite clear it's retroperitoneal origin, and we couldn't make out the IVC properly. And other structures for me will be kidney and ureter. Right ureter couldn't be made out. Okay. So it's basically retroperitoneal origin tumor. So first thing is to rule out, to get serum markers, tumor markers, germ cell tumor markers for any RPE tumor. Okay. First thing would like to rule out.
Okay. Would you like any other imaging? I mean, or are you satisfied with this particular imaging modality? You got only a CT scan. Any other further imaging that you want?
Just to rule out distant mets.
Okay.
Thoracic imaging.
Yeah. So you're sure that you're dealing with a malignancy, or you think it could be something benign? Because sometimes it does happen that you are dealing with some retroperitoneal tumors can be benign also in 20% of the cases. Anything else that what would be a differential diagnosis in this particular case? You've seen the scan. It looks to be retroperitoneal, but what would be the differential diagnosis? Dr. Ajish?
So it looks to be predominantly midline. IVC is not completely visualized. It's neither seems to be displaced on either side, so it seems to be completely engulfed in the mass. Okay. And
based on the imaging, do you think it is one type of histology, or do you think it's some other particular type of histology? Based on the imaging, does it looks
to be malignant from
it looks to be
appearance.
malignant.
It's heterogeneous.
Okay. And does it contain fat? Does it have any fatty areas?
No.
Okay, so fine. Okay. So then, would you like to go for any preoperative biopsy in this particular case, or would you just go ahead with the surgery? I mean, if the imaging is up to your
I would consider to get a biopsy done.
Okay, great. So, what do you want to see, Dr. Anuradha, madam? What would you see when you want to see a retroperitoneal mass? What do you see in the pathology to for you to give a diagnosis? What are the differentials that you go through?
So when we get a retroperitoneal biopsy, the first thing I would like to know is what is the size and location of the tumor. And then in the morphology, I would like to see whether I can make any differentiation of any smooth muscle or any lipoblasts I'm identifying, or any neural differentiation, or am I thinking of any GIST or any high-grade pleomorphic sarcomas, and do a complete panel to.
So essentially you have 4 to 5 differential in your mind. You have liposarcoma, you have some smooth muscle tumors, neural tumors, and sometimes myofibroblastic tumors. There's 4 or 5 differentials that you have to actually rule out. Okay, so in this particular case, the biopsy came as leiomyosarcoma. So the markers were normal. And for the radiation oncologist, Dr. Vijay, so do you think that there's anything that you can offer in this particular case? Doctor, so many good talks, so much of data has been shed. Would you like to be involved at this stage, or would you say that no, let the surgical oncologist take the call?
No, I would discuss with the surgical oncologist, but I would not jump in and try to treat this case because there's no evidence for preoperative RT, especially when it's resectable.
Sure, sure. So there are, for the surgeons again, as you said, there are organs at risk. Both Ajish and Rigved have said. So what do you think is the organ at risk? Okay, he says that the ureter seems to be at risk. Right gerota seems to be at risk, but this is actually the sagittal section and the coronal section. So what do you think right now you are dealing with? Is it a leiomyosarcoma of the retroperitoneum, or is it a primary leiomyosarcoma of the IVC?
Primary leiomyosarcoma of IVC, definitely one of the differential diagnosis. And
so which is more, I mean, for the sake of the audience, we know that leiomyosarcomas are commonly, probably second or third commonest retroperitoneal sarcomas after liposarcomas. IVC leiomyosarcomas are rarer, or they are more common than leiomyosarcomas?
Rarer. They are
Yeah.
rarer.
So IVC leiomyosarcomas are more rarer, and but based upon the imaging, it looks to be more of an IVC leiomyosarcoma. So is there any way to differentiate between a retroperitoneal sarcoma invading the IVC versus an IVC sarcoma which is going out of the and going into the retroperitoneum? Yeah, Dr. Ajish, anything?
If there is something adjacent to the IVC, it usually ends up pushing the IVC towards one side.
Exactly.
So you see a crescent, which is usually seen, but this seems to be completely engulfing. There's no pushing kind of boundaries.
Yeah.
So it's
So I think,
arising
great.
from the IVC primarily.
Yeah. So I think even for the general audience, basically there are some few features which would say that it is it is not it is arising from the IVC. I'll come to them down the line. Any role for any MRI? Would you go for an MRI of the abdomen? Helps you in managing your case better.
I'd probably get a 3D reconstruction.
Great. So you would go for the CT venogram, Dr. Rigved. A CT venogram, would you? Or is this enough? A CT scan with IV contrast is good enough?
For the surgical planning, this appears enough right now because it's not creeping up or anywhere, because we can see the proximal, we can plan proximal distal.
Yeah, it's
resections.
below the level of the renal veins, above the level of the iliac veins. So probably IVC origin and appears to be good enough for you. So sometimes there is a role for MRI, especially with higher tumors. Dr. Som has shown, Dr. Shraddha has shown tumors going up to the hepatic ostia, going up to the right atrium. Those are tumors which may probably be beneficial with an MRI, although it also helps in differentiating between blunt thrombus sometimes and tumor thrombus. And IVC vessel wall involvement may be slightly better delineated with an MRI, but again, no evidence for the same. So again, differentiation, as Dr. Ajish has said, essentially there are 4 types of involvement of the IVC. One is known as the positive embedded sign. So the assumption is that basically the IVC, the tumor within the IVC is pushing outside, and therefore the IVC will be present, although at the periphery, then the IVC actually will be seen. This is known as a positive embedded sign. Whereas if it's a retroperitoneal tumor pushing the IVC, it is called as a negative embedded sign, and it is a crescentic shape. Or if the IVC is imperceptible at that particular point, then most likely it is an extra leiomyosarcoma outside which is pushing it inside. Rarely you will also get a tumor which is in the IVC with a thrombus. But you do get some some things which are not commonly seen. For example, so in this particular patient, you can see that this is a tumor. Yeah, there is no crescentic margin. It is going within the lumen, but the IVC is well made out. So most likely it is a IVC leiomyosarcoma. But again, as I said, sometimes you may get tumor thrombus even in benign tumors like paragangliomas. Negative embedded sign is seen in retroperitoneal tumors like lymphomas. Yes, definitely. So what would be your next step? Surgery? What surgery, Dr. Ajish?
Yeah, so next step would be to go ahead with surgery. And,
okay.
Most likely this is an infrarenal location. So I think we should be able to resect. I don't see any collaterals there.
Yeah, so how do you know that there are collaterals preoperatively?
At least on the scan, there don't seem to be any collaterals.
Okay. Any other, sign on radiology which would say probably there may be collaterals? I've not mentioned it here, but probably you should probably look for it. So if you have a thrombus which is distal to it, so the blunt thrombus, these are basically slow growing tumors. So if you have a thrombus which is distal to the tumor, so that would mean that probably there is a DVT which has set in, and most of the time that leads to collateralization. So a symptomatic DVT patient, yes, you should probably suspect that there may be good number of collaterals, and obviously the imaging also would be helpful, but we cannot assume per se that just because there's an IVC sarcoma that they will be having collaterals. So that's the point. So obviously surgery, would you go, Dr. Rigved, would you go for a resection and primary anastomosis, or would you go for a cavoplasty? Would you go for a graft, or how do you decide that?
So it depends on what kind of setup I'm working in.
No, you are right now in KIMS. You're one of big setups.
No. But the experience what we have got in multivisceral resections, we had some 7 or 8 IVC resections which were not reconstructed.
Okay.
So that's why it depends like what is the backup I have for myself. And
so when you say not reconstructed, do you mean that the IVC was ligated and then left?
IVC was transected.
Transected and ligated, and then there was. So but then how are the outcomes? It causes an acute thrombotic syndrome.
So all the 7, 8 cases didn't have acute DVT issues because
of
collaterals were already there. So that's why, and otherwise, but I was mentally prepared for a reconstruction, though we don't have a vascular grafts or surgeon immediately, to make it with a peritoneal graft, we were prepared.
So but if this, please
keeping in mind everything, we have the best setup and all kinds of backups, then resect the IVC and reconstruct it, put a graft.
So if there is a tumor which is going up to the renal veins, even then you would go for an IVC resection and then...
we have done till the left renal vein.
Till the left
Only left renal vein was...
Suprarenal, would you also do the same?
Suprarenal...
Because you can't, on one renal vein you are probably able to save by...
Yeah, so it depends again if left renal vein is having its own collateral developed.
Yeah. Which is more likely to have a collateral, right or a left renal vein?
Right one will be having more collaterals.
Okay, this is a theoretical question. So basically the length of the left renal vein is more, and obviously the gonadal goes to the left renal vein. So probably we assume that the left renal vein has got more collateralization. Right renal vein has got a short stump, and the gonadal directly drains to the IVC. So sometimes we are not sure. But if you have to probably salvage the kidney, the left kidney is probably easier to salvage because of the length of the left renal. Okay, great. So obviously if you have a good setup, yes. Whether you go for a graft or whether you go for a cavoplasty depends upon the size of the tumor and the extent of the involvement of the IVC. Predominantly intraluminal tumors, whereas this case is both intra and extraluminal. More than 75% of the wall is involved, long segment. So definitely we have to go. There's no question of cavoplasty. We asked our vascular surgeon to hurry. He said there's no cavoplasty, and we went for a resection with a reconstruction. So this is an en-bloc excision with negative margins. And the final report has come as high-grade leiomyosarcoma for Dr. Anuradha madam. So in this particular, in retroperitoneal sarcoma, everything depends upon the margins. Now, for this particular case, would you be comfortable in actually giving, what margin would you be comfortable in reporting, and what margin would be not comfortable in reporting?
So when the tumor is very big, obviously we need to look at the shave margins. The resected shave margin is one which I would like to see, that there's a free margin. But sometimes it's very difficult to assess when there is a well-differentiated component. So that is.
So in the final histopathology, how would you differentiate between an IVC going out versus an leiomyosarcoma with IVC involvement? Is it based on a molecular, or is it based on the gross? Or?
See, one is when this large tumor, extensive grossing and sampling is the key to identify the source of the tumor, as in this particular case, and also for looking for areas of differentiation of the tumor. So if you think that the tumor is arising from the vessel, we would definitely try to take more sample to see if we can try to differentiate the tumor is arising from the vessel wall, and then do IHC to see if we can at least identify the residual.
Any IHC to differentiate between IVC leiomyosarcoma versus leiomyosarcoma extending to the IVC?
So nothing, but if it is arising from the vascular, we would like to do vascular markers like 31, 34 to identify.
Great. So basically vascular markers in favor of IVC sarcoma versus only pure leiomyosarcoma marker. Great. So any role for adjuvant treatment, the radiation oncologist, the medical oncologist, any role for adjuvant treatment, margins are negative. I think you have to press the button.
Yeah, I don't think so there is any role of adjuvant radiation option, because it's all histology driven, and we clearly understand that leiomyosarcoma is high grade, large amount of distant metastasis than...
Yeah, the prognosis is, how is the prognosis of this patient? Are they going to recur locally, regionally, or both?
More or less distant and local.
Dr. Anusha, would you, so you say more of distant, less of local, or more of local and also distant?
More of distant than local.
Okay, is there anything which impacts this? Like it is an infrarenal location. Does that location impact the prognosis for local recurrence as well as distant recurrence?
I'm not aware.
Not aware. Okay. So basically, there are three types of IVC leiomyosarcoma: segment 1, 2, and 3. Segment 1 is in the infrarenal. Segment 2 is from renal to the hepatic ostia, and from segment 3 is suprahepatic. The ones which is this is an infrarenal one, and both of them, this is a combined extrarenal and intrarenal one. So if margins as well as the presence location of the tumor. The lower the tumor, the better the chance you're getting R0, and the lesser the chance of both loco-regional as well as systemic metastasis. So yeah, so this is our particular tumor, and again the 5-year recurrence rate is almost 60%. 2 out of 3 are going to recur locally, and 10-year survival is only 30%. 1 out of 3 is going to survive. So these tumors do recur both loco-regionally. And again, the site of the tumor is very, very important, as well as margin status, right? So let's go to the next case. 70-year-old lady presented with complaints of abdominal distension and pain since 2 months. History of some vague surgeries. Large mass, more to the right side of the abdomen, lobulated margins. You are able to get above the swelling and as well as below the swelling. Weight is good, good performance status. And as I said, we come with an imaging. This is the imaging. This time I will ask to the radiation oncologist. There are 3 of you. You can just have a look. Right, so you've seen so this is the imaging, right? Any of the radio. So what do you think you're dealing with right now? Is it like the same as the IVC leiomyosarcoma of the previous case, or is there something different in this particular case?
I think it's a huge mass with retroperitoneal origin, but it's separate from the IVC. It's pushing the IVC on one side. It's not involving the IVC.
Okay, do you see any fatty areas in this particular case?
No.
Yeah.
Fatty areas.
Okay. Do you see any calcifications? Any calcifications? I mean, obviously the images are not that good. Yeah. Okay. So there are no calcifications, reasonably well circumscribed, heterogeneous, enhancing, pushing type, right? So probably, yes sir. Anything? Bharat sir?
Yeah, the kidney.
Yeah, the kidney shows some hydronephrosis, right?
Hydronephrosis and thinning out of the parenchyma.
Exactly. So great. So you have seen some organs which you think. So preoperative biopsy in this case, no biopsy. Go for surgery. Would you want to know?
We need to know the biopsy.
Yeah. So again, as we know, as far as possible, biopsy is recommended in retroperitoneal tumors. Our teaching used to be no need of biopsy, go for surgery, definitely. What type of biopsy, Dr. Anusha or Dr. Ravi? Would you go for a CT guided, USG guided biopsy? Would you go for a transabdominal biopsy? Any other type of biopsy?
I think this patient we can easily get a ultrasound guided or a CT guided biopsy. So that would be better in my opinion.
Okay. So one thing, is there something else? Do you know of something called as a retroperitoneal approach for biopsy?
So I think you can tell us more about it, but we usually follow the ultra, because such a
Yeah.
huge mass, very easily accessible.
Yeah.
So I think CT guided biopsy.
Yeah, CT guided biopsy, retroperitoneal approach, that is what, rather than a transabdominal and going through the abdominal cavity is what is preferred. And sometimes, you don't get good enough amount of tissue, so they said you go for an open biopsy. So would you, Dr. Rajesh, would you say that you should ever go for a laparoscopic biopsy for a retroperitoneal tumor? Is there a yes or a no, or maybe if you're not getting adequate tissue? Sometimes we get, calls, multiple biopsies done, nothing coming out, we want to go for an open biopsy.
Not really, no.
Yeah. So 3 no's, definitely. Image guided, Dr. Rigved, do you do, any change in practice nowadays with PET guided biopsies rather than CT guided biopsies?
For this kind of tumor, we never attempted PET guided.
Okay, if there's a large necrotic component, there is a only small solid component. Would you then go for an PET guided biopsy?
I think good IR and radiologist will get us the...
Fine. So PET guided biopsy, yeah, they say that the maximum activity may guide you in your biopsy, but again, there is no role, evolving role. So 3 no's, obviously no laparotomy, no laparoscopy, and supposing you opened a tumor thinking that it is something else, finds out that it is a retroperitoneal sarcoma, retroperitoneal tumor. Do you go ahead and go with the surgery, or then do you come out? So this is for the audience. There's no whoops procedures in retroperitoneal sarcomas. If you are not just unjustified in closing the abdomen and coming out, because the margins are going to determine what this patient is going to happen. So any markers, I think there's no role for markers here. Imaging, PET CT, MRI just for distant metastasis. Functional assessment of the kidney, the right kidney, Dr. Bharat said, is involved, so probably you could do a DTPS scan, very good. So biopsy came as intermediate grade, no distant mets, contralateral kidney, 60% function. So now, Dr. Ajish, I'm sorry if most of the questions are to the surgeons. It's a retroperitoneal sarcoma. So
This patient would require a right compartmental excision.
Great. So the organ at risk you are seeing first is the kidney.
Will be right colon, right kidney, and ureter, and probably duodenum. I'm not sure.
Yeah. So right colon, right kidney. Psoas. Do you do a routine psoas excision for all these right-sided tumors, even if it's not lipogenic? This is not a lipogenic tumor, it's a leiomyosarcoma. Would you then go for a psoas excision for all cases?
Not a complete psoas, but we can take the psoas fascia.
Psoas fascia. Okay, excellent. So yes, compartmental excision was done. Wide excision, nephrectomy, ileocecal resection, margins were negative. So this is the final histopathology report. Again, madam has told about the organ of origin, and margins she would comment mainly upon, the circumferential margin is based upon the surgeon, to be really honest. If, as already been told, there are 3, 5 or 6 classes of margins. So now this is the final immunohistochemistry report. So based on this, Dr. Ravi, any role for any adjuvant chemotherapy? It's high Ki-6, 20 to 25% Ki-67.
So tumor size here, I believe it was around 10 centimeter. It's a high grade tumor, 10 centimeters.
It's 24 into 18 into 11.5 centimeters.
Yeah.
It is mitotic rate is 1 to 2 per high-powered field. Margins, the ureteric margin free, renal margins free. No
but you're
notes,
saying that it is grade 1. So you're saying that it is grade 1.
The final histological grade is well differentiated. Grade 1, yes, excellent. T4 grade 1.
So
yes.
here you put it at it is grade 1, and here Ki-67 is 2022. So this is what actually happens in real life.
The grading and the Ki are not correlating.
It usually doesn't correlate.
Yes.
And that is why if you look across the data of all these years, 20 years, we've never been established to answer this question that adjuvant chemotherapy really helps this patient or not. So first meta-analysis was in 1980s and 1990s, and that said that no role of adjuvant chemotherapy. And then subsequently the second meta-analysis came in 2008, and that said that there's 10% survival benefit. But that was majorly because of one Italian study, so which had more patients with chemosensitive histology like your synovial.
Most of the meta-analysis are including truncal, abdominal and extremity sarcomas. So
but if you put all the data together, then you should divide these cancers whether they are chemosensitive or chemo resistant or moderately chemosensitive.
Yeah.
So this this histology would fall into intermediate chemosensitivity. So it is not very chemosensitive, intermittent chemosensitivity.
Okay.
And like the previous speaker pointed out that there is ESMO circulator calculator.
Exactly.
So I'll put all this data in that calculator, I'll put the
Great.
grade, I'll put the size, and it will give me a score. So if it will say that the recurrence chance is more than 60%, then these patients will get adjuvant chemotherapy.
So
And that
you
will
would
be
use a
2
nomogram to decide
Correct.
in short,
Correct.
right? Yeah, great. So the margins, I think R0, R1, we know. Anybody knows of this R plus 1 margin? What is R plus 1? Some people are propagating the R plus 1 margin. So something like a compartmental resection, but you give about 1 or 2 mm of normal tissue along with it, right? Any role for frozen, Dr. Rajesh? For margin assessment, proximal, distal, ureteric?
No, just to add to pathology, previous case and this one, like margins like we were discussing, actually in a growing center, a new center with low volume center, it is best the surgeon goes there, grossing
Goes with the grossing, excellent,
with
excellent
the specimen,
point.
inform all the areas he or she is concerned with, and then there will be one area which you will be suspecting intraop itself.
Yeah.
At that time, just check with them. For that area, if frozen is required or not, we can check.
Yeah.
Or in general, to orient the specimen, get whatever suspected organs which you are thinking.
Yeah, great.
That
So
might be
basically
one-
you gross yourself and then you communicate with the pathologist. Very good, excellent. So what next? As I said, prognostication, adjuvant, neoadjuvant, hyperthermia. Any role for hyperthermia, Doctor? Hyperthermia followed by chemotherapy and radiation?
I think that evidence is coming. Few
Yeah.
centers are doing that.
Okay.
Using chemotherapy and adding hypothermia to that. I
Okay.
think very few centers are doing that. So I think time will answer that question.
Sure. So basically, as I said, the two nomograms, the circulator as well as the MSKCC nomogram, the original circulator was not for retroperitoneal sarcomas. It was only for extremity sarcomas, but the 2024 update has both primary as well as recurrent RP sarcomas. There is also a sarcoma specific, a nomogram specifically for leiomyosarcoma from a Chinese group which has come up recently. So yes, supposing I have a case like this, this is a similar case. In short, I mean in lack of time, this is a multifocal disease. There are two dumbbell-shaped tumors, one above the other. Both of them are leiomyosarcomas, right? Would you now offer surgery? Patient has got a borderline performance status. Performance status 2, old lady, no abdominal fat, thin lady. But both the tumors are there, right? Both the tumors are operable, but they are multifocal. Only two sides, both on the right side of the abdomen. So would you operate this patient, or would you say that no, I will not operate this patient? कुछ फायदा नहीं है. Anyone can answer. You would operate. So we operated as usual, we operated. But what you have to know is within 3 months, patient had florid recurrence in the bed. We had a margin negative excision and also liver met came within 3 months. No adjuvant was offered for this patient. So multifocality is an extremely poor prognosticator. Even if a low-grade tumor, sometimes if you have multifocal tumors, it's not likely that you're actually going to achieve much by going for a extended compartmental resection. So the prognosis again depends on the volume of the center. Yeah, 13 is the golden number. I will show at the end of the study whether we are 13 or not. But high volume center, better prognosis. No adjuvant, no level 1 evidence for adjuvant treatment. This is a 2018 JAMA study. No again level 1 evidence. It included extremities as well as retroperitoneal tumors. So the last case, I think this is a case we have to discuss. 43-year-old male, abdominal distension, hard mass which is filling all the quadrants, lobulated surface, external genitalia is normal. I'll go to the imaging. For the radiation oncologist again. Good performance status, but about 5 kgs weight loss recently, and otherwise the patient is performance status 1. Right? So, okay, I think pretty much last few questions. So these are the organs at risk. This is the dedifferentiated component, right? This is the left ureter, which is encased. Now for the radiation oncologist, would you now say that these organs, I am sure as a surgeon I am not going to be able to get a margin. It is crossing the midline. There is a dedifferentiated component. I am saying that we will not be able to go for a surgery with an R0 dissection, even with although it's predominant in the left side. Would you now offer any form of neoadjuvant treatment? So biopsy, yeah, it's come as dedifferentiated liposarcoma.
Seems like dedifferentiated liposarcoma.
Yeah.
So we can offer pre-op RT for this patient.
Okay.
2 dose of around 45 to 50 gray.
Okay. Now it's grade 3. A dedifferentiated liposarcoma, but it is grade 3. Would you still offer it or?
So there are two aspects to it. One is whether you're improving survival. The second aspect is operability. So the patient comes to us from the surgeon because there's chance of an R1 resection. They need help with operability. Then grade 3 dedifferentiated pre-op RT will help them to reduce the volume and operate.
Okay. So again, the volume, yes sir, sure, Bharat sir. Last few minutes. Yeah.
The only thing another we need to see is dedifferentiated, whether it's a low intermediate versus high.
Exactly. So you want to know about the dedifferentiated component. That will also guide you as to.
Because
obviously,
the evidence suggests that well differentiated, and if it is dedifferentiated, low and intermediate really had the benefit.
Correct.
But again, we need to look everything into perspective because it is been.
Assuming you're in a very high volume center and you've done lots of cases, you would base it only based upon whether there was some degree of grade 1 or 2 dedifferentiation. That's what you are saying, right?
Yes.
Yeah. Again, this is a post hoc analysis. The Strexit, we all know about it. Strass trial was a negative trial. The abdominal recurrence-free survival was same in both the arms, but again, there were some protocol violations. Progressions on radiation was considered as a recurrence, even in spite of progression. If the surgeon was able to get away with an artery resection, that was considered as an abdominal recurrence. So that's why they didn't find any benefit. But essentially what they found in a post hoc analysis is that the well-differentiated liposarcoma and the grade 1 and grade 2 dedifferentiated liposarcomas have got some benefit. The role of prehabilitation, would you go for prehabilitation, Dr. Ajish? Regularly do you do it in your practice? Not about this case. Supposing you have a pancreatic cancer, do you go for prehabilitation? All patients. So pancreas gives you time, essentially, right? Patient is jaundiced. He has got a stenting done, so then you are anyway going to give for 3 to 4 weeks of prehabilitation. But in this particular case, would you go for prehabilitation?
Yes, definitely. Because.
So how long would you go for it?
At least 2 weeks.
Yes. Okay. Exit. And is it a single modality or multimodality prehab?
Multimodality.
Great. So ideally yes, and there are various tools for prehabilitation, but there are challenges. Obviously, time, cost, progression. And patients sometimes are symptomatic. This is filling the entire abdomen. He may not be able to eat properly. But yes, it is ideally it is recommended. So this is what was done for this particular patient. Complete extended resection was done. Left hemicolectomy, psoas fascia excision. The ureter was encased. Kidney was kept free. So we did a Boari flap reconstruction.
You went upfront or post radiation?
No, we went upfront. Our people, as you said, I'll tell whether it's a low volume or low volume later on. So the dedifferentiated component was also low grade in this particular case, right? So probably pre-op RT may have helped. Again, pathology. So in our case, 42-year-old, more than 20 centimeters, median size in Strass was 16 centimeters. Grade 1, organs resected as per compartment resection in Strass was left colon. Kidney and psoas were the common things which are, and the margins at the IVC, common iliac were probably borderline. So maybe you might have helped with some form of preoperative radiation, right? But the local recurrence rate is quite high, 60%, right? Any role for newer modalities, proton, dose painting? I'm married to radiation oncology, but I don't know any of these terms actually. Dose painting, it's called posterior margin is dose painted and then you go for surgery.
There are a lot of things under research, like as you were telling, dose painting in the sense where you're giving a uniform dose, a low dose to the entire tumor and trying to boost the areas at risk like the retroperitoneum or the vascular edges with a bit higher dose of radiation. Yeah. But again, everything revolving around the histology again, not being done on high grade tumors.
Correct.
Again, radiation plus immuno, some search for IORT, some search for protons. So everything is being tried, but no consensus has been approached.
So Dr. Ravi, any role for neoadjuvant chemo in these kind of cases?
Coming to your neoadjuvant chemo, I would say that if you go back to your slide, you will see that you've shown that MD-M2 is positive in this case. Yeah. So now there's upcoming evidence for MD-M2 inhibitors. So what we've understood at this kind of patients where the de-differentiated component is very less, Ki67 is less, grade 1, they are not the ones who are going to respond to chemotherapy. So chemotherapy won't benefit this patient, not add to any, not even 2% of survival. So here M2M2 inhibitors.
Excellent point. Yeah.
So
basically,
here,
the higher you are saying that the more. I'm so sorry because of lack of time.
Yeah.
The more differentiated the tumor, the less the chance of chemotherapy to work, and the higher the chance of local recurrences. In short, for the audience, right? So as you can see, de-differentiated liposarcomas are the highest recurrences. Lowest local recurrences is the leiomyosarcoma, and it converts in terms of distant metastasis. So I think we'll stop in view of time. I thank all my panelists. For bearing with my speed, because I wanted to discuss more number of cases. I think what basically our experience shows is that we initially started off with a low number of cases. We have totally done only about 38 cases over a period of 4 years, so mean of about 9 cases. Again, curve skewed to the right. Most of our cases are, de-differentiated liposarcomas followed by angiolipomas, schwannomas. And there are certain topics we have not discussed, like pelvic tumors, benign tumors, and syndrome-associated sarcomas, and the role of genetic testing. I think in lack of time we could not discuss it. But essentially, RP tumors are important. Multidisciplinary management is the key. Prehabilitation is very important. Outcomes are good in high-volume centers. Role of radiation is limited but evolving. And histology-guided treatment and newer agents may be the key to improve long-term outcomes. I thank you all for your patience and for bearing with me at this late stage. Thank you so much. Thank you.
Thank you one and all for this thought-provoking discussion. I now invite our next speaker, Dr. Prabhat Bhagraba, to brief us on the topic systemic therapies in metastatic sarcomas.
Good evening, one and all. I thank the organizers for giving me this opportunity to speak on this rare topic, systemic therapies in metastatic sarcomas. So sarcomas, we generally term them as one, but it is not one. It is comprises of multiple subtypes, and multiple subtypes differ in their sensitivity to chemotherapy, and that is what makes a lot of difference. So first line therapy depends on what type of sarcoma that we are dealing, whether it is chemosensitive type or resistant type. Fortunately, most of the frequently occurring subtypes are generally chemosensitive. Whether patient has received perioperative therapy, that also determines what first line of therapy that patient will receive. Fitness of the patient himself or herself will also decides our choice of therapy. And improvement in quality of life and to extend survival is our goal of treatment. The Ewing sarcoma and rhabdomyosarcoma are chemotherapy is an integral part, and so they are out of my discussion in today's presentation. The other chemosensitive histologies are Ewing sarcoma family tumors, desmoplastic small round cell tumor, which normally presents at an advanced stage, synovial sarcoma, which relapses frequently and metastasizes frequently, myxoid round cell liposarcoma, which is very chemosensitive histology, and uterine leiomyosarcoma, which is again a very chemosensitive histology. The moderate sensitivity depends are the pleomorphic lipo, epithelioid sarcoma, pleomorphic rhabdomyosarcoma, leiomyosarcoma non-uterine, angiomyosarcoma, and others, and so on and so forth, are chemo-resistant. So the most common drug that we use is doxorubicin based. Since on the backbone of doxorubicin, other drugs have been used as first-line therapy for the chemosensitive histologies. Gemdosi has been compared to docetaxel to doxorubicin, but did not show superior survival. Other modification of doxorubicin could be doxorubicin with dacarbazine or terbactidine, or you can change it to liposomal doxorubicin. Others, this is my summary slide. Nowadays it is fashion to show summary slide first, and second line options could be eribulin, pazopanib, terbactidine, gemdacarbazine, or any other drug which has not been used previously.
So anthracycline, doxorubicin remains backbone since 1975. I would say it was very lucky that only in 36 patients they could show 9% complete remission. Even today 9% complete remission is hard to achieve, with partial response in 32%. And based on this 1975 studies of 36 patients, doxorubicin became the backbone of 60 milligram per meter square, became the backbone for metastatic sarcoma treatment. Based on that, the other trials were done, whether what second component should be added, can we increase response rate, PFS and OS. So one of the important study is based is the one which I am showing on screen, EORTC 62012, which tried to add ifosfamide to the backbone of doxorubicin. So metastatic patients who were chemo naive were randomized to doxorubicin alone at 75 milligram per meter square. Mind you, it is a very chemo resistant disease, so 75 milligram per meter square is more important, and below 60 doxo is hardly there is any response that you will see. So 60 to 75 is the therapeutic index that we need to maintain while using doxorubicin for our sarcoma patients. And while with the addition of ifosfamide in the experimental arm, they divided into 3 days of doxorubicin, same 75 milligram per meter square total, and 7.5 milligram per meter square of ifosfamide. They wanted to see whether we can improve survival, and at least we can improve progression-free survival based with 6 cycles of therapy, or before, if there is PD, we will stop it before. What they found out, the progression-free survival did increase a bit from 4.6 months with single agent doxo to 7.4, but however the OS was not statistically significantly improved with addition of second drug. But point to be noted is overall response rate does increase. It goes into double digit compared to what single agent doxorubicin will give, and 26% compared to only 14% with single agent doxorubicin. So doublet can be given if patient is very fit, and you want, there is an aggressive biology where you want response rate for our patient. Another more chemosensitive histology, uterine and non-uterine leiomyosarcoma, based on recently study LMS04 has been published in NEGM, which showed that if adding of trabectedin, making doublet of doxorubicin, did increase PFS from single digit of 6 months to 12 months, and it also lead to statistical improvement in OS, which was not there till now. So for LMS, there is a drug called trabectedin which can be added to our doxorubicin backbone. However, at the cost of grade 3-4 toxicity to the tune of 97% with the combination, whereas with single agent doxo it is only 56%, and that too febrile neutropenia in 1/4 of the patient, and 47% will have grade 3-4 thrombocytopenia. So very selectively that I have tried this drug combination in my practice, especially when I want response rate, because response rate is 36%, which is highest reported till any of the combination available till now. And they also, the overall survival benefit could also be due to the fact that they have given trabectedin maintenance after 6 cycles of doxorubicin. So whether this overall survival benefit has to be taken with a pinch of salt in front of the grade 3-4 toxicities that we are seeing on screen, and the amount of benefit that you will receive with adding trabectedin to doxorubicin backbone. Another simple regimen that can be given for LMS is a doxorubicin with dacarbazine. So there is no prospective study comparing the same, but again EORTC group has done a retrospective analysis from multiple institute and propensity match analysis, and what you can see is with roughly 82 patients in the combination arm of doxorubicin, dacarbazine or doxo-ifos, and 41 patients received doxorubicin alone. 82 patients received, 41 received only doxo-ifos. In this, you can see that doxorubicin alone gave a PFS of 4.8 months, what we will expect, but adding dacarbazine, again PFS increases to 9.2 months. Here, a definite number of cycles were given and not dacarbazine being continued till progression. Maybe then it will also reach 12 months. We don't know. This is a retrospective propensity analysis. But the combination led to overall survival even in retrospective analysis of 36 months, which is something similar to what doxo trabectedin gave in a prospective study. And this is way back old study, and the LMS prospective study is a recent one. So maybe doxo dacarbazine can be a safer, easily financially feasible option for patients rather than doxo trabectedin, is my take from this study propensity match analysis. Another, if doxorubicin cannot be given, any doxorubicin based treatment cannot be given, then what are the options available? So JEDIS was a study where gemcitabine plus docetaxel combination was compared to doxorubicin alone. Mind you, the dose of gemcitabine was only 675 milligram per meter square on day 1, day 8. We normally give 900 milligram in sarcomas, as they are chemo-resistant tumors normally, it is what is taught. And for doxo also we are giving a dose of 75. So similarly for gem also dose should have been on higher side. They wanted to see whether PFS increased by gem dosi compared to doxorubicin, but they failed to prove the same. PFS of gem dosi versus doxorubicin is almost the same, and overall survival of the combination did not improve over doxorubicin alone. So they could fail to prove superiority, but in histology of LMS, you can see that there is some benefit, and maybe in selective LMS or patients who are not fit for doxorubicin, gemcitabine and docetaxel does stand to be a first line regimen. Another first line regimen for our older patients, where we are scared to give doxorubicin or a doublet of gemcitabine and docetaxel, could be pazopanib. A 120 patient trial is there where they wanted to prove that pazopanib is non-inferior to doxorubicin, and they could prove the same. 81 patients received pazopanib and 39 received doxorubicin. The response rate was only 12 to 15% in both the arms. Grade 4 neutropenia was hardly there, 0% febrile neutropenia, 0% alopecia, 3%, 4% stomatitis, and mucosal inflammation in only 12% of patients. They gave a dose of 400 to 600 milligram pazopanib. Their aim was to give a good quality of life at non-inferior overall survival. But pazopanib comes with its own toxicities, that is hypertension, hypothyroidism, increased frequency of motion, but it led to general deterioration in PS in more number of patients compared to what was seen on the experimental arm of doxorubicin alone. So in selected patient where you feel doxorubicin is not an option and even gemdosi is not an option, this does stand an option. So summary slide for the first line is doxorubicin alone for all comers and chemosensitive histology. Chemosensitive is the most important word here. You can add selectively ifosfamide when we know that the patient has an aggressive biology and you need response. A gemcitabine docetaxel is an option if anthra is contraindicated, and if patient has poor PS, multiple comorbidities, then pazopanib is an option. Gem alone is also an option, and lipodox is also an option because it has less number of febrile neutropenia or hematological toxicities compared to what a standard doxorubicin will give. Moving on to second line from doxorubicin based therapies. Second line options, there are plenty for our patients. If you want, based on what profile patient has and what comorbidities or organ damage that patient is going on due to sarcoma burden, you can decide the appropriate second line for patients. Pazopanib was tried in patients who had at least roughly less than equal to 4 prior systemic therapies. So placebo was their comparator arm. Compared to placebo, randomized trial of pazopanib was carried out in relapsed refractory sarcomas, and even in relapsed refractory sarcomas, PFS is 4.6 months, which we saw for doxorubicin in first line of 4.8 months. So it seemed to be an interesting drug, but in first line we saw that it is non-inferior and not superior to doxorubicin. But in relapsed refractory patients, except for liposarcoma and leiomyosarcoma, pazopanib is an approved indication. Keep in mind, lipo and leiomyosarcoma cannot be given. So what are the options for second line for lipo and leiomyosarcoma? Eribulin was compared to dacarbazine, and they could show that PFS is almost the same of eribulin or dacarbazine, but eribulin did increase overall survival, and it seems to be a relatively safe drug, very less grade 3 for side effects compared to what dacarbazine will do. And again in leiomyosarcoma and liposarcoma, it did much better compared to what dacarbazine did in the subset of leiomyosarcoma and liposarcoma. In dacarbazine arm, overall survival was only 8 months, but it almost doubled to 15.6 months in eribulin arm, and for liposarcoma, sorry. And for for leiomyosarcoma, the overall survival is the same for both. So it seems to be a better drug for leiomyosarcoma group and liposarcoma group. And pazopanib is not approved, so it seems to be a good option compared to gemdosi. It is less toxic also. Another option is trabectedin if it is not being given as first line or as second line for liposarcoma. There is a randomized evidence available where in this trial where patients were compared to dacarbazine. The overall progression-free survival does increase in leiomyosarcoma subgroup and liposarcoma subgroup and other chemosensitive histologies, and it is got US FDA approval. It did not lead to overall survival benefit, but PFS benefit is there. But mind you, trabectedin alone itself is also a toxic drug as compared to what we see on the LMS-04 trial, where combination of doxo and trabectedin was given. So grade 3-4 toxicities of neutropenia and transaminitis are up to the tune of 25%, whereas in dacarbazine it is very less. So, but PFS is more, so trabectedin does win over the combination. So options in second line available are gemdosi. If patient is not fit, then eribulin, pazopanib or trabectedin. Based on the toxicity profile of the drug and what comorbidities your patient has, you can choose one of them. Pazopanib mostly causes transaminitis, eribulin mostly causes neutropenia, but not febrile neutropenia, and trabectedin causes neutropenia and thrombocytopenia both, and even febrile neutropenia. So only in fit patient that trabectedin would have been a better option. Otherwise, the other two tends to be a better option if gemdosi is contraindicated, or beyond gemdosi as third line or fourth line. I will complete in next 2 minutes. Gemcitabine plus dacarbazine can also be given if patient is poor and conventional chemotherapy is only to be tried. Compared to dacarbazine alone, the combination increases PFS and OS both in all comers, but obviously especially in patient with leiomyosarcoma subgroup. So summary slide for second line is gemdosi or eribulin or pazopanib trabectedin based on the profile of your patient and the subset histology of your patient. Immunotherapy in metastatic, if I don't talk about immunotherapy, so I put one slide that immunotherapy alone doublet has been tried of Nivo EP with response rate of 25%, but hardly any PFS. Combination of pembro exitinib had 33 overall patients, but 12 were ASPS, and it does seem to that combination does work in ASPS. So chemo-resistant subtypes, I have not included the trials. I will just read out that in desmoid it is better to use sorafenib for ASPS combination and other so on and so forth as enumerated. Brief note, in precision oncology, sarcoma was way beyond. We know that most of the sarcoma are characterized by the translocation that they carry, and so sending NGS doesn't make sense. Nothing will come out in NGS, only this translocation will come, for which we don't have an therapy. But still, precision slides I have included a few that less than 1% of selected patient may have some NTRK fusion, and larotrectinib and entrectinib may be given. Some liposarcoma have, because of the translocation chromosome 12 involvement, they have CDK4/6 amplification and they do respond well, but the dose of palbociclib given was 200 mg for 14 days and not the conventional doses as in breast. TSGCT is a rare tumor and imatinib can work. Other targeted therapies are in rare sarcomas. Thank you.
Thank you very much, Dr. Prabhat, and now I hand over to the compeers for further proceedings.
Thank you.
Thank you so much, sir. Moving forward, I request Dr. Ravi Teja to speak on the topic reinventing a better will in NSCLC.
Good evening, everyone. So I will be discussing about the role of serplulimab in lung cancer, especially small cell lung cancer. So in various cancers, that is in the lung cancer, whether it is squamous cell or adenocarcinoma and small cell, we have been using immunotherapy for a long time, and this is a newer addition to the current armamentarium of the immunotherapy drugs. So in extensive stage small cell lung cancer, we do not have enough molecules. You can see the progress over the years, that there have been a less progress when compared to the non-small cell lung cancer. The median OS is just 10 to 12 months, even though with the advent of immunotherapy molecules like atezolizumab and durvalumab. So serplulimab is another PD-1 inhibitor with a different mode of action. That is, it has two mechanisms of actions. One thing is it blocks the PDL1, along with that it causes endocytosis of the PDL1, and also it blocks the CD28 mediated co-stimulation effectively than other PD-1 inhibitors. So it has got a distinct advantage when compared to other PD-1 inhibitors like pembrolizumab and nivolumab. So being the PD-1 inhibitor, obviously it blocks both the PDL1 and PDL2. Currently the serplulimab is approved in first stage, first line metastatic SHCLC. It has been approved in EMA and as well as in the DGCA it has been approved. And in China it has been approved for even for non-small cell lung cancer, that is squamous cell and also adenocarcinoma. So based on the trial, that is Astrum 005 trial. So in Astrum 005 trial, the extensive stage small cell lung cancer have been randomized into serplulimab carboplatin etoposide versus carboplatin etoposide. The stratification factors include the PDL1 expression, brain metastasis and age. So most of the patients are from Asian, that's not necessarily Indian, but most of the Asian population have been represented. Along with it, the brain metastasis, the patients with brain metastasis have been represented in this serplulimab arm. So when compared to the other standard trials, that is itolizumab trial and the Caspian trial which has durvalumab, the Astrum, that is serplulimab trial, has more of Asian representation than other trials. So coming to the endpoints, coming to the results, the overall survival have been improved by 4 months, that is the only chemotherapy arm is 11 months versus serplulimab as arm as 15.8 months. Both the curves seem to separate well, and at the end of median follow-up of 42 months, the hazard ratio is 0.6. All the population seem to benefit from the serplulimab arm. We have been using the serplulimab arm since 3-4 months, so some of us may have used in small cell lung cancer as well. It has got a good safety record, and apart from the mild immune side effects expected from the immunotherapy, rest of the side effects are similar to carboplatin and etoposide arm. So again, when compared to the atezolizumab and durvalumab, the 3-year OS rate is 24 months versus 16% versus 17% in the serplulimab arm, whereas the hazard ratio is 0.61, 0.76 and 0.71. So it has got a good magnitude of benefit according to the ESMO, and it stands between 4 and 5 survival substantial benefit with regard to the ESMO magnitude scale. So now it is one of the armamentarium for the extensive stage small cell lung cancer along with atezolizumab and durvalumab, and it can be used pretty well without much substantial side effects. So what about beyond SCLC? As I said, in squamous cell carcinoma and adenocarcinoma, the serplulimab is approved in China for both squamous and adenocarcinoma based on 2 trials. I'll just briefly go through those trials. That is Astrum 004 trial, that is in the squamous cell carcinoma. So here in the squamous cell carcinoma metastatic, the treatment arms are nab-paclitaxel carboplatin versus the serplulimab nab-pacli carboplatin versus placebo plus nab-pacli carboplatin. So this serplulimab is continued in the maintenance arm. So again, the stratification factors include PDL1, the race and as well as the disease state. So again, the PFS, updated PFS has showed both the curves seem to separate well enough with the hazard ratio of 0.55. Median PFS in serplulimab arm is 8.3 versus 5.7 months in the only chemo arm. As we know that the standard of practice now in squamous cell carcinoma as well, irrespective of PDL1 status, the chemotherapy plus immunotherapy is a standard arm. So here as well, the irrespective of PDL1 status, that is TPS score of less than 1, 1 to 50 and more than 50, in all groups the serplulimab has shown benefit. Again, the overall survival is 22 months versus 18 months. The hazard ratio is 0.73. So based on this trial, the molecule has been approved in China for the squamous cell carcinoma, and whereas in adenocarcinoma as well, it has been approved based on Astrum 002 trial. So again here, Astrum trial, they have compared the serplulimab plus chemotherapy with or without, this is bevacizumab biosimilar, that is HLX04, the local company, versus placebo chemotherapy. So again, in one group they have included like atezolizumab, bevacizumab, carboplatin and paclitaxel, that is IM power 150 study. Similar to that study, this Astrum 02 trial has been designed with group A, group B and group C. Group B is with bevacizumab, group C is without bevacizumab and serplulimab. So surprisingly, the bevacizumab arm did not do well. Only serplulimab and chemotherapy arm did well. That is the group B. That is without bevacizumab. With bevacizumab, it seems to be doing down under than compared to without bevacizumab. So again, the progression-free survival, the median PFS with bevacizumab is 12, without bevacizumab is 11, and placebo arm is 5.7. So coming to the conclusion of this trial, the combination of serplulimab chemotherapy is doing well in adenocarcinoma, again without respect to the PD-L1 status. So again, this is one of the combinations that can be used in adenocarcinoma lung. We have a lot of options like Pembro, Nivo, Atizo, and now durvalumab is coming. We have got Nivo plus CP in adenocarcinoma. So apart from this is one more option. The advantage of serplulimab, as I said, it has got good internalization, effective binding, and as well as the potent PD1 inhibitor, and as well as there is inhibition of CD28 signaling, thereby preservation of inhibition and enhancement of T cell activity. So it has got again the highest ESMO MCBS scoring, and right now in India it has been approved for first line extensive stage small cell carcinoma, and we have been using it in squamous cell as well as adenocarcinoma as well. The main advantage is, apart from the potency, the cost effectiveness of the therapy has been used primarily for Indian patients. So by that, I thank you for the organizers for providing me the opportunity.
Thank you so much, sir, for the enriching talk. I also thank our chairpersons for guiding us through. We now disperse for a short tea break and assemble here by 15 minutes for the most awaited fun-filled fireside chat.
Hello, 1, 2, 3. Hello. Directly from the airport. Directly from the airport. Okay, okay. Come close. This session is about purely personal insults. So if you sit so far, I can't see you, I can't insult you. So please come to the front. No jokes here. I will go there and insult you if you don't come front. Come to the front. And you see my glasses, I can't see far of any. Please come to the front.
Go back ventures.
Go ahead, introduce me.
Welcome back for the last segment, but the most awaited one, fireside chat. Scrubs off, game on.
That's it. So my name is Kaushik, and I work here. Some people are laughing in the front chair actually. Why do you work, dear? I've never seen you working. Okay, I come here for the samosa, which you also had now. But I get paid, so I have to do something to justify my pay. So which is why I'm doing this, and we have 3 people here. They have been called here. They're all great doctors, surgeons, and all that. But they've been called here because they all have a facet of their personality which is beyond what you know normally. And I will introduce them one by one. Chinna is a good friend of mine, and this is serious. He's a good surgeon, very, very good surgeon, a conscientious surgeon. He is also having a personality which goes beyond that, which many of you know, many of you don't know. He is difficult to categorize and put in a box. He's an entrepreneur, he's a social entrepreneur. He is a philanthropist and a social worker beyond any one of us comprehension. He runs a charity so big that most of us will never be able to conceive in our lifetime. So, Chinna, we are jealous of you. Okay. Subbu sir, he, in a dark alley, if you hear this laugh, you know Subbu sir is there. He's famous for his laugh. He's also a surgeon who has mentored scores of surgeons, not just surgeons, oncologists, doctors, over time. He's also the director of the biggest cancer hospital in the city and one of the biggest in the country. More than that, he's a mentor par excellence. I mean, there are so many people who have been mentored by him directly or indirectly. And he is a person who has got a viewpoint which is so radical sometimes that you will fail to see. And which is why he's here. And this gentleman, grey-haired gentleman, he started a very bad trend in the country of getting a FRCR degree. Yeah, that's what. The consequence of that is that today in my department, everybody's FRCR, I'm not the only one. I'm the only one who's not adequately qualified. So, thank you, sir, for exposing my vulnerabilities and inadequacies, as you have done for so many years as my teacher. Welcome. Good. She has messaged me, where is the medical oncologist? They are doing ad boards. Come on, who will come to listen to all this? They are in the ad boards. But, good question then. So that brings to my first question, is that should an oncologist be dependent on only one source of income? What do you think? In these days today where markets are going up and down, oil prices falling up and down, Maduro is being exposed and evacuated from his own apartment. Should you depend on one single income or not? What do you think? What's your opinion, sir? You have mics.
Depends on your lifestyle and your wants and needs. So that's all. It is highly individualized. You cannot generalize it.
Anyone from the audience? That's the place. You can raise your hand and disagree, agree, whatever. You think you should have one opinion, one single income? Yeah? No? Use the mic here.
All of you come in front.
Come in front. That's why I said it will be.
Fire is here. Fire
So,
is there.
check.
Just imagine the fire.
So I think, sir, because oncology is getting saturated, and
have you seen cardiologist? That is saturated.
Super much saturated, sir. So I belong to a second tier city, sir, and in my city, the salary of a cardiologist is like they are agreed to work in 1.5 or 1 lakh also in Ranchi.
No,
correct, sir. So oncology will be saturated in next 5 years. So I think it's the high time we can also invest in other things like people are doing opening resorts and these things. And because
your idea, sir. What do you think? Should we open a resort?
I don't know if you should have multiple sources of income. I'm not too sure, but multiple sources of spending should not be there. You should have only only one family, please. Officially or otherwise.
I think the question is wrong, sir. As he has said, based upon the saturation level, we should have at least one source of income. That it's become that bad. Most of them are not able to have even one source of income. Multiple sources to chhodi do.
Okay. Yes. Yes. I know. I will tell you one simple way of doing very ethical work and simply doubling your income in one single shot. Marry another oncologist.
Medical oncologist, yeah. Please. No. Kaushik specific, sorry. I really appreciate her. Medical oncologist. Or even if you marry a radiation oncologist, make her a medical oncologist.
Make her clinical oncologist.
So there is one person I know who is a radiation. Should you marry the same person? I mean, radiation oncologist marrying radiation oncologist, medical oncologist marrying medical oncologist, surgical to surgical, or should it be in another branch?
Yeah, it's a too morbid a love story actually. Oncologist marrying an oncologist itself is very morbid. Medical oncologist marrying medical oncologist is
very morbid.
Too toxic.
Sir, in the hierarchy of things,
both will be sponsored by different companies.
Yeah. The hierarchy of things, highest earning will be medical oncologist. Second highest will be probably radiation oncologist and radiation oncologist. Last will be surgical oncologist with other surgical oncologist or gynecologist or some.
So what happens when a surgical oncologist married a radiation oncologist?
This is what happens, sir. This is what you are seeing. Life example. Life example.
You think from your personal experience.
At least one source of income के लिए हम लोग we are waiting.
No. You look as harassed as Sridhar. Okay.
So there is one person I know who actually a radiation oncologist also married another radiation oncologist. When I showed the script of this, I have written actually. You can see the script if you can read it because I'm not able to read it. That's why I threw it away. So my handwriting is like that.
What is the love letter?
So this is the agenda for this program. So when I told that this is the first question, you know what he did? He said, "Mera flight ka time ho gaya." Bhag gaya. So, yes. Lashkar. Okay. So, yes. Chinna, yes.
Which question?
What? Sources of income.
No.
Be a multiplex or a single screen. That's what he asked.
No, I think, I've been doing that. Multitasking has been my forte. So I don't say that everybody should do what I'm doing, but definitely I have found this to be useful for me. If you look at my journey, I started a clinical research organization about 13, 14 years back. I never knew what exactly how it's going to really grow, but I think that has given some of the financial strength that I needed for the family. So in that sense, 4 or 5 things that I have done has really helped me. So I think that model, I mean, I watch for it that you should have alternate source of income.
Great. I mean, I'll possibly try to be slightly more philosophical and serious on this. Nobody can deny the need of money in our lives. And as somebody has pointed out, that the days, if you see worldwide, doctors' incomes, real incomes are actually falling all over the world, including our country. And the biggest challenge is that for a patient, for a doctor across the table, you have immense power. And what you do can sometimes go unquestioned. And the tendency to misuse the power is very real. And it is going to happen without your knowledge sometimes. And to see a patient as a source of your income and forget what you are here for is a real challenge, especially when you are under pressure to earn money. I don't know whether I made it very complicated, but this is something, yes. So what happens when you are in a private practice, you have some sort of a pressure. And that can, without your knowledge, lead you down to path which is not always desirable, which is not so if you're in a government hospital or in a hospital like ours where there is no such relationship between how much you see and how much you earn. But that pressure can be prevented if you are able to dissociate your patient-seeing activities from your earnings. And that is very vital. That is very vital, so that you know that, well, if I retire today or 5 years down the line, I have enough money. So I don't necessarily have to see this patient and convert this patient into a surgical case or radiation case because I need this month's target. That is the reason that you should have alternative incomes. Or, as he said, have less income.
What will happen, see, every venture is an adventure.
Yes.
Is it not? So you get into something and lose whatever money you have earned in medical profession and lose it there.
Yeah.
Then it becomes a much bigger problem. And then, see, basically you are, not everybody can be Chinnababu.
Yeah.
He is Chinnababu only because of his name, otherwise everything is big.
Okay.
So, it's not a place where you have deep knowledge or experience.
So,
not. So,
I mean, this could be a topic of completely different topic with a full day discussions. What are the different ways you can have passive income? What are the safe ways of having passive income? And, I have made crores in this business, many crores, more than you can realize. So I will be starting a paid course for that. If you want to pay for that course, come in and enroll in the course, I will do that. That's a different story.
So, Kaushik, it's not as simple. Just because you should have an alternative source of income, it requires huge amount of planning, time, and effort. So, I think it all depends upon what drives you, what gives you the kick. And for that, if you need lots of money, then obviously you have to have multiple sources.
I will explain myself.
That depends what, like, I'm working in Tata Hospital, salary plus in addition incentives and share of professional income. And I know I don't have any liabilities. So for me, I don't have to, complicate the matrix.
Absolutely. I think the whole decision lies down whether you have a secure future and a retirement plan.
Yeah.
If you have that, then how much money you earn is a pure personal choice. But a lot of people who don't have that, those who are in some sort of a private practice, people lose their jobs for no reason. People go for a holiday for 15 days, come, their room is locked. That happens in many hospitals. And yes, so there it is important to have a fallback plan in that sense. How you want to do it, I will start a separate paid course for that, you can enroll.
Now, you have effectively convinced us that both of us have to do something more.
No, but just to add a small note on that, Kaushik, the financial planning, doctors are very poor in that. Recently I got the data from Cyber Security Council.
Who of us will do the course?
No, because cyber frauds, if you see, most of the victims are actually doctors.
Yes.
So we're very naive and we fall victim very easily.
Yes, absolutely. So this is
Kaushik, the last point, if I have to make, I think a lot of younger people especially, we equate making money to doing something wrong. And that's not the right thing. That's definitely not right.
Obviously.
You can do normal job, have an alternate source in many ways. It could be passive income, it could be just investing in some shares. The problem is when you suddenly become 16, you don't have money, then you want to make money quickly, very fast.
Yes.
And that's when people go into frauds.
Yes.
You have to understand, and this is, I think, part of training which should be given in MBBS and MD.
Yes. So
which we don't.
So can I take it from there?
And very true, actually, Vamsi has hit it on the head. It's important to be rich. Yes. Very important to be rich. In Telugu, I'm glad you will not understand because you'll counter that with something else. So, ధనవంతుడు బలవంతుడు గుణవంతుడైతే ఊరే బాగుపడుతుంది. See, if the richest in the village and the most powerful in the village, if that man has great character and kindness, the whole village will be a heaven. That's what is said. So primarily, if you are a good person and a kind person, unless you are rich and powerful, you cannot help anybody. So if you are the kindest beggar, what can you give to anybody else? Except a old begging bowl. So it's not bad to become rich. It's very important to become rich if you want to empower society around you, if you want to give employment. And when you become rich, you automatically become an employer.
Yes.
It need not be a huge employment like this, or hospital. You employ one more cook and 2 more drivers. Yes. That becomes employment. Wonderful. So being an employer is also important. So only the rich can do all that. Only people who have things overflowing like China can do that.
Yeah. So I will come back to you. Okay, this is a free for all. Okay, just because I'm having the mic, that doesn't mean that you don't have a voice. Your mic is here. You want to interrupt me, you want to abuse me, you can come and do that without any difficulty. In the stop, I can stop to accommodate you. So since you said that, now you tell me, this is a teaching that has possibly found its resonance among all the people who are sitting here. Do you think the way the teacher used to tell something maybe 20 years ago versus how it is now, has there been a change? I'm asking this to both of you. Because I have been your student 25 years ago. The person who has come and replaced me now, is he more handsome than me?
No. So I think you tell the same thing but in a different way.
Well,
if you look at even in house, in a home, how parents talk to their kids now and how they used to talk to us when we were kids, that has changed. They're conveying the same thing. So I think it's the mannerism and how you try to be not little more gentle and not appear so rough. And of course the other thing is that people are not as grounded as they used to be. So I think that starts from childhood. There are a lot of more people have more insecurities. People take things too hard. People have breakdowns, nervous breakdowns, which, I would just, that very rarely it used to happen. Maybe 1 out of 100 person would have a nervous breakdown. I think now maybe 1 out of 10 people would have a nervous breakdown, or they would really become dysfunctional just because someone really took them to task. So I think you have to realize that times have changed. We cannot be what we used to be. You have to be gentle and sensitive. At the same time, you cannot allow a medical doctor. So medical doctors have one major responsibility: welfare of others. Primum non nocere.
Yes.
First, do no harm. Any medical doctor, whosoever is, if you feel that doctor is possibly harming or actually harming someone, you have to take them to task. That is very important. Whether that is, of course, how you do it depends upon the times that you are living in and how you are doing it. So I think students and trainees, they are trainees. You don't use them as a pair of hands, but you make sure that they are not harming now and not harming in future. At the end of it, we will also be treated by our, at some point of time.
Yes.
So
students will teach us.
Yeah.
Yes. So how do you feel from this side? Many of your students, as the teacher put it from his perspective, what is your expectation from a teacher of today? Anyone can come, I will ask them to stop the recording. You can abuse him. Yeah. Please come ahead. Come ahead. He's not going to be an examiner. Nobody. Come on.
See, one more. With my medical student, I'm very strict. With my PhD student, if they are not doing right, they are messing their own life. It doesn't matter. They are not harming anyone else. Whereas a medical trainee, they are actually harming others, and that is very serious. It cannot happen. I can't have blood on my hand. Seeing that this person is not getting trained and over a course of next 10, 20, 30 years will harm so many people. So I think that's my responsibility.
Great.
Absolutely.
Yes.
Being knowledgeable,
absolutely,
being skilled is a responsibility. It's not a choice.
It's not a choice.
For us, it's not a choice. So
yes.
So you have to train yourself irrespective of the means, through teachers, through everything else. So
I was a resident in medical oncology at Basau Tarkam Indo-American.
God bless you.
So I finished 6 years back. So during these 3 years, it was very vigorous. Our training was very vigorous. And T.S. Rao sir was our boss. He himself used to come at 7 o'clock in the morning. Dr. Senthil used to come at 7:30 in the morning. All academics used to happen. Work used to finish at 7. So initially we used to feel that it was like hell, working so much. They were so strict. particular proper lectures. Even students used to come from TMH and other places to attend our lectures. Other DNB residents used to come and attend our lectures. So it was excellent at that time. But we used to feel that it's hell over here. But then when I immediately, I'll come to that. Okay. So when I immediately finished and I started my, it was COVID time. So I have to shift, my parents still live in Hyderabad. I have to shift from Hyderabad to Raipur. So it was nowhere. I was not linked to Chhattisgarh in anywhere, not even a single relative. Only my wife was there. Even before passing my medical oncology practicals, because it was delayed. So I joined a hospital. It was just adjacent to my home where my wife was living. But then from the first day, first patient I saw, I was so confident to handle that case. And within 3 months, I decided that I have to settle back in this place itself, Raipur. And it's been 6 years now. But then only one thing helps. So whenever I fall into any trouble, I remember my tumor board days. So this case, how was the approach, how they dealt with. And the similar, it helps. So your journey as a resident is very, very important in shaping your career no matter where you are. So that's what I have learned. Absolutely. So your teachers have to be very rigorous, very strict, and then you will love them throughout your life. Those 3 years, you may not love them, but throughout your life, so you excel. Then you realize that every day you will love them. So that's what is my personal opinion.
It resonates so much with me. You know, every abuse, I think you did a clap. You did a clap. Every abuse. Honestly, I didn't know he was suffering so much. He give a hint of it then. Every scolding that you get from your teacher shapes you who you are. And in my case, I have strong memory. I often don't, I forgive, but I don't forget. So, and Ravi, I think we are so proud of him. He's one of the most successful practitioners. And he's so intense and so rich, he doesn't need a second income. Wonderful. He is very successful. No second income. I remember, I tell this to certain so many times. My people know here all the time. I tell this so many times. Once, the first rain of Bombay for me, I never knew. It was raining, and suddenly the department was empty because it's raining. Everyone ran. And I was quietly entering those data into the Foxtrend data entering, and finished my data entry peacefully. Went to the railway station, Parel railway station, it was completely flooded. Long story short, by the time I hitched a bike here, hitched a ride here, on the back of a truck and everything, it was 12:30 at night. And the next day I came, a little late for the rounds. And he asked me, why are you late? So I give this beautiful description of how I changed my trucks and then buses and autos and everything. And then he said, yeah, that was yesterday. Why are you late today? So I will always remember this. Always. It means so much to me that many of the things that I do now is, determined by what I heard from him that day. There are more abuses, I will tell you. This is my chance. Now I have got the mic. And this is so vital that it is very important for many of
public hospitals, busy hospitals have to have that military discipline.
Yes, absolutely.
Things will just collapse. Or they are sustained with a very thin, edge. Yes. If things just go, it will collapse. You won't even realize.
Absolutely. So now you know I get so mad sometimes when I think small things failing is him. That is a PTSD. Yeah, correct. Rajiv, you use the word military discipline. Yeah. I really insist on that. Especially in very high volume hospitals. Yeah. But otherwise, the dilution can actually kill patients. I think if I have any complaints against current generation, all my parents have complained against me, so it's fair for me to have complaints against my next generation, is that they accept dilution. That is not acceptable. The world is a hard place. The world is a very, very hard, uncompromising place. And if you accept dilution, if you relax your anal sphincter, someone is going to take you from there. So please be very tight-assed person. You have to be very, very, should I say, battle-ready all the time, without which you will suffer. And this level of teaching made most of us very battle-ready. But I don't know whether the next generation, we are becoming battle-ready. I don't know. I come from very poor circumstances.
To tell the circumstances right now, but the last 15 years. So based on that, probably you were, kind of looking into a different perspective, like battle ready and all. So, for example, if you take me or Nandita, we have not seen the hardships as to what you have seen in the last 1.5 decade. So now I am asking you. So what do you think about that? Battle has hardened you, probably.
So battle will harden everybody. By the time you are in my age, you will also be hardened.
No, but we have not seen those kind of hardships what you faced.
I have. What is the hardship?
That is because
I cannot define that in public, but just I'm just.
You can go ahead. I will turn my back. I will not. I will not.
You know what I mean, but yeah.
Which means he is not training you well, actually.
Yeah.
Yeah.
We didn't have any problem.
You have anything to say?
No, I always thought when you are discussing a trainee per se, somebody who is a resident, the entry into a particular, whether it is MD radiation oncology or ENB radiation oncology, the entrance should be tough. The journey has to be extremely tough, and then the exit has to be easy. This is something that I followed as an examiner. Once my name is announced, people know all of them will pass. It's very, very difficult to fail, but very difficult to pass through those 3 years with me. So become my student in examiner, but not during the training. If you are a mama's boy or girl, don't become my student during those 3 years.
That's rightly said, sir. But the hardships are common even when you were training or when we were training, when I am training my students. But the type of hardships are different probably. So because now the students face, somebody was speaking about saturation and everything. So when I joined in 2006 and 2007, then some senior radiation oncologists sat and told me that the branch is saturated.
Yes.
This was back in 2006 and 7.
Yes. Every time you hear the same.
So every time you hear the same, as Kaushik rightly said, think about cardiologists, gastroenterologists and neurologists.
Yes. Yes.
So we are still in cities only. All the oncologists, at least I can say, we are still in two-tier cities. So as a being a student, probably I was the only person in NIMS who has been shouted at, probably mostly by our late professor Dr. Esuri Ratnam Garu. So after that, I don't think he shouted at anybody.
He was so tired.
I know your next batch, so I know that. Now tell me one thing here.
Yeah.
Once you pass out, what is your preferred choice of job description? Do you want to be in an institute? Do you want to be in a government hospital? Say if I have to give the examples of, say, M&J Cancer Hospital, Indo-American, which is Trust Hospital, NIMS,
Indo-American,
Apollo, AIG. What kind of hospital is your preferred?
So
you are already in a job. Doesn't have a job.
No, that depends. Actually, the residents now who are doing the studies, they have more clarity about their future than what we had.
So give somebody's younger person. There's no young person in this crowd, or they're pretending not to be young because they don't want to answer this. Yeah, he's the fresh one. Yes, he used to be resident just few days ago, so I will take his word for it.
Yeah, I don't think the clarity thing has changed. Everyone is still exploring. People they don't know whether they want to go abroad, they want to stay in India. It depends on the person's choice. They want to work in a place where they can practice medicine and be happy. I think that's one thing which remains stable among everyone, is what I would like to say. Yeah, it is difficult finding a job, especially a job you like, and finding something you like is something which is very important, but it is challenging. That's what I would say.
I mean, that is the truth everywhere. What I mean to say is that every time also, 5 years back, 10 years back, when I got my degree, it was several months before I got a job, and that stays true here now. What I'm trying to tell you is that what determines, when you want to go for a government job, there are certain variables. Those variables that attract you, or you go to a private job, there are certain different variables. Are those variables that attract you? What is your preferred thing? What does a young person think today? Anybody? There are no young persons in there, so nobody's taking it up.
I'm the youngest with the mic, I guess.
Yeah.
So
I
think the two biggest takes, or what do you say? I keep telling to everybody, the two biggest threats for mental peace among not only surgeons, medical oncologists, radiation oncologists, clinicians, is the fear of missing out, FOMO, and YOLO. You live only once. So when you see somebody else on social media doing something, or somebody is going to a conference, giving a talk, somebody is going, parachuting, or somebody is doing some surgery, or somebody is doing thing. And the second thing is, you think you live only once, so you have to do the time scales which were there at your generation, where you used to go for 3 years, 4 years, do some residency, get your training, and then come out into the outside world. That has been shortened. 5 years for you in Tata. So the people are losing patience. The younger generation are losing patience. The reason is they say, "Itna to ragda hai, we will not do." When do we start our earning? Or then we see somebody else, your colleague who has gone out and is earning.
Colleagues.
Your colleagues have gone out, you're earning that, and he comes in a new car and you are still in your.
Deloitte.
So that is the thing. So I think that is the two things which are causing the mental unhappiness.
My biggest source of unhappiness in life is Deloitte. Every day they are the ones who block my road, so I have to curse them when I cross this and come to the department. Second thing is that why reason is that IT guys who start earning at the age of 25, 23, and we start comparing. But that has been the case all the time. I don't think that's such a different thing that has changed. You tell me one thing. You think, why do you, when I passed out, I thought that I need more training. But when you say that somebody is willing to pass out and immediately join a job, you think you're getting trained better, that you need additional training? How many of you feel that there is a need for training after you have done your MCH or DM or MD? Or you think you need a training? How many of you think that you don't need a training? You don't need a training. You don't need it. What job are you doing now? Huh? So you're training already. That's self-contradiction. Who doesn't need a residency program?
So again, good evening everyone. I'm Dr. Manish. I'm a senior resident at AIIMS BB Nagar. So the point that I was trying to make is there's a lot of variability in radiation oncology programs across the country. So somebody might have been trained in Cobalt. Somebody might have the privilege of starting with Linux from day one itself. So somebody who's already trained for Linux.
Fair. So I get your point, and you have possibly helped me in coming to the next question that I had in my mind. What do you do about the variability of training programs in our country?
No, I think coming to your question, what do you want to do? There are two things. One is the peer pressure, other is role models. Okay, so the peer pressure is increasing from within the family. Your cousins who are 24-year-old have already got a job, all those things, and your friends, and the role models are disappearing. Okay, I think that's the very bad thing. When I was a little kid, the best doctors in that town, I grew up in Lucknow, were professors in medical college, KGMC, whether a pathologist, pediatrician, chest, they were all professors of medical college. Today, if someone tells you, if I had in that mindset, I would have wanted to join the medical college. Today, anyone who's good and bright, if you tell them, would you join medical college, they will look at you like this. Okay, so those role models disappeared. After that, there were role models of very good doctors, very flourishing doctors, good practice in some good hospitals. So gradually, they are also, and they are not connected so much with the students. So the doctors who are actually connected with students, they are, not that many good. So vanishing role models. Good. That is one issue, I think, that which is a, elephant in the room, and how to.
Yes. If you bring an analogy to sports and medical profession, if you have the physical director who is a hockey player, you will have a hockey team which will beat the rest of the state. So it's like that. So teacher has much more influence when you are tender, when you are young, and this keeps coming down as you actually age. So the responsibility to continue to be a teacher, even if you are earning less, is something that we need to think about. Is it not?
This is a very complex. This is a very complex, and let me see if I can pare down this question. Now, there are two questions here. One is doctor a role model anymore? And if not, who is your role model? What it takes to be a role model? I will ask this question possibly to Chinna, because he is different amongst us, because he wears a lot of different hats. So, and you have a very strong entity as a social service person. Massive, I don't know if you know, he's Guinness Book of World Record holder in doing certain things he does, scale of which is massive. Do you think an identity beyond being a doctor is necessary to be a role model and be a different person in the society? What's your thought?
I think a very difficult question, but I think the question, answer is there in the question itself.
That's why I've called you here.
Yeah, thank you. No, the answer is there in the question itself. The identity is the most important thing, right? So to be able to know who you are, I think that's the most fundamental thing that we all need to answer. So being a doctor is not your identity. Being a cancer surgeon is not my identity. I'm beyond that. I think that's where you find the purpose and you have a calling in your life. See, there are so many identity thieves in this world, I say. 4 S's I always say, spontaneously I'm recollecting. Status is identity thief. Stability is identity thief. Right? And then, there's something called as success is also identity thief. Your success is just a byproduct of who you are. Right? So in that sense, we need to kind of understand and know who you are exactly. The true identity of your calling in this world. Being a doctor is just a part of the whole calling. It is not the entire thing. That's what I feel.
Any one of you have different identities? Dr. Jekyll and Mr. Hyde? Bear your teeth, your sharp fangs? Nobody?
Multiple good identities.
Multiple good identities, yes, why not?
Why not?
Why not? Anybody has got, a strong identity beyond being a doctor? Or am I talking to a very mono? Yes, please go ahead. Let us hear from you, please. Please come. Take the mic.
One question to Rao sir also. Sir moved from a government hospital to a private hospital. So how was his journey? And about the identity, sir. So I'm practicing orthopedic oncology and we are having a good number of patents, nearly 10 patents. So we are working on a bone biopsy gun with 2 engineers. So I want to develop that product so that can be identity. Ultimately it will serve the society. So just restricting to orthopedic oncology or any branch is not a good idea, what like Chinna Babu sir said. So you should have something what inspires you or gives some thrill or kick. So we thought that we will make some implants, some joints, some products. So you can have multiple identities. So definitely.
Kaushik, can I just share a small story on this? A journalist was asking a question for everybody who was exiting John F. Kennedy Airport. The question was, what is the most disgusting thing in this world? People said, Ukraine war, racism, different answers they gave. Finally, a monk comes out and he was asked this question. He looks at him and says, who are you? He says, I'm Mr. James. Then he said, I didn't ask your name. He says, I'm Mr. James working for BBC. I didn't ask which company you work for. He was taken aback. He says, I'm a human being. I didn't ask which species you belong to. That's when he was silent and then he said, that's the answer for your question. The most disgusting thing in this world is not to know who you are. So the identity crisis to be able to know. Thank you.
Great. So there's great anecdote. We can discuss this after a few beers. Clarity after a few beers. So
Abhijit, I think, should be a real role model.
Yes.
Very inspiring. The amount of work he's doing and he's actually a multiplex.
Anybody else who has got such, different things? You must be having, it's not necessary that what you do gives you patents or gives you money, but it could be a very important part of your passion. Anybody else whose passion at certain different things is more powerful than your identity as a doctor? Anyone? I'm one of them, which is why I'm such a bad doctor actually. But yeah. Anybody? Yes? Nobody? You murmured something, right? Forget about me. It's about you now. Anybody else? Well, yes, good. Wonderful photographer. She is a good photographer actually. She's a very good photographer. Anybody else? Yes, please, come. Mike, loud. Huh? Jewelry design, yes, wonderful. Well, it's a very creative line, I know quite a few people who are excellent in that area. It's a wonderful creative line. Jewelry design, and it doesn't take much of your time away. You can run that parallelly and do a good lot of things. Anybody else? And it can be very money making also. Anybody else? Vamshi ran away or what? He's there. Yes, please. So, yes, come.
So, I love driving, sir. And
yes,
that
wonderful. Driving people mad?
No, sir. Driving a car, and I have lots of
cars.
Yes, cars. Yes. Oh. So I have right now 4 cars in my garage.
Oh, so yeah.
And also after doing my job, I used to sing in my house. Used to sing in my house.
Yes. You can sing now. Yes, why not? You have a mic and you have an audience. Please go ahead.
I actually like him that he's confessing that he's got 4 cars.
Yes.
Because I have about 5 cycles.
Oh, great.
But I'm a bit stuck at trying to see which one I can ride at what point of time.
So let him sing. I will come to your cycle sometime.
So I had an accident, sir, while I wasn't doing.
First.
No, I'll tell, sir. So I had an accident while I wasn't working in TMH in DM 2017. Bad road traffic accident, and at that time there was a chance of amputation of my left leg, but somehow I managed to salvage my left leg. So initially my passion was driving a motorcycle, and I planned that I'll buy few Harley Davidsons. But after that accident, the passion shifted to driving a car.
And then sing.
Start a travel agency.
No, sir, no.
Yes.
I don't have any drivers. I drive my car by my own, and these cars are like luxury cars.
Medical oncology, you don't have to explain the luxury part of it. But let us hear the song from you. Yeah, sing the song.
Okay, sir.
Yeah. Anything you sing, it's free for all. Scrubs are off, game is on. So go ahead.
So I can sing a song of Kishore Kumar.
Yes, please.
Okay. So फूलों के रंग से. फूलों के रंग से दिल की कलम से तुझको लिखी रोज पाते मैं सो भी जाऊं तू किस तरह से मुझको है यूं तू सताती तेरे ही सपने लेकर के सोया तेरी ही यादों में जागा तेरे ख्यालों में उलझा रहा मैं जैसे कि माला में धागा बादल बिजली चंदन पानी जैसा अपना प्यार लेना होगा जन्म हमें कई कई बार हो इतना मधुर इतना मधुर तेरा मेरा प्यार लेना होगा जन्म हमें कई कई बार. So singing.
Wonderful. Wonderful.
So singing is काफी stress release होता है.
Yes.
तो at least half an hour तो sing करता.
Oh, wonderful.
Yes, sir. Thank you.
Sir also sings very well. Up.
No, I just want to bring out another point. You know, we're talking of hobbies and passion. Passion is one thing. We use it very lightly. Passion is passion. Okay, it's not just a hobby. It's not a passion. So, you know, sometimes we do not realize there have been years together a person has not felt his or her own creativity. You know, you can feel. And human beings, I think they are hardwired. If we sense that we have not been creative, it sort of depresses us. And then we try to do different things. And sometimes that, you know, leads us to gardening, to painting, or some other things, sometimes to good social cause. So I think even finding your own creativity, even if a small thing, is very important. It is absolutely essential for human mind. I don't know whether it's a soul or not, but at least for human mind to remain stable and to thrive. So that sometimes in the way we work, it is such mundane activities we do, protocolized, everything. These days decision making has also become so protocolized. So you don't have to think for each case. So I think we have to think that absence of creativity, which we'll feel at some point of time, will actually drive us mad, and then we will drive others mad.
Wonderful. This is, I can, please go ahead, sir. Yes.
Wonderful. I think, Kaushik, let me reveal that I was practically a professional sportsman.
I know that.
So I played senior nationals hockey up to
He's a very good hockey player.
87.
National level player.
I used to work out 6 to 7 hours per day. And I was mainly a cricket player before I got into MBBS. I was selected for zonals, which is one step away from Ranji Trophy when I was 17. Azhar was 1 year senior to me. We used to play together. I was unfortunately good at studies. So, and in those days there was no IPL and stuff like that. My father was a Madras Presidency volleyball player. He was 6'1". My mother was short, so I stopped in between. So volleyball was not an option. And then the entrance exam, I hail from a rural place called Miryalguda. So anybody from there would be given Warangal as a place. There I could not continue cricket. Other continued here in Nizam's college, and I went to medical college. And there, the physical director was a NIS Patiala hockey player. So by biochemistry, I played for the university. By pharmacology, I became South Zone Combined Universities captain. And then by pathology, I played senior nationals. And then I had a real major injury to my knee joint. At 43, it became osteoarthritic actually. But because of my muscle power, I just continue. I'm 62 now. So that injury made me a doctor actually. I was 55% aggregate, just qualified to even appear for PGA and AIMS exam. I became a student, so obsessive psychotic disorder is something that I am, I think. So I shifted all that attention onto studies and then became what I became. So passion cannot be continued sometimes, sir. Yes. Because there was not a day, when from third class onwards, not a day when I would not go to ground. When I was next day exam, some people told, are you dropping the exam? So that's how much a sportsman I was. But fate has it as something else. Other is retired, now he's a politician, but I'm continuing in what I love. So I have no regrets now, but it was not easy at all. So.
Great. Anybody has got such personal, anecdotes to share that inspires us about how having an alternative. About the cycling, yes, you're back with the cycling. Tell me about your cycling story, yes. You can start here, come. No, come here. I can't. I'll give it to you.
Abhijit, and I'm here because of Sridhar Dasu, who's a very, very good old friend of mine. I wasn't cycling when I was in MBBS. I think we were having different types of fun that time. And in a godforsaken place called a Scola, where there was probably no water to even clean your butt. So, pedaling part started, I guess, probably when I went to Korea and then Italy for my training. I saw the guys cycling there. I was like, wow, they have a good part of life. They're actually walking, they're cycling to work, they're going everywhere on cycles, they look so good, they look so fit, they're eating healthy. And I was wondering, I did my orthopedics and what am I trying to do, just trying to find some work and doing some fellowships. Came back to Bangalore, bought my cycle paying about 50K. And I stay in Bangalore in a place called as Kengeri or Rajashnagar. I don't know whether people know it or not. I took my cycle out the first day trying to see if I can go to work.
Interrupt you at this point of time. You said you stay in Bangalore, and I know that you cannot drive a car. So
I was coming to that. So see, at least it's safer to be in a car so that even if you run over, you're safe. Some parts of you are still found. I took my cycle out 200 meters and I was shit scared so much that I kept the cycle back and I didn't open it for the next 3 years. And I guess the journey started next when COVID hit. The biggest boon for us. Put my tag on, took my cycle out. I was going everywhere. Everybody was stopping me everywhere in all the nakabandis. I was like, okay, doctor, I'm actually jobless. I'm a surgeon. I'm waiting for patients during COVID. There are no patients. But I'm just literally enjoying Bangalore roads by showing my tag off everywhere with my mask on, helmet on, God knows what over there. I think that was what opened. And I've clocked about 20K kilometers up about in 4 years. It's pretty short compared to my other colleagues. But it's given a different perspective in life for me to understand and think a lot, reflect a lot while riding. It's a different experience. So I'm a biker, so I ride my bikes. I have a few cars of my own, so I really like the person who's collecting luxury cars, which obviously medical oncologists can do. So I'm a bit envious of that. And he sings well too. So that was another part. Then I really found out cycling. So I guess we have a little problem of plenty now to see where we have the time to do what. Sorry, not in a wrong sense, but in a nice way of seeing, probably it's made us understand over the last 15 years, can we find something where we can find ourselves? I guess it's a different way of looking at things with all the madness, with all the stress and surgeries. Cycling has opened up a lot of avenues. Waiting to come down to Hyderabad and cycle also. I heard there are good roads outside the city.
Yes. Cycling tracks are there. There are many.
But that's not too. I ride about 100, 150, 200 kilometers a stretch.
There are many cycling routes are there in Hyderabad.
Oh, yeah, that's there.
They do 100, 200 kilometers stretch.
Yeah, so the people are there who actually ride about 200 kilometers, 300, 400. So there's a big group in Hyderabad also.
Slaloms they call. I think.
Rondoneuring.
Okay, rondoneuring.
Yeah, brevis. So you ride too? That's nice. So in a way, maybe when surgeons are jobless also, they tend to do all these sort of things. And at the same time, when you're too much into your job also, you want to get out of it, so you probably find all sorts of weird avenues, trying to go trek the Himalayas. Couple of my friends and some colleagues have even gone up to the Everest also, the ortho guys in Telangana and Andhra. So a lot of mad things to do, but I think you find yourselves a lot in doing those. That's what my end goal is. I'm trying to find myself. I was something else before, I'm trying to find myself.
Absolutely. So this is very vital, and it resonates with me personally. I used to be a very good painter. You know, till I joined medicine. Yeah, it's not working. So can I have that mic back? Yeah. So when I was a very good painter. I used to paint water paints, watercolors, and oils. Very good oil painter actually. And the passion for painting and the love for painting has made me go all over the world to see the great painters. And I can tell you most of the famous museums where the arts of the Renaissance and the Impressionist art and subsequent modern up to the 1920s, 30s are there. I've been at least to 60-70% of them. But I have been a mute spectator to those arts. They have at one point of time inspired me to paint. But once I joined medicine, like he said that suddenly his game stopped, my painting stopped completely. And today if I miss anything majorly of my life, I go back and think, what is my regret? That I have never painted after that. You know, the last paintings that I did, they're still in my house, you know, oil paints. But I have not painted anywhere. But I have again and again tried to find myself back through other creative means, which these people laugh at actually sometimes. So, but that's there, yes, please.
So I have a small question.
Continue to do dose painting.
Dose painting.
This is the problem. This is the problem of MDTs, you know. They come to the MDT, don't know about dose painting, and there is one guy who knows everything about proton, everything about SBRT. Ban them from the MDTs, I'm telling you.
I'm very scared about non-surgical oncology, so I learn few things from them.
Yes.
It's important to be aware, is it not?
One.
Yes, now everything is bragged. The brag has peaked. Yes. Yes.
So a question for all the three panelists. How would you build the ideal team, or your thoughts on team building and preventing attrition when you're building a department?
Let me sit down.
Because we are all facing this problem. I think most centers were not able to retain talent or even find.
I don't know. See, we started, Sridhar, you know, you were a very important part, and
you left.
It was no, unfortunate that some evil elements poached you from us. I have all the complaints, but still I'll continue to answer their questions. Yeah, correct. Naren? Where are you, Naren? Out of sight, out of mind. Naren also. Correct. Anyway, so now from 4 of us, we have become 58 of us now.
Yeah, wow.
So
that's faster than a rapid.
The secret is, I think, there has to be an element of selflessness as far as the leader is concerned, because when I joined the institute and when the previous director left, I was the only one who had practice actually outside. I was all over Telangana and Andhra, so I used to operate in 200 hospitals in Hyderabad actually. So everywhere I was. Chinna was not there, so after that he took no intense competition by anybody. So I had to share, and it's very important. And anybody who is joining is coming with no patients at all of their own, and many of them are not even from the state. These two are from the state, and they are eminently poachable if they are Telugus. So and none of them have patients, but eventually I'm actually forced to tell the patients that they are so good that they are better than me, and things like that. And I would use, if anybody tells, you have operated on 4 of our relatives, I would tell them, I'm Sunil Gavaskar, now I only tell commentary. He is Virat Kohli, he actually plays. So, and then how to hold them, it's very important to preempt their needs. It's not as if the best ones, the sensitive ones, don't actually reach you for favors. Favors means a hike in salary, or at a better position, or a unit of their own. While you are dividing, we started dividing head and neck, we have divided head and neck breast into 2 already, and every other division. So once they are 5 years into, they want some eminence. They want first name to be theirs. So these are things that that the leaders should understand before they ask, because the best ones don't ask, and the ones who ask are not necessarily the best ones. So as long as you do that, you actually don't lose them. So the most committed have to be held back, and it's important to think more about them than yourself. So to hold them, you should not think that you have a family far away from the hospital. It's important to understand that there is a much bigger family here, because I spend from, as Ravi said, from practically from 7:30 to 10 o'clock in the night, I'm in the hospital. So I'm with all these people who cannot be anything less than a family. So once they become your family, you actually bother about them, you think about them, and then you are concerned, you are anxious about them. Once that happens, I think they'll stay. A few more rupees will not drag or draw them away. There can be other problems which will pull them out, mainly the spouse problem. Spouse is a serious problem. So, so I think the leader has to be selfless. Leadership includes selflessness as a package. Never think that I have struggled so much, I have laid this road, all these boys and girls are racing on racing cars on that. And why should they have such a easy path? Is not something that they should go through. Is it not? You are called a pioneer only because all of them were not actually born along with you. So you have a responsibility like a parent. So the way you visualize the future of your child, you must visualize the future of your colleague, multiple layers of them, and then your residents. So you should be very anxious about their future, their lives, and how useful they are going to be to the society, because you can make or break them. So that's how you develop teams, and that's how a team sustains. It may not be the best looking place, but it's a very warm, comfortable, congenial place for doing what you actually want to do and perform and at complete liberty, dance in joy. So this is, I think, very important.
Absolutely.
I think I can see a similar team here, Kaushik. I'm very, very, very glad to see that, to be very honest.
Thank you, sir. I think those are very important words for, Subbu sir has inspired and mentored many generations, and I am one of those generations, and people of my age who are transitioning from being a resident or junior doctor to slowly into a leadership role. This is something is absolutely vital, and many of you who are young at this point of time, you will go through this inevitable transformation of breaking out of your pupa and spreading your wings. These are absolutely the words, and this is how teams hold on, or this is how teams fail. Having said that, I lost my last team member to a government job. I cannot swallow that pain. Where is he? He's not there? Oh, he's left. Okay, now I can forget him. So, great. Anybody else has got anything on that? How to
I'll just add one thing to that. Sometimes we only look at actions, what that person said or did. We forget that what stage of personal and professional life they are. And if you go back, you'll remember when you were a new consultant or when you were a SR, final year SR, how you used to think and how you used to behave. And that sort of gives us a perspective. So I think, and sometimes, as seniors, we should not react. Just give time. Your own thought process will become clear, and the other person's thought process will also become clear. Sometimes I think not reacting, not speaking, not taking action really helps a lot. It takes a lot of, especially, it happens sometimes you're 10 years, 15 years junior, someone you have trained, he or she comes very aggressive and starts fighting you. At that point of time, if you can control yourself, just remain quiet. The next evening, same day, that person will come back and say, I'm very sorry, I don't know what happened to me. It happens. All of us. बोलते ना उसका कभी-कभी सटक जाता है, कभी-कभी होता है. So that happens, and I think so. And they should feel that sometimes a lot of people, they have pent up things. They wanted to say so many things, but for whatever reason, they thought they cannot tell you that on your face. So I think that kind of impression you create, that you can tell me whatever you want to say. Of course, when they are speaking to someone very senior, they will say it in a different way. You have to read between the lines what they are trying to say. So that is also, that could help.
See, what Helen Keller said, the highest point of leadership is tolerance. So you have to be tolerant because they belong to a different generation. You should not be punitive. You should be tolerant. It's very important to be tolerant. Yes. I think you are tolerating us.
Kaushik, I'll just bring one last point. So sometimes we forget, especially in those in medical profession, the importance of solitude, reflection, and leisure. Leisure is not going on some leisure trip. Yes. You know, that is important. So all our emotions are always free.
He is going on leisure trip every 3 months, sir.
No, that is not a leisure trip. Leisure trip, you are just going somewhere, just sitting there under a tree or on a bench for half an hour, 1 hour. That is leisure, not going on a trip. That is not. So, and the way, especially our medical profession is there, weekends are messed up with these conferences. Weekdays, the whole day we are there, you know. And, you know, in India, in the West, they never have a conference on a weekend.
Yes.
They only have during a work day. So I think that has, and we do not realize how it is affecting us.
You know why that happens? Because the residents, they don't get a leave on a working day to come and attend the meeting.
Yeah, that is, so you have to do that. So you don't have time to reflect. Even if you get half an hour, 1 hour in a week to reflect, okay, what is happening, or just being blank, just sitting there, not thinking whatever comes to your mind. We don't understand that deficiency, you call it deficiency of this vitamin, deficiency of that, the deficiency of reflection, of solitude, of leisure is huge without us realizing.
Great. So no more working from morning 7 o'clock till working till 9 o'clock at night. Sir.
No, it all depends. See, now, I think that'll bring another important topic. When you say work-life balance, I would contradict it. You said I have strong opinions. I would contradict this terminology itself.
Yes, okay.
As if work is not life.
Yes.
You are bringing work versus life, which is very wrong. Work itself is life, and that's what at least I aim to do, and I think I'm born for. So work life and family life is a better way of putting it, and nobody can balance it 50 on this side and 50 on that side. So it all depends on what you occupy. See, now in my position, if I am a very big family man, I have to spend quality time with my children and wife and mother. It's important. But if you want equal quantity, it doesn't happen, is it not? So you are actually supporting so many other families. 2,000 employees work for us, and unless I stretch myself, I cannot actually run this hospital and continue to see that it continues to evolve, change machines every 10 years. It doesn't happen. So there is a commitment to the society. In Hindu mythology, what is said is, in the 3rd month when you are named, you don't belong to your family actually. I don't know if you all know or not. The naming is done in the 3rd month, not within utero, like the West. And then the child is not born. They say Alice is dead already. So before birth. We do it in the 3rd month because that neonatal mortality is excluded. And when you name, you belong to the society. In the villages, maternal mortality was so high. If the mother dies, the village would look after the child. And when the child grows and becomes somebody like Kaushik, he has to look after the village. So you belong to the society. And that is something that is a part of our mythology. That is the greatness of this land. That should not be forgotten in the name of expanding and glorifying family life, and you keep on staying for hours together with your wife and talking, you will eventually fight. So how much can you talk to one person actually? So
yes. You have to meet me on Monday. Keep that in mind.
So when was the last time you went on a holiday with your family?
I don't know. No. See, I go to other countries about 6 times a year, and spend a few more days as a holiday. To be honest, everything is professional trip interlaced with a holiday. I'm on a holiday every day actually.
You go on holidays? What is your holiday pattern like?
I mean, I just have a break whenever I have a blast, I have a party, or go for a trek, or go for a swim whenever you get time.
Sir, can
So
you
you have
repeat
to
that?
steal.
Can you repeat that?
I go to a fireside chat and that is the holiday.
So his
So you have to steal moments.
His parties are legendary, actually.
Yeah.
We'll dance a little bit?
Of course.
Yes, of course. So, who else got a nice anecdote about holidays? We're on holidays. Who has got a nice something special about a place or some unusual place you have gone to, or yes, Vamshi, please.
No, I'm just saying because nobody else wants to talk, but
Yeah.
it's always nice.
He's mostly on holidays.
Yeah, true.
Serial
holiday
holiday.
person. So, sir, I don't completely agree. I think if I don't take a holiday once in 3-4 months and get out of a lot of stress, then I will not be able to focus more. So that's why I want a break. Yes, my teammates are laughing because
Every time you go on a holiday,
I
the
dump
stress is
all
on
the
them.
stress on them and go.
It depends. It depends. It depends.
So, again, leading on to this, sometimes it's good to have an interest and then follow it up. So for me, this happened this year when I went to Berlin. The reason being that since my childhood, I was always interested in the World War II history, how World War II has shaped the entire history of last 80 years. So for me, when I went there and I visited those places in Berlin, which are associated with World War II,
Can you
it was
tell
kind
here
of...
in the public who made your holiday trips plans?
Yes, definitely somebody helped me plan some things and told me with what not to miss and what to do. And that is the person standing on stage.
Good, thank you.
So self-praise from him. But the point being, it was something I liked. I was looking forward to it and I'm happy I did it. My family didn't come with me because they don't like World War II. Let me be very honest. So I took them some other place. We went to a beach vacation later. So I think again, sir, to answer your question, I think everybody has a different idea of work-life balance, and I kind of agree with Sujana that we should not say that work-life balance should not exist. At the same time, you should not focus on that at the exclusion of your work. But there has to be some work-life balance, and if somebody comes, I will work 30 days very well, and 5 days I want off, I guess that's their plan and it's good. As long as you don't shirk off work when you're supposed to do work, I am okay with that. And again, going back to what we all talked about, how we did our residency. I honestly, if someone comes and tells me I will not work 46 hours continuous like you used to do, I will not fault them. I mean, I agree it made a lot of difference in my life, but if somebody says I'll work only 24 hours, I think I will accept that.
Vinith?
Vinith is not here. Yeah, he already left.
He has got his work-life balance perfectly sorted out.
He's balancing.
Fully balanced.
So again, that's just my take, and I think what the message to everybody should go is you have these thoughts sometimes. I think I like the idea what Dr. Sareen said, that an hour of reflection, and it could be just that you wake up at 6:30 one day when the rest of your family is asleep.
Yeah.
Sit for half an hour.
Open the fridge and eat something that day when nobody's going to judge on.
So just sit for half an hour wherever in your room, just lie down, think. And that makes a difference because it gives you a perspective. And like Sir says, perspective is important. Again, I think we sound old when people start talking like this. I don't think at 29 I spoke like this. At 29, my whole idea was, okay, can I sleep 10 minutes more before starting rounds, or should I go rounds, or which patient is sick?
Great.
I would not want that life on everybody. I think it's important.
What excites Vamshi will not excite me. It's
Absolutely,
very important.
sir. I enjoy reading books. I read a very nice book. I find it interesting. Again, in nice is only science fiction. It is not deep philosophical books. I am not a very that deep a person.
Yes, please.
Good evening, all. My mentor and my senior guide, Dr. Subramanian Rasa, is there. I am Dr. Sompalli Sri Ramakrishna. I am medical oncologist. I am 65 years old.
Yeah.
Every day is a holiday for me.
Oh, wonderful.
He doesn't work in the hospital. He just comes.
Since 1970.
He's a visitor.
Since 1970, as a student of OMC Young Men Christian Association in 6th class, from morning 4 o'clock to morning 8 o'clock, it is my holiday. It is my personal time. Wherever you go to enjoy in the world, there are only 5 things. Bhumi, Akasamu, Niru, Vayu, Agni.
Oh.
These are there in our body itself. If you close your eyes and sit calmly and decreasing our thoughts, for a day, everyone will have in and around 24,600 thoughts. If you decrease our thoughts and sit calmly by closing our eyes and concentrating any point in our body, it is called meditation. It will give more relief than anything else in the world. And if you run or briskly walk for 45 minutes a day, if you play shuttle, tennis, swimming, cycling, anything, it will give more pleasure than visiting and waiting hours together in the airports is itself is a stress factor. So in myself, work hard, enjoy the work, counsel the patient in his family members by with smile and give good care. It is itself, it gives more enjoyment and more enthusiasm than holidays itself, in my opinion.
Wonderful. I think this resonates. And I will just share one thing with you, because you talked about holidays, you talked about World War II, you talked about reflection, and you talked about, visiting some place. I will just share one personal anecdote. I'm also a big fan of history and World War II in particular. And many of my holidays actually designed by exploring different aspects of the World War II, because it is possibly the biggest folly in our known human history. Of course, Trump is going to change that, supersede that possibly. That's a different thing altogether. Then I went to one such place. It's called Normandy. Anyone is familiar with the Normandy? Yes, exactly. So that's the place where thousands and thousands of Allied soldiers died when they landed on the northern beaches of France to liberate Germany from all of Europe from the Nazis. And the day I went there, it was early April. It was very, very bad weather. It was drizzling, it was rainy, it was about -3, -4 temperature. And the vast sea, and there was nobody there. I mean, absolutely nobody on that beach. It was in the morning time. I stood there. I took my shoes off and stood there, barefoot, about ankle deep in the soft sand. And I reflected upon the lives that were lost. Those lives possibly mean nothing to me, because I'm neither a French, nor a German, nor a British. None of the Canadians who lost their lives, but they were human beings. And for a moment, I felt very spiritual. And, people are laughing. I got you spiritual. So it was a spiritual moment. There are very few moments when I felt like that, where human beings are capable of doing the best of things and the worst of things. And that was one place where that drama played out so beautifully, so violently, so virulently, so much of blood and life, and so much of heroism. People who are laying down their lives for people who they don't even know, for the life, the price they paid for freedom and liberty, which was merely a notion or sometimes just a salary that they're working for. We don't know. But they lost their lives. And how those young people of their 20s, they lost. Maybe there are many ways of seeing a movie about the place and all that. But the intensity of the place is possibly my highest point in traveling any place. And all of us travel for those moments. The second thing I want to tell you is dinner is ready. Dinner is ready. Good. Thank you very much.
Thank you. Good. Anyway, nice meeting both of you. हम लोग का 3 लोग का फोटो ले लो.